Doctors' Day. And
Yes.
thank you very, very much where intervention has reached and Anand has shown.
My staff has, we all come here from 6:30 in the morning.
It's a fantastic job,
6:30.
Anand, and please give a very big hand to Anand and to your team as well, Anand. So
Yes,
thank you
yes,
very
yes,
much.
absolutely
And we'll be
fantastic.
hoping to see you in Hyderabad very soon. Thank you very, very much.
Sure, thank you.
So, thanks a lot for all the participants and also all the moderators who are here and panelists as well. I think this session will be closed here now. Thank you.
So, good morning, ladies and gentlemen. After an exciting session of some 2 cases from Delhi and Mumbai, we are back to interventional management of hypertension, and this will be chaired by Dr. P. Krishnan Raju. Dr. Raju, please. Monu Verma, Dilip Ratnani, Dr. Devobrato Roy, Dr. K.K. Shetty, Kondal Rao Ji, P.V. Ramachandra Raju. So please come. I can see all of you, sir. Dr. Shetty, please take your seat. Good morning, sir. And moderated by Prashant Bhopati, Dr. Sanjay Chug, Dr. Nitin Kabra, Dr. Ankur Gupta, Rajneesh Jain, Parijat Dev Chaudhary, Vitul Kumar Gupta. And the panelists are G. Shurjo Prakash, N. Ramakumari, Gajinder Goel, and Girish Kolambe. So the first speaker is Dr. Krishnamurthy KM for coarctation of aorta intervention. So I hand over the session to our learned chairperson to conduct the session.
Good morning and welcome you all. You know, hypertension is one of the most common diseases in medical history, and because it kills a lot of people. However, it is very badly managed, both in developed as well as developing countries. Only about 50% are adequately controlled to reach their target level of BPs. The prevalence of resistant hypertension is around 17%. Today we have a few speakers who will talk on interventional management of hypertension. I will request Dr. Krishnamurthy to talk on coarctation of aorta interventions. Over to Dr. Krishnamurthy.
Good morning, chairpersons, friends and colleagues. I'll cover interventions in coarctation in the context of hypertension in the next few minutes. The mechanism of hypertension is multifactorial in coarctation. They range from abnormalities of the aortic wall, including abnormalities in the microarchitecture, even growth factors, and residual gradients following surgical or interventional repair, alterations in the renin-angiotensin mechanism and resetting of the baroreceptors, and because of the presence of prosthetic non-aortic tissue, either stent or grafts following surgery, the compliance is reduced. All these contribute to hypertension. And this is the flow chart showing the various mechanisms, which means it is highly complex. So the long-term complications in a coarctation are either after surgery or intervention or untreated, and they range from local complications, and after procedures there can be aneurysm, dissection, rupture, and in the associated bicuspid valve they can have stenosis or regurgitation. The left ventricle can fail, systolic or diastolic dysfunction, they can have sudden death, and coronaries and other peripheral vasculature like cerebral can have problems. And as been mentioned, natural history is very poor. Median survival is only up to 3 decades, and by the 5th decade, 90% of the untreated coarctation patients are no more. Majority of the causes of death are cardiac. Indications for treatment have been evolving, and it is generally presumed that a non-invasive pressure gradient between the upper and lower limb of 20 or above, or a peak-to-peak gradient of 20 or above, or in the presence of radiological evidence of coarctation with significant collaterals, even with a reduced gradient, abnormal response to exercise in terms of blood pressure, significant LVH with hypertension, even if the gradient is low. These are indications. And the ESC has come up with guidelines. Those who have hypertensive patients with native or recoarctation and gradient of more than 20 in invasive pressure monitoring, they are class 1. Those who have hypertension with more than 50% of the narrowing either by CT or angiogram with a peak to gradient less than 20 are class 2A. Class 2A is again normotensive with a gradient of more than 20. A lesser category of class 2B is those who are normotensive but lesser gradient. The American Heart Association criteria are also almost similar. They also add a decreased LV systolic function or any presence of significant AR. The management is surgical, balloon or stenting, and the decision depends primarily on the age of the patient and the morphology or the anatomy. In neonates and infants, we can have critical coarctation who are hypotensive and in shock, not hypertensive, and they preferred surgery. Surgery is also preferable in children, but balloon angioplasty is acceptable and stenting is upcoming with limited data. Adolescents and adults, stenting is preferable. And this is the flow chart showing the various modalities in terms of the age and the nature of the coarctation. Balloon dilatation tears the media, the intima and the adjacent media, but its drawbacks is because of the same, it produces a recoil of the vessel and stenosis and also dissection aneurysm. The underlying fibrosis, as we mentioned, which predisposes to dissection and even rupture. These patients have sometimes cystic medial necrosis, and adults will have calcification, which are dangerous for simple balloon dilatation. This is an example of a balloon dilatation. And this baby, newborn, with critical coarctation, and because the arterial puncture was considered dangerous because of the injury, it was crossed through a PFO, and antegrade balloon dilatation was done for the coarctation. The technical aspects include 2 to 3 times, but not more than the diameter of the coarctation, and it should not be more than the DTA at the diaphragm. Graded multiple short inflations are to be given with low pressure inflation. Immediate results are good, but restenosis occurs in about 1/3 of the patients. The younger the patient, higher the pre-dilatation gradient, and patients with a recurrent coarctation develop restenosis faster. Aneurysms occur in some patients, and mechanism is because of the use of large balloons, longer inflation times, and because of the inherent abnormality of the aortic valve. So stenting has come up in a big way. It produces radial support to the vessel, reducing the velocity recoil, reducing aneurysm formation and aortic wall dissection. Stents are indicated. The hemodynamic indication remains similar as has been mentioned earlier, but the anatomical indications are long segment, associated hypoplasia of the isthmus, tortuosity, and recurrence along with aneurysm. These are indications for stent placement. Contraindications are a small child and those who are particularly small to receive a stent, which can be expected to adult size. Advantages of stenting, as we mentioned, as recoil and restenosis are prevented, aneurysm is less. The disadvantage is that reduced compliance and persistent hypertension because of the presence of a prosthetic material. These are the various stents available: closed cell, open cell, hybrid, and in India, Make in India, Zypher stent has also come up. These are the various dimensions available for the stents. Bare metal stents, stainless steel stents, open cell design, Mega, LD, these are all available. CP stent is also popular, but it is very costly. Andra stent is also there. It is a hybrid open cell, hybrid open closed cell. The procedure for stenting includes general anesthesia, various views which profiles the narrowing, passing of an extra stiff wire, placing it in either the subclavian or the ascending aorta. Adequate size balloon is chosen, and a balloon in balloon technique is deployed. Here, an inner shorter balloon will inflate the inner part of the stent first, which will avoid potential complications, and we can, before the expansion of the outer 1 centimeter longer balloon, we can even reposition the stent. This is an example of a native coarctation. We can see the narrowing, the inner balloon, stent is placed, and the inner balloon is now expanded. There is sufficient time and opportunity to reposition the stent now. And now the outer balloon is being expanded. Showing the final result. Procedure success is defined as less than 10 millimeter gradient and improvement in the anatomical diameter. Usually these patients continue to require antihypertensives maybe 1 to 4 months. We'll come to it briefly later. Results show that 98% acute success, complications in about 10% of the patients. Even children have successful procedure with stent. Freedom for reintervention is about 80% over the last 5 years. Weight to the child and a decrease in a smaller stent or predictors of a reintervention. Redilatation or reintervention usually is required when patients do not have proper expansion, either because they are small or because the neointimal proliferation causes restenosis. When there is growth of the patient producing relative restenosis, when there is redilatation, one can go up to 90 to 100% of the diameter. This is an example of a near total interruption where an antegrade and a retrograde access was taken, puncture was made, and with a electrocautery, a snare was used to pass the wire was taken through the snare, balloon was placed, and then a stent was placed, it was inflated. Very complex coarctations like those involving the arch can also be dilated. Complications of stent placement are aneurysms, but less. They usually cause at the edge of the stents. Neointimal proliferation, this is also less than in cases of balloon angioplasty. Aortic rupture and aneurysm formation are also small numbers. Stent migration is a dreaded complication as well as restenosis, but it can be tackled. Stent migration can be proximal as seen here, or while inflating it can be towards the distal aorta as seen in the second picture. Covered stents have come up. They are balloon expandable and self-expandable also come up recently. They are closed cell or open cell design. They tag the intimal flaps of the aortic wall and prevent tearing of the intima and reinforcing of the weakened areas, the preventing aneurysms. Indications are therefore patients who are judged to have high risk of these aortic wall complications, and they are electively in patients with complex anatomy, long segment, tortuous, and those who have restenosis, those who have PDA, and those who have recoactation after a PTFE graft. Patients who have a stent fracture, those who have in-stent thrombus are also candidates for covered stent. Acute or chronic aortic wall injury, those who have aneurysm or dissection, either as during the procedure, it can be a bilateral procedure, or on follow-up, and those who have genetic syndromes like Marfan's or Turner's, and those who are elderly are also candidates for covered stent. Covered stents, a few words to remember are that there is a risk of occlusion of the side branches, and the superiority over bare metal stents have not been proven. And they are not ideal for growing children, but because they cannot be expanded to the full size. Risk of spinal cord injury and also aberrant subclavian artery has to be excluded by CT before a covered stent is planned. The COAST-2 trial, where covered stents were used, showed a reintervention of 21%, and the predictors were smaller children and who have a higher pre-existing gradient. This is an example of a Cook stent which got fractured and a covered stent is placed. Comparison of surgical versus stent versus balloon angioplasty in coactation shows that there is an improvement in systolic blood pressure in all, but stent and surgery are superior in terms of reduction of blood pressure compared to balloon angioplasty. So simple balloon angioplasty has no role to reduce hypertension. This is an interesting study which shows that
Sorry to
whenever
interrupt, Dr. Krishnamurthy, please, can you wind it up? Time is up.
Whenever the incidence of stent failure is more than 39%, the initial cost of stent is better than surgery. They are also useful in children, and covered versus bare metal stents were compared, which shows that those who have only high risk, only there are indications for bare metal stents. The long-term effects of intervention on hypertension shows that those who are smaller, the younger age intervention, they respond better in terms of hypertension. The residual hypertension is present, even LVH is present in spite of drugs in certain patients, and they are usually the older patients. Thank you.
Thank you very much. I think in the interest of the time, I'll now like to invite the next speaker, and if there is time at the end of the session, we'll have some questions. It's my pleasure to invite Dr. George Joseph, who is going to speak on renal artery interventions in hypertension. Renal artery interventions, have come and gone in the past, as George would know, and now recently there has been a resurgence back in handling the renal arteries. And so let's hear what is the current status about renal artery stenosis management.
Thank you, Dr. Talwar. Good morning to all of you. I'll be covering renal artery stenosis. The commonest etiology is atherosclerotic renal artery stenosis. And a recent systematic review of 4 randomized trials of percutaneous intervention in renal artery stenosis compared to medical therapy did not show any significant benefit. The changes in blood pressure were the same, although the number of antihypertensive medications were less in the interventional group. And renal function, heart failure, stroke, etc. did not show difference. And those trials included these very well-known trials, the STAR, the ASTRAL, and the CORAL, and they all showed no benefit over medical treatment. The reasons for this are that the patients selected in these trials largely had moderate hypertension and intermediate grade stenosis. But observational studies have shown that if you take severe hypertension and high-grade stenosis, there is significant blood pressure improvement in these patients. And the other thing was angiographic severity of renal artery stenosis correlates poorly with functional measurements of flow impairment. And what are these functional measurements? There are several of them, but the two most commonly used are the mean resting pressure gradient and the renal fractional flow reserve. And these are some guidelines that are not very recent, put out by SKY and both AHA, ACC, and they are roughly similar. If there is a patient with renal artery stenosis and cardiac disturbance syndromes or recurrent congestive heart failure, then it is appropriate and class 1 indication to do a renal intervention. If there is stage 4 CKD with no other reason for this CKD except renal artery stenosis, or if there is resistant hypertension, that is 3 drugs, including a diuretic, and then it's a class 2A indication. And if there is CKD stage 4 with global ischemia caused by renal artery stenosis, then there is a slight dichotomy. SKY says appropriate, while ACC-HA says 2B indication. So this is a summation of a recent state-of-the-art review. You would do renal artery intervention if there is refractory hypertension or dynamic renal dysfunction that is rapidly progressing, or there is cardiac destabilization syndromes, and then you would do some functional assessment, a resting or a hyperemic gradient more than 20, and FFR less than 0.8. Then you would actually do the procedure. There are some recommendations like the no-touch technique, which I'll come to later. And then if you're not sure of the size of stent to be used, you can actually use Hybiz in the renal artery. So here's what I meant by the no-touch technique. A renal artery stenosis in a patient with very ugly aorta, and if you were to go with a guiding catheter and scrape the aortic wall trying to search for the renal ostium, you would embolize as well as dissect. So the technique is to send a wire up the aorta so that the guiding catheter does not abut the wall. And then when you are in the vicinity of the renal artery, send a wire in, then remove the first wire and then proceed with stenting. Renal arteries can also be recanalized even if completely occluded, if you have a stump that you can see and a distal vessel that may be seen by collateral formation. And you can also do this in patients with significant renal dysfunction using carbon dioxide guided angiography. So the hardware for atherosclerotic renal artery stenosis is basically O14 platform based. And the stents are also not very thick and strong like one would use in larger peripheral vessels. These all typically go through a 6 French system, and stents are definitely better than balloons for renal artery stenosis, as this randomized trial done quite long ago showed. And the primary success rate of stenting is close to 100%, and in-stent restenosis is more frequent in smaller renal arteries. And in these less than 5 millimeters, you have a 20% in-stent restenosis rate. And there is this comparison of bare metal stent versus sirolimus eluting stents in the renal arteries, which showed less restenosis in the sirolimus eluting stent group. Unfortunately, these stents are not commercially available, so we are basically using bare metal stents in our practice. We'll move on to another etiology, which is Takayasu arthritis, which we see fairly frequently in India. We published our results on percutaneous intervention in this disease recently in a series of 1149 patients, of which 942 had interventions. And these patients were young, average age of 30. The female to male ratio was 3.1 to 1. Almost all of them met the clinical criteria, and a large percentage also met the ACR criteria. The types of disease, type 5 was the commonest, about half of them, and we do see type 3 and 4 quite a lot in India, that's 20%. coronary involvement 18%, and pulmonary 19%. So these 942 patients underwent 2450 procedures. Lesions were treated in them, 2.6 lesions per patient, and 3805 procedures. That works out to 1.55 procedures per lesion. And the renals constituted 586 of these 2454 procedures, which is the second most common procedure that we did. And one of the important things we found that was if you do repeated dilatations of restenotic lesions, you get a very good assisted patency rate around 90%. So one of the important things in this disease is to be prepared to redilate if there is restenosis. And we also looked at stents versus balloon angioplasty. If you look at direct stenting, which is basically in aortic lesions, we use big balloon diameters, you have a follow-up outcome of 95% success, and you needed 1.35 interventions per lesion, and that's because we sometimes do a stage dilatation and not because of restenosis. But if you have the lesions which need pre-dilatation, this is the vast majority. Their average balloon diameter was 6, and we had 84% success, and we had to do 1.55 interventions per lesion. Now, if you look at the balloon angioplasty group, where the intention to treat was balloon angioplasty, here the patients or the lesions fell into two groups. One where balloon alone was good, and this group had an 83% success rate and needed 1.2 interventions per lesion. But if balloon result was suboptimal and adjunctive stenting was required, you would get the same result, but you needed 2.1 interventions per lesion. So the elective stenting group, that's the red group there, sort of falls in between these two groups. So there isn't really much difference if you combine the balloon group, both the standalone and adjunctive versus elective stenting. And this, the adjunctive stenting was required more in occlusions, longer lesions. They required bigger balloons and higher pressures. So based on that, we recommend that soft lesions or lesions likely to be soft, first you do balloon angioplasty, and then you would stent if the result is suboptimal. But if you think it's a resistant lesion, then go straight for stenting. And another important thing we found was the covered stents for aorto-osteal lesions do significantly better. The early results are the same, but at follow-up, there is a difference, covered stents doing better than bare metal stents, as evidenced by the number of interventions required. The restenosis was more in the bare metal group compared to the covered group. Now, we found that disease activity that persists at the time of follow-up is related to restenosis. So if you looked at disease activity at the time of intervention, that did not correlate with restenosis. But if you looked at disease activity at follow-up, that is persisting disease activity, that was associated significantly with restenosis. I'll just go quickly through a few cases. All three vessels treated with bare metal stents, but here the disease activity is well controlled, so there's no restenosis. And this is a case where aorta is stenosed and there is bilateral renal artery stenosis. Here we put a wall stent right across, and then through the wall stent we deployed covered stents, and this is that was the follow-up result you saw in the previous angio. Here's a patient, both renal arteries severely narrowed, left is occluded, celiac SMA also stenosed, so left was recanalized, a covered stent put in all four, and this is the follow-up showing all four remaining patent. And these lesions can be extremely resistant. This lesion on the right renal was treated with all those modalities, and finally a conquest balloon at 30 atmospheres did not yield. But what we find is if you bring them back after 6 months or a year, it yields, and we got this result in this patient. So let's look at the renal outcomes. 584 lesions treated, 1/6 were occlusions, 88% were stented, half of them were covered stents, early success 93%, 65% follow-up, and that is about 38 months later, median. And most of this follow-up was angiographic. Outcome at follow-up was 86% success with 1.46 interventions per lesion. Now, I'll also mention another etiology called fibromuscular dysplasia. There are 4 varieties. The commonest is medial fibroplasia, which has this string of pearls appearance. And this particular case is perimedial fibroplasia, where there is extensive collateral formation, and all these can be recanalized, and balloon angioplasty is the recommended treatment. You often get excellent results with just plain balloon angioplasty and good control of hypertension following that. Thank you for your attention.
Thank you, Dr. Joseph. You have extensive experience and obviously the right person to speak on this subject. So, are there any questions in the audience? Currently, how much is the renal artery intervention in management of hypertension? You know, as I said, that it was very popularly done in the past, but most of the patients that are there are atherosclerotic renal vessel disease. When would you recommend that somebody should look up with an aortogram or a selective renal angiogram in a patient with hypertension?
Right. So there are some features in a patient who comes with hypertension that may suggest to you that this is a renal artery stenosis. And one is the extremes of age. So a young patient coming with hypertension, or somebody above the age of 60 developing new onset hypertension, you would think of renal artery stenosis. Then there are these cardiac syndromes like flash pulmonary edema, congestive heart failure, and then there is this fairly rapid decline of renal function, where you would want to evaluate for a renal artery stenosis. And then there are these clinical features. If you may hear a renal bruit, or this patient may have other features like maybe a patient of coarctation of aorta, and then some investigations may show evidence of renal artery stenosis, like the Doppler is a very useful test that one would do to pick up a renal artery stenosis. And of course, if you suspect it, then you would do more definitive tests like a CT angiogram, a MRA, or a conventional angiogram to confirm the diagnosis. And the conventional angiogram can even be combined with the interventional treatment.
Can I have a question, please?
Yes, one question.
I would like to know, is there any role of renin estimation in any evaluation of renal artery stenosis? Split renal function and renin levels.
Okay. Yeah. So split renal function is useful if you have a, let's say, a unilateral renal artery stenosis and that kidney is fairly shrunken. By that they mean the pole-to-pole length less than 7 centimeters. Then it is likely that there is not much function left in that kidney, and revascularization may not achieve much. So doing a split renal function will tell you what is the percentage contribution of that kidney to the total renal function. Typically, unilateral renal artery stenosis, the normal kidney does extra renal function, so there is kind of a skewing, not just a reduction on the disease size, there's an increase on the normal side. And then if you were to relieve that renal artery stenosis, the normal side actually the percentage comes down, and the abnormal side it goes up. So split renal function, if you find it's very low on the disease side, 1 or 2%, less than 4%, then maybe not worth intervening. But if there is very difficult to control hypertension, you may even think of a nephrectomy in some of these cases.
Do we have any data for this side? Do we have any data for drug-coated stents in the renal arteries or drug-coated balloons?
Yeah, I did mention sirolimus eluting stents. There was a trial, the GREAT trial, which showed that the sirolimus eluting stents did better than bare metal stents in terms of restenosis.
Yeah, thank you, sir, for your excellent deliberation. And may I invite the next speaker, Dr. Andrew Sharp, to speak on renal denervation therapy, current approaches. Dr. Sharp.
Because the next speaker is not there, any more questions or any discussions, we can go ahead.
Sir, one question about the antiplatelet regimen that we use in renal artery stenosis for Takayasu arteritis. What is the antiplatelet?
Can we invite the speakers to please come and sit with us so that we can take some more questions from the panel, from the audience, from anybody? Especially for coarctation of aorta, because we did not have much time at that time. So we have a good opportunity now.
Yeah, so if we were to use a bare metal stent, we would typically give a dual antiplatelet therapy only for a month and then a single antiplatelet after that. If we used a covered stent, we would give dual antiplatelet therapy for 3 months and then a single antiplatelet drug after that. I didn't mention that in Takayasu arteritis, it's very, very important to control the disease activity with immunosuppressive drugs in order to get a good outcome of intervention. So intervention should typically not be done in very active disease, and one should try to get the activity down before doing the intervention, but sometimes if the very severe hypertension, you may still have to do it. So our data showed that if you can get the activity down by the time of the follow-up, then you get a good result. Whereas if it's persistently active, even at the time of follow-up, you get a much higher, significantly higher restenosis rate.
Dr. Joseph, how much is the acute or subacute stent thrombosis in these large vessels, the renal arteries? And have you seen any long-term complications? And how many patients actually don't respond in spite of putting a renal stent in terms of their hypertension? Maybe the number of antihypertensive therapies becomes less, but the hypertension continues.
Yeah, that's a very relevant question because in Takayasu arteritis, hypertension is multifactorial, like in even other conditions. But in Takayasu arteritis, the aorta is typically non-compliant. So hypertension may just be because of non-compliant aorta. Then they frequently have aortic stenosis, and that could be suprarenal. The whole descending thoracic aorta can be narrowed, and this narrowing may not look very obvious because it's so diffuse. But if you were to actually check a gradient, you would get a significant gradient. So that is one. And sometimes you can also have renal parenchymal disease in long-standing Takayasu arteritis. And some of our, we have recently done a biopsy and found one patient even had amyloidosis of the kidney. So renal parenchymal disease, aortic non-compliance, aortic stenosis are all other reasons for hypertension. So relieving renal artery stenosis alone may not make the patient normotensive. Like you said, we may be able to reduce the number of drugs, and importantly, we may be able to preserve renal function. So very typical renal artery stenosis is associated with shrunken kidneys in Takayasu arteritis. So they lose a lot of their renal function.
Dr. Joseph, when do you choose covered stent versus drug-eluting stent in renal artery stenosis?
Yes, so I showed our data that in aorto-osteal lesions, that includes the ostium of the superior mesenteric and the celiac artery and the two renals, covered stents have a restenosis rate significantly lower than bare metal stents. And it's something like 26% versus 52%, almost exactly half. So we electively stent with covered stents in Takayasu arthritis. And we don't use those coronary covered stents. We use a peripheral covered stents, which goes on a 035 platform because you need a very high radial strength. And some of these lesions are extremely resistant to dilatation, like I showed that case, where we had to go to 30 or even 40 atmospheres. So that won't work with a coronary covered stent. You need a peripheral covered stent. So we have many of them now, Livestream, Atrium, B-graft, all these are there. So we definitely like to use covered stent for aorto-osteal lesions in Takayasu arthritis.
Dr. Joseph, what about fibromuscular dysplasia? You know, but typically the medial fibroplasia, which is the beaded appearance of the renal arteries. Would you prefer a covered stent in that situation because they have alternate constrictions and dilatations?
Correct. So the beauty of fibromuscular dysplasia is that when you do a balloon dilatation, that vessel seems to normalize. Even the beaded nature seems to regress. And like the case I showed, that vessel looks so much more normal after you dilate it. The thing is that this stenosis may go into the branches. So we have to wire each branch individually and use coronary balloons in the branches and a bigger balloon in the main renal artery. So we don't use stents as far as possible, and we don't use covered stents either. That those beaded appearance doesn't require the covered stent.
It's more because of segmental dilatations rather than local constrictions that the appearance comes on the angiogram.
That's true, but there is
That's
also...
why you don't require so much of stenting there.
Yeah, so there is severe hypertension. In these patients, we had a lady with 5-drug hypertension, and she completely became non-intensive after we just ballooned those stenosis. So those stenosis are important. They do cause hypertension.
I utilize this opportunity to discuss with you other patients of Takayasu arthritis, also, sir, who present to us with so many occlusions. So, do you believe that disease activity per se, which we gauge with CRPs, ESRs, and other things, has a role while we plan for the time of intervention? And so many times when we have treated them appropriately in consult with a rheumatologist with some disease-modifying agents and steroids, they tend to, almost normalize post that period and do not actually require an intervention. So I need to have you've got so much of experience in dealing. Should we wait for the disease activity to settle down and then plan, or should we directly go for intervention in these scenarios?
Yeah, great questions, absolutely relevant to our practice. So, as I said, active disease is best not intervened with. So if you need to do an intervention, get the activity down and then do it. Typically, it may take a few months. Now, if it's something that you can't wait, like heart failure, worsening renal function, cerebral giddiness, you would want to bring the activity down very rapidly. So then we use biologicals. We use tocilizumab, now we are moving to adalimumab. So that those can get the activity down very quickly and then do the intervention. Now, there is this widespread misconception about Takayasu that you don't need to intervene. Okay, all you need to do is give steroids and send the patient home. Nothing could be further from the truth. And these patients are so pathetically, hurt by this policy. So I'll tell you the typical example where the arch is involved. So when the first arch vessel goes, typically left subclavian goes, the pulse is gone in the left hand. She has some claudication. And we'll say, okay, you live with it. It's fine. But if the left vertebral is also gone with that. So same thing may happen in the right arm, one carotid, and still the patient is fine because this disease has excellent collateralization. Okay, and then when the last of these vessels go, the patient will come to you with a stroke or blindness, both of which are irreversible. And then you will say, oh, now it's too late. What's the point in doing an intervention? You already stroked and go home again. So I have a lady in my ward sitting right now, bilaterally blind, and she's been going around hospitals in India where everybody said, just take prednisolone and sit at home. If she had come to us 3 years ago, we could have saved her vision. We could have saved her from a hemiparesis. And we can open all these arch vessels one by one. Same thing goes for the kidneys. Now, one renal artery stenosis, patient has hypertensive, you will say, okay, with a few drugs, the BP is controlled, patient is asymptomatic, why do you want to intervene? If you follow that patient, over time, that kidney loses its function and becomes totally shrunken. And then the next one will start. And then you are in a desperate state. There is, bilateral renal artery disease. Already the creatinine is going up. Now it's actually too late to intervene. So there is a window of opportunity when you see these patients, at which time they may be relatively asymptomatic, and you will say, why intervene? But if you actually follow these patients, they all pay a price for it. And the quality of life is far from optimal.
So once they are asymptomatic, that is the time that we should plan.
Not asymptomatic, once the disease is inactive.
Actually, they tend to become asymptomatic also.
See, because of collaterals, their symptoms may regress, but that doesn't mean the disease has gone away.
Right.
The lesion is still very much there. Right. And then when this is a progressive disease, in India it's very difficult to monitor disease activity in our patients. Some of them come back after years, and then you'll see the disease has progressed so much, and you have lost the chance to have fixed something when the patient did come. So we don't have ideal follow-up where month by month patient is coming, you're going on, looking at the progression, and then when at the right time you will intervene. You have to be very practical. The patients may never come back for a long time.
Thank you, sir.
I know this is anecdotal, but it just, gives strength to what you're saying about intervening in Takayasus. We've recently published a patient who had a very bad renal artery, left renal artery, which could be crossed only by a CTO wire, a UB3 I had used. And I could get away with stenting with a coronary stent because I wanted to use a drug-eluting stent, Takayasus. And now it's 2 years. She came to us with 4 drugs in very severe hypertension, resistant, and she's off all drugs, well controlled. She's on Doppler follow-up. There's been no restenosis so far. Her left subclavian, of course, had gone earlier, but at least we could save that kidney and give her a drug-free period for control of hypertension.
So that's a very fortunate outcome where an intervention was successful with a single intervention, no restenosis, and hypertension normalized. But more typically, there is recurrent restenosis, and you have to be prepared to go back and dilate again. And if you use a covered stent, the chance of restenosis is less. Yeah. Just one more thing. We actually analyzed, we did a lot of drug-eluting stents in small vessels and renal artery stenosis, compared them with bare metal stents, and found no difference. So Takayasu arteritis is a pan-arteritis, and typically the inflammation is mostly in the adventitia. The adventitia is very thick, so it's very unlike the drug will elute and reach the adventitia and reduce the inflammation. So our results show it. There is no difference between bare metal and drug-eluting, but there is a difference between bare metal and covered stent.
Yeah, here I would like to think that my drug-eluting stent did the work. I used an onyx, but whatever it is, maybe she was lucky, we were lucky.
Yeah.
Okay, next question. Thank you. Yes, so we published the 120 cases of Takayasu arteritis, renal artery stenosis. Our result of reverted to normal blood pressure is the 60% cases. You rightly point out, for remaining 40% cases, several mechanisms there, because the constriction of thoracic aorta, abdominal aorta, and distorted arch of the aorta, all the baroreceptors are distorted. So therefore, so many baroreceptor responsible hypertension also. So these are the failure rate of 40% cases. Then another point is, during the activity, you have to do also some cases. I remember at the age of 7 years, girls, repeated convulsion. I did the right carotid total occlusion. So 20 years before we presented our national registry meeting here, so that case is total occlusion, right carotid, I opened it. Though there is Pianka, Sianka, high SR, everything positive. But I have to do it because repeated convulsion. I do by coronary balloon and open it. After 15 years, you see, that is again the restenosis. Then ultimately give the stent. Now, good strain from the originator of the subclavian up to the internal carotid artery is doing well. She even give birth the child. So therefore, I mean to say, during activity stages, we are reluctant to do the intervention, but some cases, if the symptom, you have to do it.
Now, I have just a small comment. Now we have peripheral drug-eluting stents which elute drugs for 1 year. And they, in my initial experience of last 2 years, I have found to be beneficial in improving the restenosis. Peripheral drug-eluting stents which elute the drug for 1 year as compared to 3 months for the coronary stents. Thank you.
Dr. Tyagi, what are your comments about the timing of doing patients with osteoarthritis, since you also have very extensive experience of handling these patients?
Sir, like as Dr. George said, if patient is critically ill, like patient having severe angina, severe heart failure or severe hypertension, then we have to intervene even in the active phase and continue the immunosuppressive treatment on long term. Even we have seen that immunosuppressive may reduce the ESR and CRP, but patient may develop new lesions, thus indicating the activity, and so close follow-up and intervention for any new lesions is required in such cases. Though we would ideally require the patient to be in quiet stage, but patient often come in critically ill, so we have to do interventions in the acute stage. Thank you, sir.
Apart from steroids, is there experience with other immunosuppressive therapies as well?
So nowadays we are using combination immunosuppressives, not only steroids. We start the patient on steroids as well as methotrexate in most of these patients.
Yes.
And reduce the
combination. Steroid combination. After doing the all intervention.
One moment, let him complete. One moment.
So combination immunotherapy, as initially, I think Dr. George will agree with that.
Yeah, absolutely. It's in the guidelines. The EULAR guidelines say that you start with a steroid and a DMARD, that is a disease-modifying anti-rheumatic drug. Yes. And there are many of them. Methotrexate is one. We are very fond of mycophenolate, but there are others, azathioprine and cyclophosphamide and so on. But the issue is that this combination may not always work, and you may need to scale up to a biological. And in fact, the Japanese now believe in going straight away to a biological. They have this TACT study which they show that using tocilizumab up front is a good policy.
Yes, biologicals are useful. We have also used them. But biologicals have to be given intravenously, and patient has to come repeatedly for high-cost injections. So initially we start them on these immunosuppressive agents along with the DMRDs, and then if required, if they do not respond, then we give them biologics.
Biologicals are expensive, but very effective. Yes. So the issue with biologicals is they are dramatic. You give it, and within 3-4 days, the ESR is down to single digits. But there is a thing called rebound. When you stop a biological, the ESR jumps up again. So you got to kind of overlap with a regular conventional DMARD when you are coming off a biological.
Yes.
So thank you, Dr. Panda. Yes, you wanted to say something.
Question about that: how long continue whether it is methotrexate as well as the steroid? I think it should be continued lifelong, because disease process, natural history of the Takayasu arthritis, worsening and waning. When it comes, when it goes, you don't know. Therefore, it is after intervention better to continue the lifelong, even in low dosage. Doesn't matter anything. Thank you very much.
The issue with lifelong immunosuppression is there are risks involved. So we typically start aggressive and very rapidly bring down the immunosuppression and come off the steroid as quickly as possible and just keep the DMRD going. And typically in 6 months, you should be at a very low dose of steroid. We may continue the combination for 2-3 years, but the issue is keep looking at the disease activity. If the activity is flaring up, you got to again scale up your immunosuppression. So as long as activity persists, immunosuppression should persist. But there are a minority of patients who are burnt out, where the activity is gone. And in those, all you need is surveillance. So you keep monitoring them for 2 things: disease activity by ESR CRP and also vascular damage. So they need a periodical imaging. You could do it by MRI because cumulative radiation dose is an issue, and that has to be lifelong. So lifelong surveillance is the key to success in Takayasu arthritis.
Actually, restenosis rate is high. Even we have done the coronary angioplasty cases of Takayasu. 10% of the arthritis involve the coronary artery. See, we observed the more than 50% cases develop the restenosis after doing the coronary angioplasty. So that case is definitely you have to continue the lifelong disease therapy, particularly coronary. This is very important.
Coronaries do the worst among all the lesions in Takayasu arthritis. First of all, because they are small vessels and possibly they behave differently. It's like small renals don't seem to do as badly as the coronary arteries. So coronary artery is a real dilemma. Bypass surgery also does badly. Stents do badly. And sometimes we have to just keep on redilating, and we have tried drug-eluting stents, but we don't have a solution. Maybe some newer technology like ELCA or something might be a way forward.
We have
premature
atherosclerosis.
We have to close this session now.
Premature atherosclerosis may develop in Takayasu arthritis, rheumatoid arthritis, Wegener syndrome, or Takayasu arthritis, premature atherosclerosis. That's what keep in mind.
Absolutely.
So on behalf of everybody, I'd like to thank all these speakers, my colleagues, and especially the audience that very actively participated. And we took advantage of this 20 minutes availability to draw upon experiences of Dr. Joseph and Dr. Tyagi and Dr. Panja and so on. Thank you very much, ladies and gentlemen, and back to the organizers.
Good morning, everyone. This is Ramesh Dagubati. We'll be starting the next session, which is Bifurcation Stenting Live Case Session 2. I'm the chairperson. With me is Dr. Barua here, Dr. Madhu Sridharan, Dr. Sumit Sethi, Dr. Sarvanan, Dr. Rajshekar Varada, Dr. V.K. Bell, thank you, sir, Dr. Eunice Lawyer. I also invite the moderators, Dr. Mriganka Shekhar Chalita, Dr. Kunal Mahajan, Kunal Gurnani, Dr. Manohar Ganeshan, Dr. Nitesh Pansari, Dr. Sajan Narayanan, Dr. Mahabekar Mashadi, thank you. And the panelists Nitin Anarapu, Dinesha B, Dr. A. Jaychandra, Dr. Kinjal Bhatt. So I think we are right on time. We'll start off with a live lightning talk, DES, thin versus thick stents, Dr. Milind Karche. So we're going for live case first? Okay. So change in the topic. Dr. Pratap Kumar is on live. Pratap, Ramesh.
We are ready.
Yes.
Ramesh, can you hear us?
We can hear you loud and clear.
We are actually on live. Can they show us? And if they're okay, then we will. Anuj Kapadia will be. We are actually doing a live from AAG Hospital, Hyderabad, one of the 5-star hotels. The room is looking like a hotel. I was telling today. Even our Akiko was shocked to see such a super hot hospital in this place. So now the presentation will be done by Anuj. Anuj will be.
Hi, sir. Hi, NSI, and hi, Dr. Ramesh. So this is a 44-year-old male, hypertensive diabetic, with a creatinine of 2.2, is EGFR with the mild LV dysfunction. And next, please. So this was his angiogram. So we had a subtotal occlusion, acute occlusion of the OM, which we stented, and this was the LAD with a true bifurcation of the mid LAD with a diagonal disease. And we will take it forward from here. Basically, we stented the LCX a week ago, and we brought him back for zero contrast PCI, I think with the best hands in the country. Dr. Pratap will take over from here. My colleague, Dr. Uday, is along with Dr. Pratap, and we have our whole team here. Sister Kantama and the whole team is around. Thank you so much.
See, Ramesh, actually, we have Dr. Akiko will be interpreting our IVS images today. We have two main images I'm just showing. This is the images not done now, earlier. That is an angiogram done after the intervention by Dr. Anuj and team. That is actually an LED lesion. And can you just go back the image, you go to freeze. Okay, stop, freeze. You have a lesion in the LAD that is exactly after the first diagonal. Diagonal has a significant disease. Diagonal second is okay. So we plan to do a complete zero contrast PCI, and finally, if everybody requests, I may take one shot of contrast and then show you what is done. Our plan is next shot. This is an epicranial shot. Next shot.
Okay.
No, next. There are two shots I am going to focus. Our plan is to put marker wires. We have to first cannulate. I did not do anything. I'm just going for live, and I just wanted to show you. Ramesh, can you make some comments? Because only with the two shots, two angiogram shots, we are going to put wires, and then we'll create a metallic salute. Then followed by, with the help of Akiko, we will be interpret the image and the IVUS, and then tell that how to go about it.
Yeah, so I'll ask Dr. Bell to comment on these two shots, Dr. Bell.
Morning, Pratap.
Yeah.
So what is your plan about that bifurcation?
Bifurcation will be a decay crush is my plan. Now I'm putting the wire up. This is actually, I'm going to cannulate. This totally blind I'm trying to do.
Right.
So now, normally what people actually, I just wanted to show everything live.
No, so before that, anatomically, the left main looks normal, circumflex looks okay, mild diffuse disease. There's a proximal LAD, there's probably about 30-40% disease. The mid LAD appears to be at 70%, and osteal diagonal is 95-99%. So this is my interpretation of the angiogram. I definitely would put an FFR wire or a DFR wire into the LAD, just so that we know exactly on the pullback how much stent do we need to use. And I think, I'm sure you're going to show us a zero contrast, perfect way of performing it, right from the interpretation, right from the actually
so I actually,
cannulating the artery.
Just look at, I thought I cannulated that. If you wanted to see the cannulation, I have only the saline there, just this saline flush. When you put a saline into this one, if you look at the ECG, and the ECG is not very big size, ECG will have some changes. I'm just not, I don't know. ECG, can you look at the ECG? You will have some ECG, ST changes are there. So I personally feel that I cannulated. Now I just take the wire. First wire I'm going to take an field FC wire. Yes. Let me see actually, can you just help me?
So for the audience, the cannulation with saline injection into the left main artery or the right coronary artery will cause repolarization changes. So T waves will be really upright and like almost like an acute MI. Don't worry about it. Patient is not having chest pain.
How often that happens?
Pardon me?
How often that repolarization?
All the time. All the time. You can give saline into the coronary artery. Immediately you will know that T wave changes will happen.
Little up, little up, little. No, image should be similar. No, just go up. Okay. Now actually, can you see both the images?
Movement of the camera also you can make out.
Can you see both the images, Ramesh? One is actually a reference image. I'm going to take the wire down. This is the first wire I'm going to take. The wire I just wanted to take not to the LAD, to the circumflex. Probably I am in the vessel. So now I am planning to take the wire into the circumflex. I have not made a big curve. No, the wire is going into LAD, so I'm okay with that. Now this wire is actually taken by ariocaudal. See, the wire has gone into the ariocaudal. Now I go to the epicranial shot. Can you show the epi here?
Brother, why do you want to wire
just
the
show you how I wire. No, I decided to take the wire into the circumflex because then my everything should be done on the LAD part. So. No, basically it is not like that. I actually, that is what everybody asks. My plan is always I take a field FC wire as a workhorse wire in my hospital for years now. The comfortable wire for me. I put the wire, I probably feel that I am in the first diagonal, that this is the toughest lesion I expected. Now I take the second wire.
Pratap, in these cases, dynamic stent boost by Philips helps?
Field FC wire.
Yes, sir.
So actually it can help us. Basically, how do you take the dynamic wire actually can be helping us. That is one of the way to understand this one. Now I'm going to take the second wire. If I take the wire to the distal LAD is okay, or I will be taking the wire into the circumflex. Circumflex actually is there are three marker wires that are required in this case. The first wire should be in the distal diagonal. That is the second diagonal. Another marker wire should be in the circumflex. And there are two lesions. One is in the LAD, one is in the diagonal first. So there are 4 wires required. People will be worried that how do you put 4 wires? The first wire gone inside. And these are all, now you just, just look at show me the wire. See the wire actually, if you look at this wire and the other wire. Can you show the images only? 2 angiogram images, please. Let them show images of okay. If you look at the wire position is actually, can see that it is in the LAD only, even from the RIO caudal protection. Now I'm going to take the second wire. I'll show you the 4 metallic wires I'm just going to put. I'll create a metallic salute. Then the rest of the work is completely, see, for DK crush demonstration is not my purpose of doing this case. Basically the zero contrast, how to do a proper zero contrast, that is my plan.
Exactly.
Now the second wire going. Can you just come again to epicranial?
Yeah,
this wire actually should go. This wire
Pratap,
is actually again going into the LED.
There's a question regarding the size of the guide, because you need 4 wires, you said. So what size of guide do you put?
7 French I have taken. So the next wire actually, if I am able to take the wire into the diagonal, I'll be happy. But if it is going to the LED, also okay for me. So the next wire gone. I'm checking with that one. I'm not doing anything so far. You just understand that everything is complete zero. And now I'll take the third wire, because I want a marker in the diagonal part. Can I take the third wire? Even if I don't put a wire into the circumflex, it's okay in this case, because Akiko can help me.
I agree. I don't think there's a need for a third wire right now, because there is not much of disease. But if you choose to, I think you can go ahead. And there's a question, Dr. Barua, you were saying something earlier?
Yeah, I was just, in this kind of situation where they don't give contrast, what wire do you prefer, Dr. Pratap?
What?
Any specific wire you should suggest?
No, you can take a BMW wire, you can take a simple, softer wire. But actually, I told you the preference is actually by the operator's choice. Basically, why I take these wires, only to tell you that these wires are comfortable with me, that's all. Epicranial, and show me the diagonal second.
Pratap, again, the D3 is a bit distal, isn't it? Do you really need a third wire? Because, you can, with Hybiz, you can see the length as well.
Madhu, actually, the problem is actually distal wiring is actually, now this is not, probably if you may get out with that, but I'm just telling, this is actually the metallic salute I created. Now, how to identify the wires? Just keep the wires in different place. The second wire, the third wire of diagonal I don't require. That I'll.
So third wire you are putting as a landmark for the distal landmark?
Here, can you just focus on this one? Second marker. Actually, the first marker should be on the this circumflex. That I will do later. Now the work is actually to do the first wire. Actually, I kept on the diagonal one, where I have to see that whether the Hybiz catheter will go or not. Then only I will understand that whether that is a tight disease, which is by angiographically, that is the tightest disease. So I will just take an Hybiz now. Because Akiko was telling the Hybiz will not go there, because Hybiz catheter will be having a difficulty to go there, probably because of the lesion is looking tight. So I'll take the Hybiz now. Let me see the Hybiz can go, but you should actually understand that there is a blood coming out into the catheter. Can you just focus on the this one? You can see some blood. So what I do is, focus on my hand. I just flush in between. So that, I think heparinase, huh? Yes. And in between, these are the most important things. You actually, in between, you flush it, otherwise you create thrombus.
And you're using heparin or Angiomax here? Or bivalirudin, I mean?
No, we actually don't give bivalirudin in India. Basically, earlier people were started using it, especially only in situation bivalirudin is used in HIT. Otherwise, people use always heparin, and keep the heparin in a CTO. You know that we keep at 300. Here also you can keep at 300 or 350, not less than 250. Definitely not. So I'm going to take the Hybiz catheter inside. It is a Boston Hybiz catheter. iLab is using. Akiko standing. So I just tried to pass the IVUS catheter inside. I'm just telling you, I could pass the IVUS catheter. So I actually crossed the CTOS, that lesion, tight lesion. Now IVUS will be interpreted now. Can you show the IVUS? Can you focus the IVUS? No, IVUS. Ready?
So after the IVUS, we'll go to the next live session and come back to you. But let's
no
see
problem. Can you show the IVUS?
Yeah, I think that something wrong.
Oh my God, some problem there.
Yeah, I couldn't show. Okay, can you disconnect IVUS and then connect again? Yep, and then push again. Thank you. No, I'm talking. Oh, good. Okay. Okay, so everybody, okay, we are ready. So can we start forward? Yes. Okay, so this is a pericardium, and we are in the diag, which is very distal, and I think because of the flow, it's not much, it's very small, and we have only like 1.5 millimeter, but you see the not much plaque, now we start seeing the plaque. I think this probably what we are looking for, the osteal region. It's soft plaque, and you see the LED is coming in the 6 o'clock, which was 2-wire, and we are in the proximal LED. And bottom is sector, and we are proximal to the trifurcation. And you see actually chunk of the soft plaque, which is proximal LED. And then I guess that is a small diag, which not wired. And that's a big plaque. And we have like 1, 2, 3, 4, like the vesicle size in the proximal media to media is like almost 5. Not much calcium.
Can you come to Areo?
Yeah, still we don't see the circumflex yet. Okay, so that's a circumflex, and we see the left vein. So it looks like the plaque is almost up to the ostium of the LED.
Right.
Ostium of the LED.
Yeah.
So we have to put a wire up to the circumflex. It should have a marker there up to the circumflex.
And the left vein is, by the way, super clean.
We can stop it, Akiko?
Yeah, we can stop.
So
thank you, Akiko. And Pratap, one question to you now. Because of the IVUS findings of the diagonal vessel being so small, at least in the mid portion, would you change your strategy now from DK crush to provisional?
Actually, you have to dilate the vessel and see that how
provisional won't
the
take
vessel
care because it's after the ostial, the diagonal. So you will leave that.
I think that, I'm sorry, I think that
can you hear from IVUS? Can you hear from Akiko?
Do you consider here some diagonal treated drug-coated balloon?
Right. My thing would be provisional with the DEB to the side branch because of the...
That depends what you...
Right.
prefer.
And or versus DK crush. I mean, the length of the diagonal is more important actually than the size of the diagonal alone. So anything that the Korean COBIS registry showed that the length of the diagonal, if it is more than as long as 80 millimeters, then I think it's better to use the two-stent technique.
Akiko, what is the length of the diagonal?
Okay, I think like the normal to the... Okay, so give me a
How many millimeters?
Sure.
From the...
I understand, sure. So ostium to the normal side is only 7 millimeters.
7 millimeters.
Yeah, and then let me talk. I think the ostium of the diag, media to media is 2.7. That's real number, right? But if you go to the distal, because of the proximal is so occluded, 1.95, but I do think that's going to be grow up. So at least the diag should be able to put like 2.5 or 2.5 steps. That's my
Do you think that it would be a regulating balloon will be better or a stent should be better?
I think because of the plaque is a lot, I think the stent is better.
See, actually, I heard that now, Ramesh?
Yes. We heard Dr. Akiko saying that metallic stent is better than DEB.
DEB because of the 7 millimeter lesion length, but there is a plaque. Plaque is very severe plaque is there, so better to have a stent than. I am okay with that regulating balloon, but if the regulating balloon doing very well, do you think that this much plaque you have to just do a balloon directly and put a balloon, and I'll be happy to finish it off faster, then.
Pratap, if you dilated diagonal, would that size be, because it does look very, very tight and the flow is slow, so would the IVUS be different if after dilatation and nitro?
That is what I'm trying to do. I'm going to take a 2.5 millimeter balloon and dilate, and after that we'll do a nitro, and then by the time you can go back and come back.
Right. Madhu, it won't go more than 2.5. I think I agree. Dilate, give
2.5.
nitro, you can actually look at Hybiz at that time. But I'm sure Dr. Antonio Colombo is here in the audience. He would say that DEB will work quite well if you prepare the vessel, right, Antonio? DEB will work?
I don't believe you can make the prediction. Depends on the result.
Yes.
Sometimes the DB works, sometimes doesn't work. So it's not very predictable.
You don't have much data on native vessels with DEB, isn't it?
Dr. Colombo has a lot of experience in native vessel, and also Bernardo is here in the audience somewhere, I think.
Actually, can you ask Ramesh, can you ask Colombo that we will be doing a drug, will he do a cutting balloon in this case or just do a normal balloon?
The plaque looks soft, so I believe a normal balloon should be okay.
Okay.
So I will do a normal balloon, repeat the IVUS, and see the result after the IVUS, and then make the decision.
Yes. So Pratap, if it's okay with you, we'll go to the next.
Please go to the other lab and come
next
back.
to the next session, please, and we'll come back to you. Okay.
Thank you.
Thank you. Can you hear us, sir?
Can you hear us?
Yeah, we can hear you, but we can't see you. I think our AV is working. Oh, yes, we can see you now very clearly.
Hi, everybody. This is, so if that was a 5-star hospital, this is an amazing piece of 7-star comfort that I have been, visiting now. This place is amazing, a wonderful cath lab, wonderful staff, and the facilities are really out of this world. Maybe even the so-called first world would take a second look at this and may plan their hospitals in future.
Anil,
So
you're
we
just
have-
saying 7-star because Pratap said 5-star. The prices also will be 5-star and 7 stars, I think,
So,
audio is not
a very interesting case. So with me is Dr. Bharat Vijay Purohit, Dr. Pramod, and Dr. Shri Krishna, who is actually the bedrock of the team, and wonderful staff. I was so amazed that the technical staff and the nursing staff being so competent and proficient that they could probably do a much better job than we could in any case. So a very interesting patient.
I think the connection from their side.
Yeah, can you hear us now? So I think we'll come, would you like to just tell them?
Anil, hold on for a minute. If we are not having a good connection, we'll go for the talk until you fix it. Is the connection good? No. So the connection is not good. We can't see them.
Can you hear us?
Put
We
the
can
wire
hear you loud
already.
and clear.
Can you hear
the
us?
wire already?
This is like lightning. We have to give a lightning talk first, and then we'll go after you fix it, okay? So in between, we can invite for the lightning talk on thin versus thick struts, Dr. Milind Karche. Let's go for the talk.
Let's see what we have got. Because,
So very good morning to all and happy Doctor's Day. So I'm going to talk on thin versus thick strut DES today. Yeah. So since the introduction of stent for the treatment of CAD, there has been continuing efforts to improve the clinical outcome, mainly through reduction in restenosis, need for repeat revascularization, stent-related complication, and incomplete healing and stent thrombosis. So coming to strut thickness, it is defined as ultra thin when it's between 60 to 80. Thinner are the second generation DS from 81 to 100 micron. Thick strut like the first generation DS were typically more than 120 micron thickness, and intermediates are between 100 to 120. So do thinner stent struts improve outcome? So the discussion started since 2001 when this study was published by Dr. Adnan Castrati. And what he compared, this was basically a bare metal study, and it compared a thin versus thick strut BMS. And what he found is restenosis rate was almost double in thick strut stent. It was 14% compared to the 25% in thick strut. And even Reintervention required was also quite different, 8.6 versus 13.8%. So which is better? A thick strut, thin strut, ultra thin, or thinner the better? So answer is not that straightforward. So I will like to put forward whatever evidence I came through, and then we'll discuss. So there are definite advantages of thin or ultra thin struts, like lower crimp profile, improved flexibility, better side branch profile, less metal at carina, and bifurcation stenting. And other benefits like risk of acute thrombogenesis remains low, there is lesser trauma, lesser inflammation, minimal flow disturbances, faster endothelization and healing, and which is a basis for a recent trial showing benefit with the reduced duration of DAPT. So this was the meta-analysis published of thick versus thick struts, basically the first generation DS compared to the second generation DS, and it shows it reduced MACE by 18%, MI by 43%, stent thrombosis by almost 46%. And there was trend towards reduction in the rates of TLR and TVR. But is ultra thin better than thin? So this was another meta-analysis published in 2018, and it compared second generation DS with the ultra thin stent DES. And what it showed is there was a 16% modest relative risk reduction in target region failure. And this was another meta-analysis which also showed that TLR risk ratio was 0.85%. But these were the meta-analysis. What head-to-head comparison trials of ultra-thin DES and thin DES shows. So there were the studies like Bioflow 2 to 6 which compared ultra-thin sirolimus eluting with second generation urolimus eluting stent, and most shows that these two stents are non-inferior to each other. There was one study which is BioSTEMI which compared ultra-thin sirolimus eluting stent with second generation urolimus eluting stent in STEMI patient, in which the ultra-thin strut stents fares better than the thin strut. But if you consider a PRISM 4 study which was in a CTO patient, the late luminal loss and high TLR rates in ultra-thin struts were higher than compared to second generation DES. So, and again we have to consider when we do a bifurcation lesion, the side branch expansion capacity of the DES. We should know what is the side branch expansion capacity of the different drug-eluting stent, and it can be different in different sizes of the same stent. So we should know which balloon we are using and how much expansion of that stent is done when we use that balloon. So in nutshell, ultra-thin stents are as safe and effective as second generation thin strut stents. Ultra-thin strut stents fares better in some patient subsets such as STEMI. Thin strut stents fares better than ultra-thin in CTO and calcific lesions. Ultra-thin strut stents ease side branch crossing in bifurcation stenting. Thank you.
So thank you very much. I think, congratulations. I think this is the first lightning talk I've ever seen where I learned the same as any 10, 15-minute talk. Thank you. So we'll go back to Dr. Anil Dal and Dr. Purohit. Please get back them online and we can present.
Ready, I think.
We're ready? Dr. Barua, you're saying something?
Hold on.
Maybe you have a time we can discuss about the thin and thick stent. Just I want to know whether thin stent stent, what is the utility in clinical practice, whether in terms of diameter of the vessels, some of the big vessels, small vessels. Second, can you say at this stage? Can you say at this stage that this is superior than the ultra thin struts are superior than the thin strut or thick struts?
Yeah, so the data has not been strong, and that's at least my belief is that really to support saying that ultra thin struts are doing any better than.
Now, can you take wire? This is LED wire. No, I want to take LED wire.
Any comments from our panelists and Dr. Bell?
60-80 will be better than 100 or 120, but you'll lose the radial strength, so it
Right.
also depends on the type of lesions you are dealing with.
Yes, agree. Can we have a case presentation. Dr. Anil Dal?
Yeah.
Yeah, we can hear you now. We can see this. We can see you also. Go ahead with the presentation, please.
We'll go back to the presentation. I think the team had, the introductions had been done. There's a fabulous team here in a fabulous hospital. There is Dr. Bharat Vijay Purohit, Dr. Pramod, Dr. Shri Krishna, who's going to actually give us a brief introduction about the case. And it doesn't matter, just this is a 50-year-old gentleman, hypertensive.
Yeah, please introduce the team and the case presentations.
Dr. Krishna is there on my left. Dr. Anil Dal is there, and in the middle, Dr. Pramod is there. And we have our technician, Chiranjeevi, and the sisters, and all our, Dr. Jitendra is also there. Fabulous team. So we just started the case. This is a 63-year-old male, hypertensive smoker, came with angina.
Can you put yours in the front? Because we got a slide there. We can't see you.
Yeah, next slide, please.
Next slide.
You can go ahead.
Yeah. He came with angina, and the ECG had RBBB. The echo was normal, though no RWMA. So we did an angio. Just show the angio picture. Let's go to the angiogram. Show the current angio today's. So this is the ECG, and come to the angio straight. Yeah, so this is a angiography of the patient who has got a left main normal, LCX mild calcification. LED, you can see there is a tight LED diagonal lesion is there. And the lesion actually starting from the ostium of the LED. And you can see a little bit of calcium at the bifurcation point. It's a Medina 111. So we thought of deciding the strategy. So first we thought we'll ask their opinion. So here is a patient who's got a large diagonal. And you can see it's almost like a dual LED system. In fact, if you go to the cranial view, you can actually find that the diagonal probably is larger than the LED itself. And this diagonal is diseased, and it appears to be a fibrotic disease of about 20 millimeters, which is, and there is an intermediate lesion, what we thought angiographically, in the proximal to mid LED. So can you go ahead in the next angiogram? So we just we were debating whether this would be either too simple for a live demonstration, or what should be our strategy. So we would really like to know what you all would think, and then because we've been waiting a long time, we'll tell you what we have done and bring you up to date with where we are. So if we are faced with this, many things crossed our mind. Whether should we do one stent into the diagonal, which appears to be pretty large, and maybe do a provisional and look at the LED later, do an FFR, or maybe reserve a drug-eluting balloon, because it is, after all, an LED. If you can go to a cranial view, the distal LED appears to be like a bridge, because if you see the distal LED, it appears to be almost an intramyocardial course. And that was another thing which we thought that if this patient is presented with an ACS, could it have been a SCAD-like picture which was there? So we decided that we will resort to imaging, but we would really defer to your points of view. What do you have? What would you all do if you were faced with this?
So we'll just take one comment because of time. Dr. Barua, what will you do in this patient?
Yeah, I can see there is a bifurcation lesion with a moderate stenosis of the LED. And of course, the diagonal is a big, and it has got a significant lesion. Significant stenosis with a long segment. So I'll prepare this. I'll try to reassess this LED lesions with a FFR. Then probably I'll decide on what is the strategy next.
See, there is no question diagonal requires stenting. Now Anil's question is that whether we should treat LED as provisional. Yes. So for that it will be essential to know the significance of LED by any imaging or FFR, whatever it is.
Absolutely. Dual LED system. The diagonal is longer than the LED, but in my opinion, I still think diagonal is still treated as a side branch and LED as a main branch. Some people think that LED is shorter than the diagonal. Should we treat diagonal as the main vessel? So,
by intuition, you don't feel uncomfortable leaving the LED.
Yeah, go ahead.
Go ahead. That if a diagonal reaches up to the apex, it is damn well very significant. And we could not ignore it. And the fact is that the tighter disease is in the diagonal than in the LED. And the LED distally has an intermyocardial pause. So we thought that we would give primary importance here to the diagonal. So we resorted to imaging because we debated whether we should go for physiology or with imaging. We thought that physiology may not give us a complete picture because we would not be able to analyze whether there's any calcium. If you had looked at the epicaudal view initially, there was some calcium at the bend in the circ and OM. So we thought that just to rule out some calcium, we thought we should resort to imaging. So which imaging modality would you can see some calcium at the bend where the circ bends into the OM. So we were not sure whether there is calcium there, whether there's going to be calcium in the LED diagonal system as well. So what imaging modality would you choose? Would you choose an OCT or would you choose an Hybiz?
Yeah, I think any imaging is better than nothing. So it depends upon what lab you have and how much cost it is, right? And so for imaging is a must. That's what at least we can promote.
Thank you, Ramesh. So what we did was we decided to do both. We will now just briefly review the Hybiz images. Can you just show us the Hybiz images?
So the LED Hybiz.
LED Hybiz first. So if you start distally, you can make out that here we are in an intermyocardial course, and you can see that this is the bridge. And it was pretty exciting to actually, document that also in a live transmission. And then we come forward and we see this is the mid LED, which appears to be rather healthy. And as we come more proximal,
yeah, it's a 4x3 millimeters size.
Now the plaque starts off, and it's you can see it's a crescentic fibrotic plaque, which has in the proximal aspect about maybe 2 quadrants of moderate calcium, not much, and therefore we realize that this LED is also significantly diseased. Now we go back and we also imaged the diagonal. Can you show us the diagonal run, please? And we also by this identified the sizes because our strategy was going to be dependent on whether the diagonal and the LED were going to be within 0.5 millimeters diameter of each other so that we could decide an appropriate stenting strategy. So now this is the Hybiz pullback run from the diagonal, and you can again see that it is
about 275.
Yeah, it's about 275, and we can see that it is as you come more proximal, there's tight disease. There's fortunately there is not much calcium, maybe 1.5 quadrants of moderate calcium. We can't estimate the thickness very well on an Hybiz, and the proximal appears again to be diseased, and the disease is going almost to the ostium of the LED. So with this in mind, we also thought we'll confirm these findings on an OCT. Now I know that may not have been really warranted, but can you just review the runs?
This is the LED OCT.
So this is the OCT. Can you see the OCT images from the LED? And we again picked up the distal, and here is the tight segment, which is a fibrolipid plaque with as you come forward, there's a little bit of calcium, and we also realized that we cannot ignore this LED. Now we can say that we needed to have demonstrated functional significance, but if we see the MLA was such that it would warrant a treatment definitely. Now we got the sizes. Can you show the run from the diagonal as well, because there's a little shortage time. So again we confirmed, and keeping both in mind, we kind of settled on a strategy, but we would like to know your opinion as to what strategy would you all choose. Would you choose to do a DK crush, as is the flavor of the day, or would you choose to do a provisional still, or would you choose to do a culo, or would you choose to do a tap? What is it that you would have preferred? So we would like to hear from you, and then we'll tell you what we have done, and bring you up to speed with what we have.
Dr. Lawyer, what would you choose?
Looking at the size of the LED, that has to be LED will have to be taken as a main branch rather than the thoughts which were before. And I think DK would be a standard strategy.
Okay.
If he is comfortable with it.
Yeah. So two-stent technique for a Dr. Lawyer, doesn't matter which type of two-stent technique versus provisional. Two-stent technique, raise your hands in the palm. Okay, majority is two-stent techniques, and I didn't ask the audience as well. Audience.
So what kind of
role of FFR still left?
Yeah.
Sir, in presence of a myocardial bridge which is there distally, FFR might probably be erroneous and diastolic FFR might be of great help. And once we know that we have got a distal myocardial bridge, we understand that proximal disease is probably bound to be happening in presence. So would it be a possibility that we consider a DCB in LAD, a drug-coated balloon for native disease? Because even if we place a stent in presence of this type 2 LAD with distal myocardial bridge, we discussed about it yesterday also in a couple of cases where just DCB was done in the native vessel, especially in a bifurcation.
Right. I mean, as Dr. Madhu said earlier, we are still waiting for data on a native DCB, but I think it is
just a thought after seeing this vessel, sir.
Yeah, very nice.
At this stage, we don't have a lot of data on a big vessel regarding DCB. Yeah, we have to be a little careful.
Okay. So
that is
Anil.
A similar discussion happened with us here, and we all also had to decide how we would approach it. And we were all committed to the fact that we realized that treating or giving too much of importance to the LED in presence of the distal bridge is going to have some challenges. So we went back to our rather disruptive or counterintuitive thought of making the primary branch being initially to fix would be the diagonal. But should you keep it just at provisional? Should you use just a DEB? Or should you actually put a stent? And we can, even in a provisional, we can always extend the provisional to a different modality. We can make it into a TAP, we can make it into a QLO, we can make it into a DK QLO. So what would be your thought processes?
So we said two-stent technique majority, but what have you decided? You please mention it to us. We'll go to the other site and then come back. Then you can show us what have you done.
Right. So we started with a pre-dilatation and we pre-dilated.
No, just tell us what type of technique are you following, and we'll come back to you, Anil.
Actually planning a DK QLO.
Okay.
Because what we have done is we will just briefly review this because we pre-dilated into the diagonal. We pre-dilated, go on. We did a cutting balloon into the LED, and this was the new what is it? NSI alpha. And with that, we had a adequate expansion, and we've gone ahead and fixed the stent. This is a 275/28. We have gone ahead and fixed the stent from the ostium of the LED into the diagonal, and we have post-dilated with a pot balloon at high pressures with a 3O pot balloon. So while you go to the other side, we are working, we have re-established wire in the LED, and we are now pre-dilating and trying to get our first kiss ready.
Can you adjust the quality of the video? Now it is better.
So, Anil, as I understand, you are doing a collet and taking diagonal as the primary vessel. Is that right?
We're doing a DK QLO, and we are going to have, because we are not going to have more than a 0.5 millimeter difference.
LED. Let the struts.
Yeah, this is a case when both the techniques can be done, but it depends on what you are more comfortable with.
No, we also thought that what should be more suitable for this anatomy, because every anatomy is a little different, and therefore we are right now trying to balloon dilate and do our first kiss. We've kind of prepared the bed in the LED. We have put a stent into the from the LED ostium into the diagonal. And
okay, Anil, we're going to come back to you. Please continue, and we'll come back to you in a few minutes. Okay. We'll switch to Dr. Pratap Kumar to show the zero contrast DK crush.
Already doing.
Already doing.
We are with you back, Pratap.
It's okay. I'll show you what the things happen. Can you show the initial, whatever we left out them? No, next, fast. Next, that you show the balloon. Actually, we tried to take a balloon and balloon dilated. Actually, I'm telling you that balloon was not holding. It was moving here and there. Then we took a cutting balloon. The balloon was not moving. Can you see that? Next.
Can you enlarge the video, please?
Can you make it bigger, please? Screen.
Bigger. Can you show the image? Tell the IVUS is not required. Only the angio. Only angio, please. Can you show only angio? Okay.
No, we are not able to see in a bigger screen. Very small.
Now, can you see the bigger screen?
No.
Yeah. 1 minute, Pratap. We are not. I mean, you can go ahead.
They are not showing it.
There's a problem with the
now
audio.
You can see.
There's a problem with the video, Pratap. Just hold on.
Okay. By the time
so there is a bandwidth issue. So, but we'll go ahead, Pratap. In view of time, I think we can see your screen. It is just a smaller screen, like a picture-in-picture.
It's a quarter of the size of the normal screen.
My goodness.
I'll put my reading glasses on.
My goodness, that much, huh? Vipin Bhatia should not be given money for this live case then. Ujjal Bhatia will not get the money. Is it okay?
Yeah, go ahead.
No, actually I have shown you some of the things. Did you see that? I will come back out.
Yeah.
No, it's better now. You can carry on. Yeah.
Okay. Now, can you show the angio? Whatever I have done. No, go back. Faster. We actually tried with a balloon. Then it is not holding on. Next. We took this is actually a cutting balloon of 2.5 into 10. Because our lesion is only 8 millimeters. So we kept little into the LAD and dilated. That is, we kept for 15 seconds so that the cutting effect should be there. Next. In the meantime, we did an IVUS into the LAD. Can you show the IVUS into the LAD? IVUS? Okay. IVUS, can I explain, please?
Sure. Okay. This is sorry. How can I go back? Okay. Okay. Yeah. Can you see the IVUS? Okay.
Yes.
So let's start. The proximal, this is a distal portion. Distal to the diaphragm, and you see the cranial artery, and the vessel size is 3.25 or something like this. And that's a super small septa coming in the 6 o'clock, and they're starting the disease. And the plaque is quite similar to the diaphragm. It's very soft, and you see a lot of attenuation. This is really lipidic plaque, eccentric plaque. Compared to the angio, looks like much more disease in the LAD. Still, we are in the distal to the diaphragm, and very eccentric lipidic plaque. Coming back.
Deflate.
And very diffuse disease.
Go. 10, 11.
And a little bit calcium, but not too much at all. And then you start seeing the trifurcation. 6 o'clock is septal, and 12 o'clock is diag. And this is proximal to the diag, which you already seen before. And diffuse disease. And that's soft plaque and up to the left main. So you see, this is plaque burden is like more than 70%, and the lumen is like 3 square millimeter, the small diag on the top, and that's diffuse soft plaque up to
this one is
left main.
So would the stain be okay from the ostium of the left main, or would you have to stain from left main to LAD?
Yeah, give me 1 second. So coming back, that's ostium of the LAD, and that's the third. So seems to be we have the space to landing at the ostium of the LAD. So this is the osteo LAD 4.3, and this is a super distal, which we start 3.2. So we decided 3 or up to the osteo LAD 48 millimeter, and then opening the proximal portion using the 4 balloon.
Wonderful.
Okay.
I agree with that plan, Dr. Akiko.
Yeah, can you go back to the angio?
So can you come back to the angio now? So next one. No, before that.
So Pratap, I forgot to ask you, did you have co-registration on this?
No. Before. So actually what Akiko told you, you can take a 3x48 stent. So it is extending beyond. My marker should be on the proximal, not on the distal. So what I did is, go back. So I took that wire on the circumflex. No, go back. I took that wire, next. That fellow is not recorded, I think. The wire actually into the circumflex, that diagonal, distal, diagonal wire. So we have 3 markers now. Diagonal, distal is not required. Next. Then we did an IVUS into the diagonal. Can you show the IVUS into diagonal?
Okay. Can you see the IVUS? Yes. So this is much better compared to before in terms of the flow. You see the dark area, right? So still the vessel size is only 2, which is without nitro. And coming back,
already decreased.
And small artery, but quite normal.
Fast.
Like 8 millimeter distal to the cutting button. You don't see a lot of like dissection, and just a little bit opening at the lumen. And then the 6 o'clock, that's LED. So actually, the picture doesn't differ a lot. So based on this IVUS, we thought we need a stent into the diag as well.
Okay.
We have to go back. The next. No, before that. Just before that. I don't know this. Next. Okay. We kept a stent of 0.02 millimeters. We took a 2.25 into 12 millimeter stent because the proximal part we have to dilate up to 2.75 to a 2.25 millimeter stent of 12. It is 3 millimeter actually on the crushing part. We took a 2 milli atmosphere. Next, we just balloon dilated the next crushed. After that, no. Oh, he did not take. Fluorostor is there. Remove the same wire, but lot of bend is there. Luckily, the same wire only I passed into the. I have experience of using lot of aux wires, So this wire gone inside with not much difficulty for me, but the wire gone inside. After that, now I'm going to take a 2.75 into 8 and into the circumflex, into the diagonal, and a 3.5 millimeter balloon into the diagonal LED, and then do the first kiss. After that, putting a 3.3 into 48 stent, then proximally we will go with a 4 millimeter balloon and final kiss and come out. That is my plan.
Okay, wonderful. Okay, we'll be with you. Is that okay, Pratap, until you finish, and then we'll switch to, or we can go and come back. Up to you.
You can go and come back. Actually, no problem. Actually, there is Anil will be showing something, and just go and come back. By the time I can, I will be ready with the last shots.
We
probably.
would like to see the final shots.
Akiko is smiling. No. I wanted to show the last final 2-3 kissing and all. So you can go and come back, sir.
Pratap,
Pratap,
I have one question. Because you don't use contrast here, basically, by this metallic tree, you are implanting stents and all. So in this particular cases, do you take a little longer stent than a normal situation, or same size?
We have taken a longer stent for the 3 into 2.7, 3 into 48 is the longest stent. Akiko's measurement was showing only 40 millimeter. There is no 40 millimeter stent. It is a Boston sponsored program. They have only 38 and 48. Orsiro has 40 stent, but I cannot use an Orsiro here. They will kill me. So I can take only a 38 stent, otherwise 48. So I decided to take, Akiko also a Boston favorite person. So we decided to take a 48 stent. So that is why the 48 came. Come.
You have 48 millimeter stent, I think is very good. Dr. Barua, for your question that you can have the circumflex wire and you're coming all the way up to the ostium, distal marker is immaterial.
My question is because we are not able to see we are not implanting the stent on the angiographic guidance, positioning of the stent.
Right.
So this kind of situation where we should take little longer stent, normally what to use, that's my question.
Yeah.
What he means by
diagonal, he used 12 millimeters.
No, diagonal actually, no, Ramesh, I wanted to make it clarify. Diagonal lesion has only 8 millimeters. We have taken a 12 millimeter stent.
Yeah.
Okay.
So, and the 12 millimeter stent is taken 2.25 because Akiko was very clear that the distal vessel is only 2.2 millimeter. Okay. So I don't want to take a higher millimeter balloon and make it 2.2 millimeters. So I took a 2.25 stent. And the proximal, we decided to take a balloon dilatation with a 2.75. So the first decay crash, the first kissing, I had taken a 2.75. That I had taken only 8 millimeter. So that I will not be extending to the distal part, but I will be covering the proximal part. So this is actually a 2.75 into 8 and a 3.5. That is the proximal part she told. We can take a 4 millimeter up to nearly 20 millimeters.
Yeah. So the question basically was zero contrast PCI, whether you should take a longer stent than normal stent. But if you're depending on IVUS, I don't think we need to...
Little longer than the normal.
Yeah, little bit longer, but not too long. If it's an 8
precise,
millimeter...
you can be precise.
Lesion, whether we should take 16 millimeters or 12 would be enough. I think 12 is enough, and you can confirm that with intravascular ultrasound afterwards.
Now, both you can go. Both. Put together 10.
So the first kissing balloon inflation is being done right now.
I thought she is faster.
We'll go to Dr. Anil Dal and we'll come back.
Yeah, go. Come back.
And we might need 5 minutes extra time.
For what?
Anil, we are back with you, Anil. Anil, can you hear us? We can't hear you. Anil, we can't hear you. Hold on.
Yes. Yes. Can you hear us now?
Yeah, now we can hear you. Yeah.
So we told you that we had fixed the stent 2.7528 into the diagonal from the ostium of the LAD. And can you start with those images? And
increase the volume. Increase the volume, please.
Go back.
Okay.
Go back.
Go ahead, Daniel.
Yeah, go back. Come back. We're just going to take you where we left you. Come back. One more. Couple more.
What size was your first stent in the diagonal?
We
Long
took
one?
5. We were conscious of the fact that we had to size according to the distal vessel. So the distal vessel was about 275. So we took a 275/28, and we went up on this stent. And next, we followed this up with a very good pot with a 3x6 pot balloon, a dedicated pot balloon, which. Thereafter, and using judicious use of stent boost, which can be done dynamically and did not make us waste any more time. We knew we had got the ostium, and we knew that our next wire, which had to go, should not go subliminally. We recrossed into the LED, and next. And then we pre-dilated, got a little purchase with a tour balloon, and then did our first kiss. And this kiss, there was a little slipping issue at this stage, but we could manage it by sequential dilatation. And go ahead. And 3 and 2.75 balloons were done. We did another pot with 3.5 this time. Next. And once we done that, we were now set for actually treating the LAD. And for this, we actually took a 3.25 into 23 stent, which we again carefully using stent boost aligned to the ostium of the LAD and going into the normal segment, and went up on this after a lot of careful positioning and ensuring that we were away from the left main, and we managed to dilate this well. Next, please. Next. And after this, we again did a pot. This is again with a 3.5 pot balloon, and we again rewired. And this, following this rewiring, we again pre-dilated the ostium of the diagonal. Next.
Next, we're going to the final.
And now we are ready for the final kiss and the final pot. This is where we are. If there are any issues, our balloons are ready for the final kiss. Any comments, any suggestions, anything we could have done differently, or anything that anybody would like to suggest?
So, I mean, I'll just, this is nothing to do with the procedure itself, but I mean, it is slightly related to that. Radiation, I think, is really utmost importance, and probably I wouldn't use so much of stent boost in my own practice, just because the radiation is so much. As we can see here, this patient already received 3.3 gray. And so please be judicious, reduce the frame rate for fluoro, and don't cine every time. Don't use too much stent boost for all the pictures, except for probably live case demonstration, it is fine. But in your daily practice, watch for yourself. You will not actually know exactly how much radiation you're receiving. Protect yourselves, okay? This is a 3.3 gray. That means you're exposing yourself to a lot of radiation as well.
You'll understand that this is largely because it's a live demonstration, and we also wanted to capture every step so that we could play it back. And also because there was a lot of lag between, our getting ready and the little bit of disruption we had in the transmission. So we wanted to just record it for you all. That is why a lot of this has been done on cine. Otherwise, you're right, we use a lot of fluoro saves, and we can manage. We are ready for the kiss.
Absolutely. Any comments, Dr. Lawyer?
Can we see an AP cranial of this?
Oh, okay. AP cranial shot is this. This is almost.
This is the RO cranial.
Yeah.
Yeah, we will show you. If you'll permit us, we'll just finish the kiss, and then we'll show you all the views that you want.
So please, yeah, go ahead. We have just a couple minutes left for the whole session.
We allotted time because we have a very efficient team here with outstanding support. There has been no delay in getting any hardware. Yeah.
Yeah, excellent team under Dr. Purohit.
Yeah.
Go with the diagonal first. One second. I'll tell you. Because this is the struct now.
Yeah.
Go with the diagonal first.
So we got
20,
22,
24.
So the most important part in any final kissing balloon is the two-step technique. Inflate the side branch balloon and to high pressure, deflate, and nominal pressures at both after that.
Go to 12.
Go to 6.
Yeah.
Go to 6. No.
No. You'll have to hold the balloon.
And repot, I think, is important for that after that.
Diagonal for 6. Yeah, go to 6.
X. Yeah.
This has turned out to be a standard culotte, right?
Yes.
Yeah.
No, it's
DK culotte.
DK culotte.
But the layers were in the proximal ostial LAD, right?
I mean, basically, I think we can make it as complicated as it is. So but to simplify, I like to simplify things. Culotte requires the most angulated branch should get the stent first. So that is now called standard culotte, because if you're trying to culotte into the LAD here, which is a straighter branch, whether it is alternate culotte. I think I simplified. Most angulated branch, that's culotte. So the first stent should go into that.
Yeah, but the EBC still refers to it as inverted culotte, but that's all semantics. Yeah. But what you said was absolutely correct. And here is your cranial view, which we are seeing We wanted an AP.
Wonderful. One caudal view is also. Or,
Can we have a final OCT, please? That'll be great.
Yeah, we will be doing. We are ready with the OCT.
We will come back with OCT results. We'll quickly go to Dr. Pratap and come back to you. Please complete the OCTs by that time. Pratap, we are back with you, Pratap.
Yeah. Actually, I'm trying to put an OCT IVUS wire into the circumflex and then putting the stent. So, Akiko will show you. Inflate.
And can I request 5 more minutes time, Dr. Pratap Kumar?
Yeah, we can take.
Okay.
Because it is
He's the one
outfit,
doing it, so no issues.
Please. I will take this wire out, everything out now.
So are you doing the stain with live IVUS? Or?
Yeah, actually I did a live with, she was helping me. She told me that it is in the right place. Then I will tell you now how I did it. Can you show me the wire tip? He's not showing the wire tip. Okay. Actually what I have done is, can you show the image? Here. No, angiogram image. Can you go to the front? We kept the IVUS like this, and you just look at the now we go to the main IVUS imaging. IVUS. Main. Okay. Show the image. Okay.
Yeah.
Can you see this?
So we are in the circumflex, and we are looking at the LED in the 6 o'clock. You see the end of the stent is here. So that's meaning the stent is located at the ostium of the LED. That's it. So based on this picture, if you're opening the stent, you are catching the ostium.
Actually, Ramesh, what my plan was not to keep a strut into the LMCA.
Yeah.
So for which, what I...
Akiko, can you zoom out? It's too much zoomed in on the IVUS. Maybe. Yeah, but that's a good technique to see where the stent in the LED
IVUS
is landing.
catheter and...
Yeah. All right. That's okay.
Sorry. No, what actually, this is the LED ostium. Can you see the LED ostium now?
Okay, sure.
Can you show the LED ostium?
Sure. Yeah, we see, this is the circumflex on the top,
Yes.
and then this is the LED ostium, and you see the stent strut is here, so that's indicating LED edge is in the ostial LED.
That's a very good teaching point.
Protruding the left main. Meaning when we come, when we go to the left main, we see only the wire. Actually, this is not, he pushed, like when we see the stent into the left main, based on this picture, he pushing the stent into the LED, and we confirm the stent is really ending in the ostial LED.
So now you understood that was my plan. I put a 48 stent now. I can come to LED. Can you come to the angiogram now? Now we are actually doing a balloon dilatation with a 4 millimeter balloon up to the, she told beyond the entry of the diagonal, you can go up to 10 millimeters. Go. There is a small septal coming out, deflate. Now I'll take the distal part is not well opened up. I'll take a 3.5 millimeter balloon and dilate that distal part. And then I'll recross into the...
So Pratap, the live IVUS was, and 3 wires is possible with the 7 French guide?
Yes.
No, I took only 2 wires. I have to remove after the decay crash, I don't want the wire.
You were able to cross place 3 wires and 2 D1, D3 or D2, D3 and LED, and he did the diagonal IVUS. So it crossed with 7 French. You can do it.
Yeah, I can do that. At the same time, I'm telling in this case, what happened is actually I was having only 1 wire now in the circumflex. So I removed the other wire. My aim was actually to show that I am 100% sure. Now I will take an IVUS and show you that whether I did anything protruded into the LMC or not. That's the most important thing. Whatever we have demonstrated, whether it was producing a result, I don't know. I will be just telling. And everything, if it is not produced, it is because of Akiko. If it is produced, it is because of skill.
Wait. Sorry.
That is a normal phenomenon by every cardiologist, Always we blame the nurse and technician whenever we had a problem.
So we'll come back to you with just 1 minute. We'll go to Dr. Anil Dal and come back. Okay, we'll just look at the OCT.
13, 10.
Anil.
This is Rio.
Anil, we are with you. Can you show us OCT and both the diagonal and LED, please.
So can you show the OCT run?
Yeah,
so
we can see even.
The OCT run from the LED. Yeah. So you can, the second segment starts here. There's no dissection.
Very well opposed.
And good apposition. You find, and can you do after this, can you do a 3D rendering for us?
So looks good, no distal edge dissection, but needs a little bit more post dilation. So that's what you're doing, I see.
Yeah, we are actually also checking the diagonal, which we'll do live. And if you can see,
the diagonal.
This is a.
Yeah, that looks good.
Oh, that's good. So can we just do this live now? Where we guide check. You need a guide check? Small injection? Small injection? Done. Okay, guide check. Guide. Are you ready?
Yes.
Okay, inject.
One second.
Yeah, just come. All right. We can go ahead a little.
Ready?
Okay, ready? Okay, inject. Okay. So we've got a, Bharat has had a hearty breakfast, so he's had a hard time doing these very forceful injections. Okay, so can we see this? So this is actually the diagonal stent. No distal edge dissection. We've expanded the stent quite well. And this is now we are in the main in the proximal segment. So this is guys, this is what we've done. We might have a little more work to do but we'll sit down and analyze. Are there any comments or any questions or anything?
No, I think that's very good. Minimal stent area, what we want on OCT is 5, at least 5 or 5.5 is better. And,
there's a bit of stent into the left main, isn't it?
Pardon me?
Bit of stent into the left main.
Yeah. Did you? No, this is cool lot LED diagonal.
No, proximally.
Yeah, proximally it is not in the left main. We've seen that even on, maybe there's just half a strut inside the left main, but nothing much. So and then the circostim was pretty roomy.
I think, Anil, continue your good work. Excellent, all of you from the team. We are going to be cut off, I think, right now.
Just do one final line. We'll do our part later, but we can just show them.
I don't think we're going to go back to Dr. Pratap, are we? Are we going to Pratap? No.
Final angiogram.
Hey, come back. Come back for 1 minute and go.
We thought we got cut off, Pratap. We are with you for a couple more minutes.
Actually, Ujjwal Bhatia will not cut off.
Pratap, special for you.
With the 2 points deflate. 4 millimeter balloon. 4 millimeter balloon. 4. I'm going to do the final kiss and then finish. And then take an IVUS and just show the IVUS only to the lady and come. They are not fast, I'm only fast. Actually, port and all I will not wait because port I will do later. Only thing is I wanted to show the IVUS into the LED, otherwise, anyway we brought Akiko here.
Yeah.
She will be angry.
You want to see the IVUS there?
So when zero contrast...
Now, 1 minute.
Yeah, while you're doing that zero contrast PCI, some of us actually do it without any pictures at all. I mean, obviously, patient had a diagnostic cath, and now GFR is like either 15 or 20, and truly believe. But how many of in the audience and also on the panelists, would you feel comfortable not even taking one picture? How many of you would not feel comfortable, and you want to take one picture?
Can you take your balloon dilatation? This one, 2.75, 15.
Now, how about a zero contrast OCT? Here? Would that
zero contrast? I have done saline OCT. Go.
Yeah.
Both this one. Go.
Yes, saline contrast OCT could be done, but I
both together
prefer
for 10.
Hybiz.
Both together for 10.
So he's doing the final kissing balloon inflation for the DK.
She is very slow. Hey, diagonal, you just go inflate. You first. Otherwise, I think she is going very slow. Both together.
Okay.
Deflate. Now I'll take the final Hybiz and then you can go. 1 second.
And you can do report afterwards, right?
Report and all we will do offline.
Okay. So that's a question that some people might be interested in knowing, that pot, final kissing balloon, and report is being proven to be good on bench studies, but that has not been studied in clinical practice, whether a report is necessary or not. We still believe a report is necessary. I do it routinely in our practice, but still, I can't say that versus
but if you ask,
not doing a report is going to make any difference.
No, but I'm just saying, if you ask Annapurna Kanish, they are telling no need of any report at all.
The report is more important for a provisional, isn't it? Is it for DK crush? Is it that important?
Yes, yeah. So that's a Shaoliang Chen. So we feel it, the group, the Asian group believes
just leave it.
Need to do a report.
Leave the wire. Leave the wire.
Does not.
I think report is a must, because else you distort the stats anyway. So
can you be with
the main branch?
Okay.
I was already and go to Hybiz. Main screen. Hybiz. Full screen. Okay. Can you, Akiko, can explain?
Okay, so this is even more distal than what we see.
More distal than what we have.
Yeah, so there is some plug, but that's okay. We are putting back.
Yeah, minimal lumen area there is still
Yeah,
good.
wait. So this is a diag which he originally wired. So we are proximal to the second diag. Now you see the vessel is real and supernormal, right? And that's a stent, nice. Who put the stent? That's noise dissection, right?
Yes.
Thank you.
Okay, perfect. And we are very comfortable. And...
what happened?
No. I think this segment is actually quite normal behind the stent because we are a little bit longer. So small septa is coming from the...
Here we are the 4 millimeter.
Yeah, we may have to balloon more here.
No, 4 millimeter.
Wait. This is a little bit small, right? So this is under, we have to balloon. Like 50 millimeter distal to the trifurcation, I guess. So still we are distal to the first dial. I think this can be better. It's a little bit under expansion, right?
Yeah, you need to balloon more, I agree.
Yeah.
Okay, but no
Okay,
dissection.
everybody agree? Yeah. This time is fine. Okay, so still we are not seeing the diag yet. You remember that's a lot of attenuated plaque? Okay, by the way, that's a stented diag from the 11 o'clock. And bottom is a septal perforator. We are combined and we are proximal to the diag, which is actually nice, right?
Our now aim is to see that whether we
Okay, so then finally we will get the final answer. That's a small diag, whether we are landing the perfect or not. That you will see soon. So that's a very proximal LID. I think proximal LID looks good. So we will see the circumflex coming from the 9 o'clock soon. And looks okay. Oh, okay, you have much space and you're good.
Good, thank you.
Yeah.
We are exactly on the ostium. So
actually, a little bit distant.
1 millimeter distance. Because that is because of Akiko.
No, I think that segment no disease, so I think we're good.
Thank you very much, because I think now the only one or two more millimeter balloon dilatation and proximal pot. That's all required.
Yes.
So we will finish it off, and I will not take a single shot, and Anuj Kapadia will take an angio shot. I will not take, because if I take, my zero contrast idea will go away.
Yeah.
Thank you very much.
Thank you. Wonderful demonstration.
Thank you so much. Thank you.
Nice.
Thank you to all the chairpersons, panelists, and moderators. I apologize to the chairpersons of the next session for taking 15 minutes of your time. Thank you.
So we are ready for the next session, which is on bifurcation again. And my co-chairpersons, Dr. Chirag, Dr. Lekha Adik Pathak, and Dr. Shashikant, MS Ravi, Lipika Adhikari, Rajan Joseph. All these people are requested to come up. And the moderators, already the names are there with them. So please join. And we will start with the presentation very quickly now. And we have the first presentation by Dr. P.K. Sahu. So Dr. Sahu, is he here? Dr. P.K. Sahu, please come. So he's going to talk on kissing balloon inflation. Should I do in all cases of bifurcation PCI? And what are there any long-term effects? So we'll start with this session quickly. And by the time all my co-panelists and moderators will join in.
Good morning, everyone. In fact, the topic is on kissing balloon inflation. Should I be doing in all cases of bifurcation PCI? Are there any long-term effects? So I need to answer two questions over here. Should I do in all cases of bifurcation PCI? Number two, are there any long-term effects? Now, when do I do a kissing balloon dilatation? Two situations. One is provisional strategy to address the side branch, or when I use a double stent to do a kissing balloon dilatation. These are the two situations. Let us take the first situation, provisional strategy, whether to address the side branch with a kissing balloon. To kiss or not to kiss is a big dilemma, as I'll show to you what is the scenario like. First scenario, this is almost a CTO. Patient comes with angina, chronic stable angina, TMT is positive, there is some retrograde flow, and then you can see when we did an OCT, we could see that there was a lesion which was almost from the left main, almost extending to the LAD. So what we did was that we gave a stent from the left main to the LAD. So it was a single stent strategy. You can see the angle is quite wide. So here, if you try to see the post-OCT pictures, there is no strut across the LAD and the circumflex. So this establishes the fact that there is no need to kiss at all. So these are the situations where possibly you don't need to kiss. Here, if you take a 3D view, there are no struts across the side branch, and definitely there is no need to kiss or no need to go ahead. Let's take a scenario 2. This is a similar type of situation with an ostial LAD extending to the left main literally, because you have to stent from the left main to the LAD, and the angle is quite narrow. So when when we did this thing that is LAD to LMCA, we took a run, we could see there was some plaque in the left main, and first a cutting balloon was used, a Wolverine. You can see the beautiful cuts that have taken place, and then a stented with a single stent strategy from LMCA to LAD. And then what was seen was that there were struts in between, there were crowding of the struts in between the circ and this thing left main. So one, you can see that there are a few struts that are this thing. So these struts were questioned whether these struts would cause any problem. So these struts were, the question came whether we have to kiss this or not. Now, sometimes what you do after you do a pot, you might take a small balloon and try to just push it across and try to just open the struts or do a kissing. And this is what was done after the pre-dilatation. You can clearly see that there are no struts. But the question is it essential? Let us try to see what the studies say. If you come to 2015, when the final kissing balloon inflation, the whole story came, it was basically that it was to optimize the side branch strut. So that is why the reason for the kissing balloon dilatation came into being. But as we grew further and further, we saw that the geometry had to be changed so that the coronary flow would be better. Now, if you try to see some literature quite back, some years back, it was shown that if it was a jailed side branch, it all depended on the side branch width. If the side branch diameter was less, it was seen and the struts were across, then one could see that gradually with time, the link group, they started having restenosis. So the question came that on an 18-month follow-up, this study showed that the side branch started having restenosis. So the question came that should we routinely do it? The OCT analysis showed that definitely at the almost 1.5 year, if there were struts left across the side branch, this would cause problems. The initial studies was that the final kissing balloon, these were studies in 2015 to 2017 when they clearly came with the guidelines or the study that final kissing balloon as a single stent strategy is the treatment in non-left main lesions in ACS patients. So there were views which were published that definitely you have to kiss it. But then gradually as we went on, this COBIS registry clearly stated that with a one-stent strategy, final kissing balloon is associated with a favorable long-term clinical outcome, mainly dependent on the reduction of TLR in the main vessel or both vessels as a result of the increase in the MLD. So the concept was that
I say relatively safe against wrist stenosis, but not so safe. So the bottom line is that we try to minimize the need of stenting of the side branch. And how do we make this decision? This is a typical example where if you look at this angiogram at the baseline, you will say that you need a stent on the circumflex. And nowadays, we rarely make this decision by looking at the angiogram at the baseline. There is no need to say at the beginning, do I need 2 stents or 1 stent, or even do I need a stent? This question does not need to be answered when you see the angiogram, and not even when you see Hybiz or OCT. This question needs to be answered after you have done pre-dilatation. So in this case, we dilated the circumflex with a trio balloon, high pressure. We did a kissing balloon, which is something that is not suggested to be done, but we do it. And after kissing balloon, we do the angiogram, and you see that there is a good result on the circumflex, because frequently angioplasty works, believe it or not. So at this point, we continued, and we did the stenting left main to the LAD. Then we did dilatation of the struts towards the circumflex. You may argue that this is not necessary all the time, as we heard before. And then we did a kissing balloon, and we utilized a drug-coated balloon because the result was still adequate, and this is the final result. So the decision to treat the circumflex was taken after pre-dilatation and not at the baseline. And this is a message that I would like to transmit regarding side branch. The side branch decision is not taken at the baseline, but after the result following pre-dilatation. So 1 stent, left main LAD, and provisional with kissing balloon. This is a typical case, which is a real pain in the neck, isolated disease of the circumflex. You place a stent at the ostium, there is some protrusion. Long-term result is very unpredictable. In this case, we did balloon dilatation, no stent, a final drug-coated balloon. This is a 1-year result. There is some late loss, but it's very minimal, and the lumen is maintained. So this is what I call a more modern way to approach a side branch disease. This is a more severe disease of the circumflex, a diffuse disease confined to the ostium, but extending to the body. This disease in the old time, we would say absolutely stenting. Now, absolutely, I don't know. We pre-dilated, we had a reasonable result, there is some dissection, but the lumen, residual lumen is fine. We did a drug-coated balloon. This is 1-year follow-up, which is well maintained with no compromise of the left main and the ostium. And to final, I would like to say that even if the circumflex or the side branch is severely stenotic, these may have no clinical impact. This is a lesion that all of us will be ready to treat and to stent. The FFR was 0.90 with adenosine peripherally given, high dose. We checked with SPECT and was negative, and despite this tight stenosis, there was no clinical need to do anything. So don't be always pushed by images, but we are still doctors and we don't make the decision based on pictures but on clinical situations. So to conclude, we should try to minimize the usage of stenting as the ostium of the circumflex, but I would like to add as the ostium of diagonals, OM, any side branch. And when stenting cannot be avoided, because sometimes it is necessary, imaging-guided optimization should be pursued because the side branch stenting is a malignant situation. Thank you for your attention.
Thank you very much, Dr. Colombo. I think this is extremely important points which you raised about how to treat a ostial circumflex disease, because sometimes it is de novo and at times it is because of a sequelae of a first stent from left main to LAD. So in both these situations, as you already mentioned, that avoiding a stent is a better technique. And what is your idea about using cutting balloons like Wolverine or any other device, if it is very calcified, even a shock wave, and then assess whether we need to put a stent or just a drug-eluting balloon?
But we are very liberal about using a cutting balloon as the ostium of the circumflex, because we know that there is disease. It's always difficult to make a decision and say when to stop to being too aggressive, because we all know that unless we do directional atherectomy and we remove the plaque, if we push the plaque away from the circumflex, it will go towards the LAD and the left main. So this is not an easy decision, and it's a matter of art, you have to decide case by case. Depends how big is the circumflex, how large is the territory. And many patients do a normal life, even if they have a stenosis of the circumflex, so, or of the diagonal. So let's not be too concentrated about picture taking.
Dr. Colombo, can I ask a question? It's a very important topic and important discussion, because circumflex ostium is really a pain for all of us. So what I want to ask you, that is the philosophy, your philosophy of ballooning and using drug ballooning balloon will still hold true when the circumflex is very dominant vessel?
Yeah. No, doesn't matter if the circumflex is a dominant. I think it depends on the result you achieve after predilatation. But we all know that if the circumflex is very big, if you place a short stent and you place it well, the results are going to be good. I'm not trying to go against stenting. I'm trying to say not to stent when it's not necessary.
Right. Can we make use of the, can we have a drug-eluting balloon at the circumflex ostium instead of a stent?
Yes, but that's my hypothesis generating. I hope it will take another 2 years, but I think in 2 years I will provide some data.
Sir. Can you take a mic?
Dissected.
Can you take a mic, please? You can go to the mic.
I think the third case that you showed, where the circumflex was very tortuous and very badly diseased, and you showed that after balloon dilatation there was a dissection, and it looked on angiographically that the dissection was quite extensive. Now, how do you decide that drug-coated balloon will be enough for this case, and I would not stent it? Because you will have to come out. You will have to take everything out, the wire out.
Yeah,
And based on what do you decide?
New generation interventionists are not used to accept dissections. So every time you see a dissection means stenting. We don't suggest to do Hybiz to evaluate a dissection because in clinical practice people don't do that. The way to evaluate a dissection is the residual angiographic lumen. If you have a dissection but the residual angiographic lumen is large or sufficiently large, we accept the dissection. And I've been doing this approach for the last 2 years, and I did not have a single occlusion. So residual angiographic lumen, if large, dissection can be accepted. If the residual angiographic lumen is compressed or small, you need a stent.
Okay, and you do a 1:1 balloon dilatation? Do you do a 1:1 balloon dilatation?
Yeah, 1:1. And sometimes the last resort before placing a stent is to do another dilatation with a little bigger balloon. Believe it or not, sometimes a bigger balloon helps to make the dissection a little bit bigger and makes the residual lumen larger. So converts a malignant dissection into a benign dissection. Don't be afraid because you always have a stent in the lab. So whatever happens, as long as you don't break the vessel, you can place a stent.
Thank you.
Thank you.
Thank you.
So, okay, one last question.
After the DCB of LCX ostium, is biovascular scaffold worth consideration to LM to LAD?
The BVS, after doing the treatment of the ostial circumflex, will you still consider a absorbable scaffold?
You know, the problem of absorbable scaffold, my emotional answer is yes, but we all know we can make a full day symposium about BVS, so I give you emotional answer is yes, but that's it.
Right now we do not have much data to support that, but certainly this technique of treating the ostial lesion well with whatever you want to do, you do shockwave, you do a cutting balloon, but the dominant strategy is a Wolverine in these situations and then get a stent-like result. And many times, if you have a FFR wire up front, there is a FFR wire down the vessel, and then you can check the FFR. If everything is okay, image looks good, you can do a DB and just stop there. Yeah?
But my main message is do not be too concentrated on ostial lesions. The best way to avoid ostial lesion problem is not to do angiography.
Okay, that actually, caps the whole talk very well. Thank you very much, Dr. Colombo.
We'll call upon the next speaker. Predicting long-term outcomes in bifurcation stenting, role of imaging. Dr. Giulio.
Thank you very much. Starting with the potential pit stops that you might have during the procedure by using imaging. A lot. You can do imaging before to get lesion characteristics, stent size, length. You can go with imaging across all the different steps. But the point is, what is really important and in which type of bifurcation we should approach with imaging. Here you have a couple of risky situations. Patient presenting with unstable angina and what they call a complex artery through bifurcation 111 or 011 Medina. And you have in a 2-to-1 propensity score match in hundreds of patients. And this is the results of using imaging at 1 year. The strategy was changed in about 1/3 of the patients. The adequacy of the expansion was reached in more than 80% with a significant impact in terms of MACE. What about long term? 7 years later, the same group of patients, you can see the big difference in what? Marginal aspect? No. Total cardiac death and revascularization. So when you are moving to the high level of complexity, there is some difference. Not all the bifurcations are the same. Data coming from Renovate complex PCI. So the first randomized study in a 2-to-1 showing the impact on imaging versus angio guidance. And you can see the subgroups. Unprotected left main coronary artery disease, very good results. What about global through bifurcation? Neutral. So it's important to understand that depending upon the level of complexity, we might be in trouble clinically. There are data from the Excel comparing what we can achieve in the left main when we are comparing to surgery based upon the ostial and the body of the left main, where we can compete very nicely, compared to the distal bifurcation. So two concepts. So when you have a challenge in bifurcation, you are challenged by the adverse events. And the second one is try to keep simple. This is the case. 15 years old, coming with unstable angina. And the question becomes, should procedural planning be part of a standardized set of imaging guidance criteria? And my answer is only one. Yes. Yes, but you must use high quality of imaging. Likewise, we have today, it doesn't matter which technology, and full information. And full information means also longitudinal extension, means where to land, means the type of plaque, taking measurements. Why we need to watch around, for instance, at the landing zone. There are results from the ultimate trial, with about 1/4 of the patients with a bifurcation and 10% with a left main PCI. The most frequently failed Hybiz criteria was plaque burden more than 50% at the edges. So don't be concentrated only on the plaque, but watching around. And that is becoming very important when you are dealing with a hostile lesion. Here you can see an example. Should procedural planning watch around, especially at the ostium of the LAD and the circ? Here you have when you try to nail the ostium and when you doing a crossover based upon the imaging extension in the left main. And you can see the difference in terms of a TVR. There are data in support of this? Yes. Here you have the intracoronary imaging on proximal lesion when you compare imaging to the angio guidance. And if you are going to the bottom of the slide, you see that when you are using imaging in the ostial lesion, you might have a lower rate and a better survival, lower rate of TLR and a better survival, primarily due to which type of lesion, the ones they are referring to the left main. And so it's becoming the more and more relevant to watch around. Please stop number 2. Try to get measurements. Why try to get measurements? Because measurements are very important to decide the size of the stent based upon the distal reference, but also for fixing the size of the pot when you finish the procedure. Which type of measurements? The most simple. The length of the lesion, the landing zone, and the size that you might have for the pot. Can we do by using just a single imaging technique Now, you can do by using multiple imaging technique, but then you have to add also another P-stop that look to the plaque, to the distribution, eventually to the carina, and the risk of the side branch occlusion. And here you have an example of the possible contribution of the OCT. What about the type of plaque? How much can be impactful on outcome? Here you have some study focusing on the characteristic on the main vessel. And here you see the importance to have a look at to what? In the main vessel, to the amount of lipids that you have around the side branch. And when you are growing in terms of amount of arc of lipid and volume lipids, you might have a maximum risk of a side branch occlusion. But, of course, that was obtained by OCT. Here you have the same obtained by using Hybiz, where it's not only the main vessel to watch. For the left main distal bifurcation, it's also very important to have a look at the type of plaque. If you have a calcifying nodules at the origin of the circ, that could be one of the major aspects for getting in trouble. We will continue to always use the same images. This is from Dr. Lee. I don't think so. I think that images can be used in the future to get a better characterization and a prediction before going to the procedure. In a growing number of patients coming with non-invasive information of the risk to get problems during the procedure. What about calcium? It's not only to see or not calcium, it's how much we can gain when we are treating calcium. Here you can see the same pair images in the patients when you have a huge amount of calcium after the shock wave without any significant result. Unfortunately, in this case, you take measurements and then you can see that you need some escalating of lesion preparation. That go into rotational atherectomy and what is possible in the two different branches. Very, very important. When you are coupling the imaging technology with the best of technique that we learn from the clinical data, in this case, you have the combination in a huge number of patients with unprotected left main distal bifurcation of imaging guidance, Hybiz and OCT, and POT optimization based upon the clinical and the imaging criteria. And you may see the significant impact in terms of outcome. That is marginal, is not marginal. You can see that the most impactful were on stent thrombosis and sudden cardiac deaths and longer-term cardiac mortality. They are very important factor on this branch. Check the coverage, the apposition, the MSA, the expansion, and of course, the symmetry of the carina. When you are confronting with this section, you can see clearly the difference between what is optimal and what is suboptimal. There is a space for other variables. Here you can see one possible contribution that is in the link crossing and detection of the link crossing the major branches, especially at the level of the distal left main. How much is important? Here you can see the difference. When you compare all the bifurcation with the distal left main bifurcation, if you are leaving the link crossing the branch at the level of the left main, you have a much higher risk of restenosis. It's not applicable systematically to all branches. Do we have suggestion for using imaging in the best setting? And which one? Here is the document we produced in 2018, said they are the subgroups of patients that can benefit of imaging to be guided. And you see the left main. And you see in the best country in Europe, the percentage of the people approaching left main by using imaging guidance. And here you can see on the left side the potential impact in terms of mortality when you are using imaging versus angio guidance in the distal left main. Everybody is claiming that if we needed to use imaging, we would like to do in the left main and in the proximal LAD. But unfortunately, this is the reality. When we are confronting the use of imaging, you can see that also in this high-risk situation, there is a spectrum of use across all these hospitals and all the interventional cardiologists. One additional pit stop that we recommend: when you are in doubt of something, please use imaging. There are trials, they are coming for Hybiz and for OCT, randomizing patients to angio guidance versus imaging guidance, and they will be available soon. The conclusion are bifurcation PCI planning. The concept that the bifurcation are different is tenable, and the more complex they are, the more there is the need to get a planning by using imaging. High resolution tomographic imaging, it doesn't matter is invasive or non-invasive, are seminal for ameliorating understanding and treatment. As we said, the randomized trials are coming. Bifurcation PCI optimization, we needed to redefine the optimal procedure benchmark at all steps. Thank you very much.
Thank you, Guru. I think you have made it very clear that every bifurcation stenting need imaging, and very good imaging is required for a successful procedure. Do you think that there is any situation where imaging may not be required?
Well, I think that the clinical judgment Antonio was alluding before is always important. So don't go in trouble because you wanted to do at any cost. If you are in doubt, doing in the main vessel can be more than enough to get some information about the bifurcation. But the extension of the bifurcation, the clinical relevance of the situation is very important to try to stay oriented.
Any questions, comments? Okay, if there are none, I think we'll give him a big hand.
So we now move on to the next presentation, and this is by bifurcation stenting and imaging in the BRS era. Dr. Chadda, it's yours. So BRS is like very, very few cases are being done right now, although we have BRS in India and everybody knows about it. Yeah, so please go ahead.
Good afternoon, everyone. I think the topic is having a re-look at BRS. I'm not here to advocate BRS as a therapy for bifurcation stenting because we've learned our lessons, and over the next couple of minutes, I'll just take you through the journey of the BRS. Yes, this is one stent scaffold which is desirable. It has multiple advantages as listed. It restores your vessel vasomotion. It basically dissolves over a period of time, so leaves the branches open for re-intervention. And you would not like to leave behind something which kind of becomes a nidus for some problems to come up, restenosis, neoatherosclerosis. And yes, these vessels at a future date are graftable. Well, we've learned our lessons from Absorb, and we noticed a very high rate of early as well as late thrombosis with Absorb because of mechanical and biological reasons. Mechanical primarily because the struts were very thick, so it led to compromise of the lumen and thrombus formation. There were also strut fractures because the protocols were not being followed, and since the struts were thick, the endothelialization was delayed, and that led to its own set of problems.
Can I interrupt a little? Yeah. Because the next session live case is ready.
Right.
So if you can tell us the more salient points and make it a little faster.
Fair enough, I can forego the talk also.
Yeah. No, I think we can have some of the important points.
Okay, fair enough. So the lessons from the Absorb were that the stent thrombosis rates were very high. So they kind of revised their protocol to PSP, wherein they said you pre-dilate, you size the lesion well, and do the post-dilatation, and that was the way forward. But did it help? Yes, it did help. It brought down the thrombosis rate. But when you look at Absorb 4, the problem still persisted. So the problem, since it persisted, there were certain challenges, and as listed on the slide, the struts were very thick. There was compromised radio opacity, so people using in an overlap fashion had problems. It had to be stored in a cold chain, had to be maintained for the quality, and one could not overlap these struts. So there was a need to improve the device. There was a need to improve the technique to implant this device, and kind of features which are given here. The strut thickness was very, very thick, and we have the new platform Mirus, which has brought down the strut thickness from 150 to 100. They have also given a couplet of radio opaque markers at each ends, which help you in implant, and yes, the size matrix has increased. Well, this is Mirus 100, and all the features which I enumerated. It's got a hybrid closed cell and open cell design, and you can see the radio opaque markers, and they help you implant the stent better. And if you see that this slide shows the dissolution rate is pretty good, and there are studies where it has shown that the strut dissolves over a period of 2 years of time. And the deliverability, since you have a very bulky stent with Absorb, the deliverability was questionable here. It goes to the 6 French, and it goes very easily. But if you have tortuous anatomies, you have to be careful. You have to use the guide extensions. Now, what are the important things to remember? You need to select your patient well. It's essentially meant for young patients. You need to prepare the lesion well. Yesterday we saw a case, there was a little bit of calcium. You need to crack that calcium. The BRS is not a platform to use for vessels more than 4 millimeters, because you can't overexpand and blow it up. You need to pay attention to the expansion limits. You can blow it up only by 0.5 millimeter. You can't keep blowing it up further. And this needs a very dedicated protocol for expansion. You need to go up slow. You need to maintain pressure. It's not like a metal platform. You go to 16, 18 and come down. You need to stay there for time, and DAPT has to be kind of cemented onto the patient, and you need to have a separate session with the patient that he needs to continue the DAPT well. Well, the Mirus platform, they have paid attention to all this. These are specific markers which are available, and if you need to overlap, now the balloon marker, the distance between the balloon marker and the stent is about 1.3 millimeters. So once you overlap this, you match the balloon marker with the previous stent's radio opaque marker, and then when you go up, you have a perfect overlap. So this kind of overcomes the shortcoming of Absorb, where it was not possible to have this kind of overlapping without the struts getting on top of each other. Well, the following situations you should avoid in tortuous anatomies: complex CTOs or calcific lesions or very small vessels. I'll just show you 2 straightforward cases of RCA. We dilated, and these are the images. It's very important to have the reference diameters, because this is what will help you select the sizes. OCT scores over IVUS in this regard, and this was, and malapposition is a norm, and I'll show you the images that whenever you implant these stents, you will have malapposition, so you need to post-dilate. So this is the kind of malapposition you will see around the struts, and you need to optimize. Another case of RC, again a garden variety, you do the sizing, and this is how it looks on boost. You can see the arrow markers on stent boost. Rest, nothing is visible. So the triaxial markers are very well seen. This is post-stenting, and a very well opposed stent. Little bit of malapposition as a norm, I told you. And this is an image which a rendered view of a stent shows. You have the guide wire, you have the stent struts. These are the open cell designs, and at each end you have closed cell design. So you can have 3D images also available to show you whether the stent is expanded well or not. It's been tried, and Dr. Praveen has been part of these trials. 2 have been completed, 1 study is ongoing. What is important to note is that the scaffold thrombosis has come down tremendously, and they haven't recorded even a single scaffold thrombosis. So the strut thickness reduction, the storage change, the protocols being advocated for a proper implant have been followed, and that has really helped in producing good results. But yes, they have been very cautious in advocating this stent. And to conclude, I would say that the new generation MIRAS is here, but the caution here is that if you want good results with this, you have to follow a protocol, select your patient well for implantation. You just can't do it in anyone or everyone. I'm not advocating it for calcified torches or for multi-vessels or for bifurcation anatomies. Use imaging, which is very, very important, and follow up your patients well with DAPT, because this is what is going to ensure good long-term results. Thank you for your patient hearing.
So thank you very much. I think you did perfect in time. And with this, the message is very clear by Dr. Chadha that the device is there, it's a good idea, but we still need to have that comparative data between a DES and a BRS to make it much more routine usage. So we'll quickly move on to the last presentation of this session, and I'll request Dr. Manuel to be a little quick because Dr. Pratap has taken too much time today and we are a little delayed. So, but we still have this presentation, and thank you very much.
Thank you. Thank you to the organization of the Congress, and especially to Dr. Pratap Kumar for this kind of invitation. The NIC is one of my favorite meetings, and it's my second time in this. And the presentation is technique to preserve the cyberarm access in bifurcation lesions treated by provisional stenting. Provisional stenting has become the default technique for the treatment of most coronary bifurcation lesions. However, the side branch can become compromised or even occluded after main vessel stenting. So in the slide you can see 3 examples that after main vessel stent implantation, the side branch disappear. Diagonal disappear in all these 3 examples. So this is a problem and a limitation of the strategy of provisional stenting. What can I do to avoid this complication? First, to identify the risk of side branch occlusion during a provisional stenting strategy. Second, prevention of this complication with several techniques that I am going to describe. And third, if after all these strategies the complication occur, we have to fix the problem with some technique that has been previously described. Regarding the predictor of side branch occlusion, we have a lot of them. We have angiographic, we have Hybiz factor, we have OCT factors. Julio has presented some OCT image that describe factors that predicts side branch occlusion, but generally by Hybiz, the most accepted factor is the presence of an spiky carina. Alfonso Medina called this sign the eyebrow sign. But you can see that in this example that after main vessel stent implantation, the carina is displaced against the side branch ostium and the side branch become occluded or compromised. But from a practical point of view, the operator normally uses the angiographic to evaluate the risk of side branch occlusion. For this purpose, we have the resolve score. The resolve score uses 6 angiographic variables. 4 of them are quantitative. And quantitative angiography is not a practical strategy when you are in the lab. So the visual resolve has been described also and correlate well with the quantitative measurement and can be also used. The variables are the plaque distribution, the TIMI flow, the pre-procedural diameter of the bifurcation core, bifurcation angle, diameter ratio between main vessel and side branch, and diameter stenosis at the level of side branch. If you have unresolved score more than 10, you have at high risk of side branch occlusion. To prevent this complication, first we have to follow the main EBC recommendation that to implant the stent according with the distal diameter of the bifurcation, and then perform a pod. With this strategy, you avoid an oversight at the level of the side branch, producing the compromise. But before the main vessel stent implantation with this recommendation, you have two possibilities to protect the side branch. The conventional, that consists in wire the side branch and leave the wire after main vessel stent implantation, the known jailed wire technique, or use a more complex strategy called active protection that consists in leaving a balloon at the side branch while implanting the main vessel stent. This second strategy is more complex, but in some complex case may be more effective. The advantage of jailed wire technique is summarized in the slide. Everybody knows that the technique helps to keep the side branch open, and in case of occlusion, the guide wire is the only marker of the side branch ostium, like in the previous example that I showed you. It facilitates the access to the side branch by favorably changing the angle of the bifurcation. The jailed wire can provide anchoring of the guide catheter, which facilitates the balloon crossing through the stent strut to the side branch. And more important, in case of side branch occlusion, the jailed wire can be used to pass a low-profile balloon or a penetrative microcatheter between the stent and the vessel wall to restore the side branch flow. This is an example of this situation. A left main complex stenosis at lateral and spider view. The operator implant and stent from the left main to LAD. The circumflex disappear, but you have the jailed wire in place. So after several attempts to rewire the circumflex, the operator decided to use the jailed wire to dilate the ostium of the circumflex. First, use a very low profile balloon and then a normal 2.5 balloon that restore the flow of the circumflex, producing a crash of the proximal part of the stent at the level of the left main. The procedure continued with a crash, an inverted crash, in this case, implantation of one stent at the circumflex, kissing, and a final result. So this is a good example of using the jailed wire to restore the flow in an occluded circumflex artery. Normally, insert a jailed wire in the side branch is an easy procedure, but sometimes you have to face with a very complex, challenging anatomies. These are three examples of very unfavorable tortuous angles that make difficult the wiring of the side branch. To resolve this anatomy, to resolve this problem, some techniques has been described. The more simple is a good pre-shape of your guide wire. You have many possibilities: a single bend long tip, a smooth bend, or even a double bend. If you fail with this simple maneuver, you have the reverse wire technique. That is a complex maneuver. You have to perform two bends to the wire, a long one and a short one, to pass distally in the main vessel and then produce a retrieval of the system, trying to engage the tip of the wire at the level of the ostium of the side branch. This maneuver can be facilitated by a dual lumen catheter, like this example, or even with other simple catheters. Another possibilities Another technique is the use of dual lumen catheter. We think that in case of bifurcation in combination with ACTO is an excellent scenario to use the dual lumen microcatheter. Many times you have a proximal dissected segment that's, and a wire at the distal true lumen. Use a second wire is difficult to cross this proximal dissection, so the microcatheter facilitates the wiring of the wire and finish the procedure successfully. Dedicated single lumen angulated catheter is also useful for very angulated bifurcation, like in this example. In the cartoon you see that the microcatheter face exactly the ostium of the side branch, provide support and facilitate the wiring of the side branch and finish the procedure with provisional stenting. The effectable tip single lumen catheter are also useful, like in this example. In this case, the operator can rotate the tip of the catheter according with the complex anatomy of the bifurcation. You can see the position of the tip according with the anatomy and the wiring, the successful wiring of the side branch. And finally, last option for desesperated cases, the balloon block and support technique is, in general, is not recommended, but can be used if you have no dual lumen catheter or even a smooth main vessel balloon predilation or a rotablation with a small burr in order to increase the lumen of the main vessel and facilitate the side branch wiring. On the contrary, active side branch protection consists in leaving a balloon at the side branch while implanting the stent at the main vessel. In the cartoon, you can see the stent at the main vessel, the balloon deflated, and if no compromise occurs, you remove the balloon and continue the provisional stenting in a normal way. If side branch compromise occurs, you have the possibility to inflate the balloon, producing some deformation in the proximal part. You correct with port and finish with a conventional kissing balloon. Some modifications of these techniques have been described, but none of them have demonstrated some advantage over the original technique. You can see the balloon kissing, inflation simultaneously. They modify that the balloon is placed distal to the proximal part of the balloon is at the level of the ostium of the side branch, semi-inflated in order to provide less deformation of the main vessel, or even use a penetrated microcatheter instead of a balloon. These two cartoons summarize the previous modification of the Yale balloon, the semi-inflated, can be seen in this slide. Minimal deformation pot, and in this case, you can continue normally with the provisional stent. Comparison between active versus conventional side branch protection has been done. This is a randomized study that demonstrates that side branch occlusion occurs less in case of active protection as compared with conventional, as compared with the single use of the Yale wire technique. But in terms of myocardial infarction, the study did not obtain significant difference. This meta-analysis summarizes all the published studies comparing active versus conventional protection.
Manuel, can you come to the main points?
Yes. So, and to finalize, side branch occlusion can occur despite all this situation, and in this case you can use the previously commented technique, but with small modifications. Reverse wire and dual Microcatheter are not so useful, and the pre-shape of the wire and the use of defectable or angulated microcatheter can be useful. This is final example of a case of the using the gel wire to pass a Corsair balloon after failing a low-profile balloon to finish the procedure with a second stent. So this presentation can be is summarized in the last consensus expert of the ABC published at the time of the PCR. Thank you for your attention.
So thank you very much, and this was very demonstrative and just tells us that we should have all these thoughts in mind and all the hardware also in the lab when we are treating such complex lesions. So thank you very much. I think we are already late in this session, so we can have some offline discussions and we move on to the next session. Thank you. Thank you.
We'll go to the next case. Actually, I just, because of me, there was a delay of 10 minutes. That is why Praveen told. Now we will be compensating in the afternoon where one speaker is not there. So we'll go to the live case directly. The chairpersons to the session are Dr. Manjunath CN, Devadatta Bhattacharya, Dr. D.B. Pagalajani, Dr. Julio, Dr. Selvamani S. If you are sleeping, just please come up. Srinivasa KH, Rajiv Rajput. And we have moderators like Florian Kukuli, Manoj Chopra, Abhijit Kulkarni, Rahul Arora, Dibiranjan Bahera, Gaurav Chaudhary, and panelists Prashant Dwivedi, Madhulkar HM, Manoj Kumar. Please go to the live. First live actually will be coming from Srinivas Kumar. It's actually, he is doing from Apollo Hospital. No advertisement, just go to the live. And the other from Star Hospital, Hyderabad. It will be done by Elvin Keti. So the first will be from Srinivas Kumar. Please.
Hello.
Yeah, good morning, Srinivas sir. Can you hear us?
Yeah, can I go ahead?
Yeah, we can hear you.
Yeah. Good morning, everybody. Dr. Manjunath sir and many other stalwarts there. Thank you, Pratap, for the opportunity to. Pratap has asked me to demonstrate a bifurcation stenting to all of you here. Before I go into the case, I would like to introduce our team members. To my right is Dr. Gokul Reddy, senior cardiologist. It's always great help to have another senior. And we always, as a policy, follow when you're doing multi-vessel PCI. After the thing is there, we always exchange. I do meetings, various other things. Without my colleague, Dr. Gokul Reddy, it wouldn't have been possible. Most of the patients work in the lab and all. He takes care. To my left is Dr. Ranga Reddy. I'm very fortunate to have a lot of youngsters, dynamic. And this case, incidentally, was Dr. Ranga Reddy's case. We had a few other cases, but we thought this would be an ideal case. I would tell you how we selected this. And then to my right is our senior and most talented sister Soumya, and the other technician Srinivas, Ramesh are all standing there. And we should be extremely thankful to Pratap for making another thing possible for me today. The most respected person in imaging, and for whom we have learned ABCD of imaging. We are honored to have Dr. Garimid sir there, and it's actually so comfortable working with him. Thank you, sir, for the opportunity. Again, it's a great honor for us to work with you. So with this introduction of our team, what I would like to briefly tell you is my colleague Dr. Ranga will present the case. Then we'll have initial angio pictures and then discuss about the case. Then in the process we were waiting because it got slightly delayed. We did imaging aspect of it, but we'll show you. Ranga, can you present the case today?
Yeah. Good afternoon, everyone. This gentleman is a 44-year-old gentleman who is a known case of diabetes mellitus for almost 6 years. He presented 6 weeks back with chest pain and shortness of breath. When he came, there are some inferior changes, regional motion abnormality is there. Then we took him for primary. There is a circumflex.
Next slide.
Next slide. So this is the initial ECG when he came on May 2nd. Next slide. This is the present ECG. Next slide. Next slide. Next slide. So this is the initial ECG, initial angiogram when he came that time. So you can see the LAD that time there is a bifurcation lesion with a big diagonal and LAD involvement, and circumflex there is 99% subtotal occlusion. As it is a culprit lesion, that time we did primary angioplasty. Next slide.
Next. RCA was okay.
RCA.
Next.
Next.
So that's the result after.
This is the post primary PCI result, and so we start off doing a staged PCI later for LAD and diagonal.
Yeah, I think I would like to mention some of you who are sitting in the audience and some colleagues also feel that if it is a triple vessel disease, LCX occlusion and the LAD diagonal being big, why some people think of sending him for surgery too. But as a policy, I would like to mention that in acute MI, always possible to avoid, if possible to avoid surgery, you should. And then probably in such a young patient, unfortunately in our country, this is a scenario. I was discussing with the Gary Mitz also here. 43 years plus gentleman gets into disease, but inferior MI that was effectively tackled and result is quite good. Now we come to see the present angiograms. I think, hope you are able to see the angio now, the present angio.
Yeah, we are seeing the angio. Can you show us the other views, please?
Yeah, we are going. This shows LAD diagonal bifurcation disease. Can you show them the other views? Next. So that is again a cranial view showing the disease is extending both into the LAD and diagonal. And the proximally, if you observe it carefully, can go back minus. If you observe it carefully, the LAD looks like proximally, it was actually going little deep into LCX. We had to pull it out because LAD looked like mild osteal disease. Then later there's a segment of normal segment there, and there's a tight disease at the LAD diagonal. Next, LAD diagonal bifurcation. So this view shows the bifurcation of both LAD diagonal best. As you understand, both are equally big size vessels, and then having a long segment disease in the diagonal, maybe disease about 20 mm or so, and the LAD also has a significant disease. So with this idea, we're waiting for you. We did imaging probably to decide the strategy and the size of the vessels. And probably at this, most of us, because the vessel sizes are big, you would think of, even with the presence of disease in the diagonal, you would think of a two-stent strategy. What technique we will follow, I think we can discuss. But any of you differ in following the two-stent strategy in this, or some of you might feel the provisional is okay. EBC2 and others showed that provisional is okay. But here, because the LA diagonal is too big and its disease segment is also about 18 to 20, that's how we thought we can do elective two-stent strategy in this.
Can you show the eleocranial view, please?
Next, I think eleocranial we'll show you. And then while taking other thing I wanted to tell you was, when we are taking images with OCT, we can save some contrast because at the time of OCT itself, you get angiographic pictures too. So with this, I think, show the next. We wired both LAD initially and then diagonal. Next. And then that's another method to follow. When there is LAD osteal damping, be careful not the guide to be getting sucked too deep into. And then this is what we are doing, a OCT of LAD. Then next, then we did a OCT into diagonal. And now we are very fortunate to have Gary Mitz, and we were discussing, he made it very clear, and he'll also explain to you all that once that imaging tells you what size of stent, what is the length, it becomes so easy for us to just execute that plan. So I request now Gary to comment, and please focus on sir, and then show the OCT pictures, please.
Right. So we're going to show you quickly the OCT. We're starting at what is a reasonable distal reference. You can see that there's some modest amount of plaque and it's all fibrotic. As we get more proximal, again, this is essentially a fibrotic lesion throughout its length, and not 100%, but for all practical purposes. So the MLA is about 1 square millimeter. Now we get more proximal, and then we're looking for a good proximal landing zone. We just passed the major diagonal, and we're now into the proximal LAD. So I'm going to stop. So here's the circumflex coming in at around 7 o'clock. The MLA at the ostium of the LAD is only 4.5. And then here is a good proximal landing zone for both the stent and for the pot balloon. So that's kind of really straightforward. The length is about 30-ish. The stent size is about 3. The pot balloon is about 3.5. The pot balloon length is 8 millimeters. And nothing to worry about in terms of calcium or lipid. So now let's pull up the diagonal. So no surprise angiographically, the diagonal is diffusely diseased. Now we're at a place of a secondary lesion distally that we'd like to avoid. So now we look for a proximal landing zone, a distal landing zone proximal to this secondary disease. Have I missed it? I probably missed it. Sorry. So here's the bifurcation with the LAD here. And we're going for a decent distal landing zone about here, okay? So that's about a 2.5, 2.75 of a length of about 20 millimeters. Again, no surprise in terms of plaque composition. It looks almost all fibrotic.
Thank you, sir. I think all of you heard it clearly that it's more a fibrotic lesion. And the tightest point, the other thing discussion was the tightest point in LAD, if you can show that, focus that, and then probably was 1 millimeter. And then it had a plaque all around it. Are you able to see the OCT screen now? That is the tightest point.
No, this is the diagonal tightest point.
No, we are not seeing the OCT screen now.
Okay, you believe us, again getting the LAD, but the tightest point, it was, to our surprise, it was just around snugly fitting around the catheter. Yeah. He is getting it for you.
And the diagonal wasn't much bigger.
Yeah.
Definitely diagonal is not much bigger.
A lot of advancement happened in the OCT. What other thing is that instead of reconstructing again a time, it should immediately come like an angio. I think now the freeze picture, are you able to see that? That's the tightest point. And then ostium of the LAD, there was some concern how much it is. We measured the area there, it is about 4.5 plus. So we don't want to touch and make it more complicated. So the little normal segment, we have about 3 mm away from the ostium in the LAD. From that's where we would like to end the proximal portions of the stent.
So
with this,
So a couple of points that, Gary, we would like to have you highlight is on the plaque distribution. You can see in the longitudinal view clearly on the opposite of flow divider and the carina. And tell us a little bit how you can use it, this information eventually, especially the carina.
So here is the carina. Here's the carina on the cross section. Here is the carina on the longitudinal section, and the plaque is opposite it. So the carina is almost always disease-free. That's a key point. And I'm not sure what else you want to mention, Julio. But Julio, what else do you want to mention besides the fact that the carina is free of disease?
So probably if the plaque is opposite side of the carina.
The plaque is always opposite the carina.
And there is a chance of occlusion of side branch is more when it is opposite or to...
Well, but it's 100% opposite.
Yeah.
So, the chance of occlusion is because you're moving the carina.
Yeah.
But they're right at the ostium of the side branch, there isn't that much disease right at the ostium.
Okay. Thank you. I hope all of you understood that. What is the plan now is we have something like 2.5 to 2.75-ish diagonal. Length is about, we got exactly 19. And then LAD is something like 3 and 28 to 30. So that is the plan. So we wanted to pre-dilate with a smaller size balloons. We have taken a 2 mm balloon. We are pre-dilating the LAD now. I feel it is always important to pre-dilate the bed and prepare it well. And the only precaution is you have to take care that you shouldn't be going into the areas where you don't stent it. You're not likely to cover by stent, obviously. It slipped back, so probably I'm taking it.
So what is the technique that you have decided that?
Why are you taking a 2 millimeter balloon when you know that the vessel is much bigger? You want to prepare the vessel.
The lesion is 1 mm. Lesion is 1 mm.
That doesn't matter. You should take a 3 millimeter balloon and prepare the lesion better, and preferably there should be a dissection before you stent it.
Yeah, but it's all fibrotic. There's not much of calcium. I thought if needed, we'll anyway post-dilate with a bigger size balloon. The only idea of now it is to see
Just dilate with a 3 millimeter balloon before you stent it.
We'll do the other dilatation with the diagonal also. Then we'll see. Diagonal dilatation. Go.
Diagonal wire is coming.
Pardon? This wire is little stickier. I will get that other wire and balloon out first. Anyway, we didn't show you the live. We'll do it.
Srinivas.
We didn't dilate the diagonal yet.
We will just go to the next lab and come back to you. Is it okay?
Whatever you
wire,
decide.
You can prepare it and keep it ready, sir. We'll come back to you.
No problem. No problem.
Okay, sir. You can go to the next lab.
Can you go to the case directly, please?
Katie, we are seeing you. Can you hear us?
Of course. We're hearing you from half an hour. We're waiting for you. Yeah. I'm Dr. Ramesh here, and Dr. Katie is there to help us with the case, and Dr. Srikanth, my colleague, is carved up along with me. Dr. Raju will present this case. Raju, can you please go ahead and present the case? Yeah.
Good afternoon. So we have a 58-year-old male, a hypertensive, diabetic, ex-smoker, COPD, presented with exertional angina class 2, which worsened for the last 2 weeks. His ECG was normal. Echo showed no regional wall motion abnormalities with normal LV function. TMT was positive for inducible ischemia. We have done an angiogram a few days back, which showed RCA injection showing a long segment mid to distal RCA, significant lesion. Then the left injection is showing a proximal LAD lesion, which is significant. Diagonal, which is a large side diagonal, osteoproximal significant lesion. There is another lesion in the distal LAD from mid to distal LAD. So to Dr. Ramesh for his comments.
So yes, this patient also has associated COPD and is a high surgical risk. So we're going to go ahead and do the angioplasty for this patient. Today we'll be demonstrating the LAD and the diagonal, that bifurcation lesion. Dr. Katie will be explaining.
I'd like to have your thoughts also about this.
Visual guys to fix your audio, your speaking voice, because there is a lot of vibration.
Okay. I will not touch anything anymore, actually. I will go to the OCT machine after, so I'm not touching this. Let's show the angio. It's a beautiful case of angio. I'd like to show and focus in 2-3 aspects. Now, you could not see very nicely the bifurcation from this position, but we're showing you this because you have also some disease in the distal LAD, or say mid-LAD. And there we have 2 focuses with very severe tight stenosis. And can we show the next picture? The next one? Well, here you have another projection. What is very interesting to see that also in this projection you see the same severe stenosis. So the stenosis in these 2 distal lesions, I say distal from the bifurcation is there. And then you see another thing here, and when you look to the bifurcation itself, already under it, and right under it, you see a haziness, and you see a patchy pattern on the feeling of that. Can I have the next slide, please? The next picture. When you see this, you see also in the proximal part of the bifurcation, you see also a little bump right over the bifurcation. Next. And here, it's a pity that the catheter is in front, but you see that the proximal part of the bifurcation, you also have some lesions that we're not sure if it was calcium or something else. So, can we go to the other projection that we have here on the reference? The second, yeah, here. Coming back to that, I'd like to throw the word now back because we were discussing here with Ramesh. Is this calcium calcified noduli? What do you do with them? And what would you do with them? So who from the panel thinks we should do something of atherotomy here? Dr. G, what do you think? Julia.
Well, I think that is the typical situation you can meet in India. Is a younger patient with multiple lesions, bifurcations. The proximal one has, depending upon the view. Let me say one thing. If you wanted to go to the zero contrast or low contrast volume, the most important is to get a nice angiographic view without too much overlap. And that is very important for everybody when we are taking multiple views. It seems that he has some, you say, the bump cavitation, so the diagonal is no marginal. So I think that is a younger patients that eventually can be also nicely grafted in the distal part. And so the point is, if we wanted to compete with the surgery, we needed to do the best that we can for the entire pathology. This is my personal view.
Yes, but the question is, we are now about to take a decision on how to tackle this, and we'll do let's say from these images that we have here on angiography, we would say, I'll maybe start, let's say, with a rotoblader. And we would say, I will dare taking a balloon and see what it does. Is Dr. Susana there?
So can you show us some intravascular imaging and then we can plan it? We can't hear you very well, that is the problem.
So tell us a little bit of the strategy, Katie, because we have some trouble in getting your voice clearly detected. So if you are starting detecting your strategy, perhaps we can interact much better with you.
No, that is even worse. That is worse.
You can take the mic. You can take the head.
Hello. Do you hear me?
You can take the top and you.
But please go ahead and show in your strategy, your decision.
Yeah. So, do you hear? Do they hear you? Yeah. Can you hear me? Hello. Hello. Can you hear me?
Lost them.
They don't have any contact. There's nobody with us.
Show us the case. We have to switch. Yeah,
Okay, let's do this way, Katie. We are going to switch back to the other lab. We are giving you 5 minutes for trying to solve the problem, and then we will be back to you with a clear understanding, if you agree. Okay?
Yes.
Okay, super. Let's switch back to the other lab.
Come on, guys.
Yeah, we are back with you, Dr. Srinivas.
Yeah, another thing I just wanted to highlight when you're, I think you just...
ask him to come in. Ask the other guys to come in.
There is no...
yeah, what I wanted to tell was because both were actually bigger size vessels, we wanted to follow two-stent strategy. And then what we have used here is another advantage of a slender sheath, 6-in-7 sheath. If you see the radial, we have used a 6-in-7. So outer diameter is 6, but inner is 7. So that's why you could take a 7 French guide with a reasonable ease. And then now what we did is we deployed the diagonal stent when you went off. Now we are crushing that diagonal with a balloon across. And
So what is the diameter of the diagonal stent? It is 2.75?
Yeah, 2.75.
Okay.
Can you go to yellow caudal?
And you're crushing with what diameter balloon?
Balloon is how much? 3 balloons.
Again, it should crush with a 3.5.
No, okay. Yeah. Give us a minute, just go.
Since your proximal LED is 3.5, you could probably use a 3.5 here, and that will provide a better crush.
Slipping back.
Anyway, you can go up to high pressures.
Because of the proximal disease, again, I'm being a little careful, Deva. Because I don't want to make it too big, because the proximal vessel, the mild disease. Actually, it's better to take a little longer balloon. Unfortunately,
the balloon is
12.
jumping around a bit.
If it is actually this unnecessary trouble, a balloon is creating.
That is because the balloon is of a smaller diameter.
I think this is fine. This is fine. I think we are now, other precaution we generally follow is to see whether it is moving freely in and out. Which one? I'm getting the stent thing out totally. And if you are okay, then probably because now you want to take the stent in, we don't want to crush the stent wire in between the two stents. Now, only thing is I'm trying to see it is going easily, and I also checked it before. How is the distal vessel, distal to diagonal? There is no dissection. Though it looks like slightly under, we might dilate it post later after leaving the edge. So now, because we want to follow the two-stent strategy to avoid the wire getting stuck, we might come out.
Take the diagonal wire out. I mean,
out. That's what I'm doing.
That is, it has no purpose there. Take it out.
So now, that is the diagonal.
There is some straining there in the LED near the crushed area. Do you want to just give a check and see?
Yeah, epicaudal. Yeah, we'll check just, Salva. We are just getting the balloon out, stent balloon out, and then we'll also, before we remove that, we'll check. This is small test and then we'll remove it. Yeah. Here I think because of stent being crushed, it gave that appearance. Yeah. Oh, there's a dissection there.
That is the point. That the contrast that was staining was clearly anticipating the fact that you have a huge dissection. And now we needed to understand exactly the extension of the dissection, perhaps without continuously injecting, but try to fix the point. So imaging might also be useful, but we needed to understand your strategy now.
No, but anyway, if it is dissected also, we would go ahead and stent the proximal vessel. That will be sealed off. Then I think we can study it and then decide. What do you think, will you? Do you agree?
Have you recrossed, or that's the jailed wire? Why you have to take that wire out?
No, that's what I'm saying. Before I take the wire out, do you want me to do anything, or otherwise I'm about to take the jailed wire out? Anyway, we'll cover that proximal portion of LED with the stent. Then we can decide.
Yeah, take the jailed wire out.
This is the diagonal LED, no? So I'm taking the jailed diagonal wire out. Okay?
Yeah.
lady. Come. Huh? Yeah, small test. Okay.
Yeah.
Then now we'll take, as planned, we'll take a 328 because I don't think dissection is so much proximal. But anyway, we thought we'll stent, take 330 stent. And then the dissection is fortunately just above the plane where we are anyway likely to cover with the stent. So we will take a 330 and stent the lady from the proximal segment to distal and then study it everything later. Yeah.
Can you cover the ostium? Because you can have the same problem at the proximal end of the stent, the LED stent. Just cover the ostium and then you can do a good post-dilatation.
But we wanted to avoid the ostium because first 3...
Yeah, but now you have a dissection and you will have to place the stent exactly.
The dissection is distal to the point of a little normal segment what we found. Still you can see there. Dissection is...
we can see and we have seen the OCT pictures as well.
The proximal to the dissection you have a little normal segment.
Just
take a LAO caudal, one picture for LAO.
I would stent the ostium.
The only thing is if you stent the ostium, it becomes more complicated than probably you
it won't. The circumflex ostium is quite okay.
No, but if it is required, we can do that. If it is required, we can do that. If we can get away with a normal segment in that, anyway, I'll take one LAO caudal picture for you. I think that's okay. We are the proximal to where we plan to have a stent, there's nothing there. I think we can, that branch also is going there. That's another giving a more horrible appearance in the caudal view there. In the LAO caudal, it looks reasonably okay. The diagonal is well stented. The ostium is covered well. Now we'll get a LED stent.
Okay. But you don't plan to leave a 3 millimeter stent in the proximal LED. You will post-dilate it with a 3.5.
We'll do that. We have a short pot balloon that the proximal segment measured 6 to 8 mm. So we have a 6 mm balloon which we can do proximal pot with a 3.5 balloon. Okay?
So my personal opinion is we are facing a situation where we were starting with a bifurcation with the two big branches. Now we have some trouble. We needed to understand, we got already the measurements, we needed to understand a little bit better the trouble. So I think that if you needed to understand and you have already the imaging available, this is the case where I will go in the main vessel, I try to get a precise understanding of the situation, and then I will go ahead with the planning, if you agree. If you think that is too risky because you have a dissection, but the section is not coming back too much.
They're wanting to image again. This is up to you. Yeah. What do you feel? I think it's reasonably okay. No? With too much injections, we want to seal the dissection first before.
I mean, go ahead. Yeah. So you're hearing two viewpoints. And I don't think it's an absolute right or wrong answer. I think Giulio's approach is totally reasonable, mostly to understand the extent of the dissection. But Srinivas's approach is also quite reasonable. And I don't think there's an absolute right or wrong answer. I think people need to do what they are most comfortable doing.
Don't force the stent. You have to crush that stent better.
Yeah, and that's the other problem.
Absolutely. Now you've got... Because balloon was also skipping, and as you said, it was 3. Probably I was worried with the dissection, but we are forced to again.
No. You have to crush it better. The stent won't go.
Because the balloon crossed easily. I did check before removing it. But don't pull. Yet we'll do with the NC balloon, crushing now.
Is it a plan for the decay crush? In which case you should have do the kiss first before you put the stent, isn't it?
Yes, there is a dissection, so that part is not being done.
So we are changing to a crush.
Yes.
Get the NC balloon, please, the little bigger size. Don't pull them out. Sorry? Yeah, initially we thought we'd do a kiss here.
So there is a question from the audience that have you changed your plan? So yes, we have.
Yes, you answered
because
that.
There is a dissection.
Yeah. That I think a slipping part of the balloon created a little trouble. I think ideally we should have taken a little bigger size balloon and gave one inflation at one go. I think that would have helped, but anyway, life is different. We are getting a bigger size NC balloon to crush it better.
And which type of balloon are you taking? Which size now?
How much is NC balloon size now, what you're taking? 315, little longer length, and NC.
We are talking about a non-compliant. We have a dissection to deal with also.
Yeah, that's another worry. That's why we are not increasing the size of the balloon. We want to keep it little distal and then crush the stent alone if possible. But NC balloons also sometimes create trouble while going in.
If you stent the main vessel without doing the first kiss for the side branch, and if you stent the main vessel, what are the chances of accessing the side branch with a crushed stent which has not been opened with the first kiss? Because you may not be able to access the side branch after you put a stent in the main vessel.
So you want us to wire it and do kissing, then go. That is ideal.
Yeah,
but anyway, if a dissection is not creating much trouble, we could do that.
Yeah, the wiring in a dissected segment is distinctly very challenging, but I would prefer, if I am the operator, that I would go with a double lumen catheter down into the LED, deliver the second wire, so you don't know because you already have a wire in the main vessel, and then remove the double lumen catheter, withdraw the second wire, and then try to access so that you are certain that you are in the true lumen.
Yeah. I mean, that is an alternative approach. Thank you. So, can you alter the alignment of your guide catheter a bit, and then the balloon might slip through? So
NC balloons, I think, has a different.
There is a little bit of wire bias there, I think, towards that stent. So if you just try to fiddle with that alignment of your guide catheter a little bit, and the balloon
I
might
lifted
just
it little, but I feel this NC balloon sometimes have shoulders and sometimes it just touch and create trouble. I want to dilate with a regular balloon first and make more passage. And this is what is the life. I am sorry that we are not able to show correctly.
Yeah, show us the epicaudal view, and then we will have a better understanding how to realign the catheter.
Epicaudal. చిన్న balloon ఇచ్చింది మనం.
Yeah. Now you will be, I think you should be able to understand better how to just
No, we wanted to avoid
in or go out with your catheter. You just want to just alter that guide wire position a little bit, and your balloon might slip in. What balloon is this now? No, this is not working.
I changed it now, as you said. Now it went.
There.
Okay?
Yeah.
Go eleocaudal.
Go to epicranial or eleocaudal, yeah.
Because I don't want to come too proximal, because that dissection part, again, should not extend proximally.
This is a 3.5, right?
No, the same balloon which
Oh, same, okay.
Yeah. Because the other balloon was not going, I am putting it distally now. Yeah, I think now it's okay. Go high pressure.
Crush it.
Okay, deflate.
Hopefully, yeah, it is.
So this balloon goes quite okay. If you see that?
Yeah.
It goes quite easily. So now I'll take the NC balloon and dilate it. If you want to go to our lab and come back, it's fine. I'll dilate the NC balloon, take the stent in, and show you.
No, we
final
want to see. You just take your NC balloon. We'll see how it goes through.
Yeah, get the NC balloon. Is it ready?
Yeah. Go to the other lab. Yeah. No, let's just stay a few minutes because that is quite challenging.
That staining part is actually the crushed stent, I think. No, it's actually looking again the same way here in this caudal view. Come to epicaudal again. MC balloon. I'm wanting to, other thing is, if ostium was not much of disease, guide could be taken a little more deeper, but I'm a little worried here about osteal disease also. That's why I'm a little being careful about the guide. See that? Go eleocaudal again. But it's very important for NC balloon to go, otherwise stent will not go. Stent is getting crushed then. Just push it. Come to epicaudal again. I think we need to create a little more space there. That is why I think stent is also, it looks like it is getting moved from that part.
Instead of going in, pull your guide catheter out of it, make the guide catheter the more coaxial. Yeah.
No, I did try that.
And now try.
Yeah.
There.
Okay. Okay, 1 minute. I don't want to come too much. Yeah, small test. I don't want to come too much proximal. I'm just taking Kriya. Okay, now go. Exactly at the point of dissection. But I'm worried about increasing dissection. But however, I think now it's okay. Keep the stent ready so that, okay.
It was a very nice demonstration how much the position of the guiding catheter might have impact when you are dealing with this situation. We wanted to stay strategy.
Just make it, it will become coaxial and the balloon will cross. You just
the same way which it went,
have to be just a little patient. That it is not coaxial yet.
You want me to get it out?
Yeah, maybe, no.
Okay.
You had it when you crossed it.
No, go hello, Cardo.
So eventually,
okay. No, I think you just rotated clockwise.
I think a little stent got projected a little more than what we thought. We were a little over enthusiastic not to miss out the diagonal ostium. That's why I think it's creating little trouble. And more portion of the stent to be crushed. So it is leading to trouble. You see that when I move it, the proximal portion of the stent appears that it is moving.
Try a different approach.
With size and new balloons.
Yeah, probably. I mean, this deflated balloon is causing you trouble.
Causing trouble. I'll take another balloon.
Okay, we are leaving you working in peace, and we are switching possibly to the other cath labs. And then you will update us on the step-by-step approach.
I will show you all the steps and what all we did and show you the final result.
Let's go back to the other cath labs. Okay, Katie, you are live.
Do you hear us now?
Please, can you hear us?
Yes, we hear you. Do you
Erwin.
hear us? Do you hear us?
Yes, a little bit better. Damp, but a little bit better, without echo. Okay, so go ahead, please.
So we show you again where we started. We had two distal lesions that looked pretty tight and probably very calcified. So we were thinking what to do with these lesions. Either should we then rotablate beforehand or not. So we took the decision, of course, to do imaging. But to do imaging there, you need to predilate a little bit. So that's what we did, to predilate to 1.5 balloon, and then we did the imaging. Can we show them the distal part of the LAD on OCT?
Can we?
That was a 2 millimeter balloon.
Yeah, it's a 2 millimeter balloon, sir. It's
Okay.
212 balloon.
Go ahead.
So that's where we start. Distally looks like not so big, but do you see the OCT images?
No yet. We are still watching the angio. Now the OCT is coming. The OCT is coming, okay? If you want to comment distally, this is the crack.
All right.
Dissection
Can
distally.
you take off the upper part?
Two things. There is some bigger protrusion around the noon. And then, okay, if you are going back, nice
That's
view,
where we
some
dilated the
dissection.
distal part.
Okay.
You see that it's mostly a mix of lipids. I don't see super much of calcium there. We
Some
come back.
calcium upstairs, but it's okay.
Not much.
Okay.
Yeah, go back, come back. I mean, here we're coming to what we saw as there's a septal branch coming in, and here we come very close to what that nucleus of calcium that we thought. You could see here calcification coming in.
Calcification, yes.
So, and then can you stop here, please, and find that nucleus where we found some. Yeah, can you scroll that, please? Okay, I'll do that.
Kevin,
Wait a
what is very interesting is really not a uniform involvement of the vessel, but they are multifocal lesion. In
exactly.
Between,
So
you can
here
see
you could see
clearly.
some more calcium here. Here at, let's say, 11, 10 o'clock, a little bit more.
Can you scroll down a little bit, and Giulio, can you tell us about this appearance here? What is the, bit down, bit down.
Okay, what I was doing is watching to the longitudinal view, where you have a lesion, and then you have a big normal segment, and then you have again a lesion, likewise this one, and then you have again a big segment. So it's in a diabetic patients, it's not a uniformly diffuse disease, but it's a multifocal disease. Here you have a calcification.
Here you have some calcification, yes.
Clearly.
And here, but it has been erupted from the balloon. And here you have some more big calcification. That's the largest part, but it's actually not over a long, say, angle. It's only in this part here. So would you think that based on this, you're going to need some more form of atherectomy? Because you can see here is the maximum calcium.
Okay, let's just stay this way, Herwin. Let's just stay this way for a second. So for in all cases, when you have a normal segment like we have from 2 to 4, and you are going dilating, pre-dilating, and you have a calcium, you are making this a crack or dissection or fracture at the interface between the heart tissue and the segment that you can see. That is the point. But you are not removing calcium, and the remaining is the remaining segments is still plenty of some calcified tissue. Here you can see the proximal edge of the dissection. Once again, you are going a little bit more distally, just a little bit, and you still have a lot of calcification. So the dissection plane is only from 3 to 5. For the remaining, the plaque is still there. So you needed to be a little bit more aggressive, and you saw also in the balloon that when you was dilating with the undersized balloon, you still have the imprint of the balloon. So you needed to be more aggressive on this lesion. You have a marginal segment that has a dissection, okay? That is my personal opinion.
Yes, I mean, what he is asking is, does he need to do calcium modification by rotablation or something like that? But here, I think balloon dilatation should help.
Or bigger balloon, or making incision, making cutting, Wolverine, what you want.
The only thing that we see here is that part of calcium that extends mostly from here to here. The calcifications we see further on.
Well, you can see also in the upper part.
Here is the most, that's the only part where you have some more calcification. If you look to this, they are not more than 2-3 millimeters. Less than 0.3 millimeters, I think, not more than that. So, in my opinion, it was more dealable with a non-cutting balloon, and having atherectomy here or IVL would have been a bit of an overshoot. That's my opinion.
Okay, let's move on. Let's go to the proximal part, because there is a big portion of the discussion that is in the proximal branch. Once again, normal segment, a big one, you can see clearly. Multifocal
Here you have
disease.
some more calcification, but nothing much.
Okay.
Doesn't matter.
And here,
there is a
bifurcation.
Because here we need to show you the other view. The other run is better to understand it. That's the second run, because we run out of length there. So it's loading. Here we start more or less recording where we stopped before. So we pass these parts.
And you can see longer carina. If you look to the longitudinal view.
Exactly, you took my point. You can see a long carina. And then just after that, just when it goes in, you see a very nice plaque rupture that continues.
So very important. When you have this short distance, watch to the longitudinal view between the takeoff of the branch and the tip of the carina. You are going to push this carina toward the vessel, so you must protect this vessel before.
Exactly, but it becomes even more important because we thought on angiographic view that we could actually land in the proximal part of the LAD, but this segment of, you see this hematoma that comes from the plaque here, you see this plaque rupture segment continues till the ostium of the left main, and actually if we look it into another view here,
so
where you see the
part of the left main. Can you show the circle?
Here,
okay.
Here, you can see it here. So you cannot, in my opinion, come on and land here because it's also very lipidic segment, And if we continue here, the vessel becomes, let's say, landable here. So we had to take two decisions. Go and end up with a stent here, ostially, or because this circumflex looks pretty healthy, at least ostially, come and bring the stent till here and then eventually open the struts of the circumflex.
Very clear point. So the left main is, I would say, marginally involved by the pathology with a wide lumen. But in this lesion preparation, we had some, I would say, the small touching of the distal part of the left main that is wide. And so you wanted to know what to do. And so we would like to know if we needed to land at the ostial. Can you go really to the ostial, a couple of millimeters down?
Here.
Again a little bit. And you can see this type of, I would say,
where the plaque,
fissure.
the ruptured plaque ends. Here ends the ruptured plaque that we had.
Okay,
previously.
Rupture fissure is going back, but for a short, I would say, the segment, and with a marginal involvement of the circumference. Can we go around quickly and ask for the opinion? Dr. Selvamani, what do you want to do?
Yeah, actually, there is a ruptured plaque very near the ostium of the LAD, and then probably this is a case like we can do a crossover from the left main into the LAD. And the angle between the LAD and circumflex is very favorable.
Excellent
Circumflex
point.
is clearly healthy. And I think even the disparity is not very much. And probably crossover should be a good option here. And your opinion, Dr. Srinivas?
Yeah, I think crossing over to the left main is the better strategy.
Okay, crossover.
Yes, crossover to the left.
Okay, everybody say crossover. And Hervin, so I have a
That's also
making
our
sign,
opinion.
incredible sign that we needed to stop this conversation. So we are leaving you.
One more point before we go. Who's
Yes,
going to
sir.
start the LAD? Because we did the FFR of the LAD, because I know you're going to ask for it. And it was diagonal, the diagonal. And to choose a type of it, it was, the RFR was negative, was 0.94 if I don't, or 93, and the FFR was 0.81. And so, who's going to stent it and who's not going to stent it? I'm a partisan of stenting it. First of all, because of this long carina, if you crush it, also the FFR will be positive, and it has disease all over the way. So I'll go for a DK crush. Who is with me in this situation? Who will respect the FFR and who will say, we have more information here. We are going to actually go through a vulnerable plaque that has just ruptures, is full of lipid still all surrounded. We have a long carina, and the FFR is 0.81 now. So with that carina shifts further, we're going to go also on an FFR on an ischemic LAD. Who's for and who's against stenting it? And who says let's do eventually a provisional? The provisional you cannot do because the angle is not so favorable.
Okay,
But you can always do a balloon.
Erwin, very quickly, let's ask to the audience, who want to go with the DK crush? Please stand your hands. 10, 20%. Who don't want to go and leave a provisional? Stand your hands. No one, very few. So I think that the vast majority is for DK crush treating. And so you have a huge amount of work. So
yes,
in
well, waiting for you, we did it, see, because
Okay.
that was our strategy. But let us finish it, and you go back to the other lab eventually, and give us 5 minutes, and we're finished here.
Okay, good. Very good. Let's switch back quickly to the other lab to see the situation. And good luck for the work that you have to do in preparation and going back to the left main. Can we go back quickly to the previous lab?
Yes.
To the other lab? Can we switch, please, IT? Can we go back and see the situation in the other lab? Okay, please, you are live. Can you tell us what you did and where we are?
You have stented it?
Yeah, yeah.
Very good.
Give me 1 minute. Yeah, okay. What we did is you show them from where we left.
Short time, you needed to go quickly.
Yeah, yeah. Can you show the previous tips, not this?
So go back a little bit when we were stuck with the balloon. Go back,
Yeah,
back.
go back, go back, back.
We wanted to understand how did you solve the problem. Go
Yeah,
back
we'll let
a
you
little
know.
bit.
Minus.
Okay, guideliner,
Minus.
you can recognize the guideliner.
No,
Okay.
no, but I wanted to, because we were getting alienation was helping, the balloon dilatation we did it again with a bigger size balloon. See that? I did it, but still the stent was getting stuck. Then I thought it is also the problem of angulation and how the guide, and exactly if you see in the caudal view, exactly at the bend point when it is curving like this, that is the lesion there. So I thought probably if you tied over that, this is again further crush. Distally also we crushed and proximally, but still it was not helping. So next. So see that balloon goes so easily. Next. But next. Then that's point where I took first initially I thought without going across because it might injure the studs, I kept the guideliner just there, but still it won't go. So then the only chance which I left was I took the guideliner distal to the stent and then it becomes easy to deploy it. Then we brought the guideliner back. Next. And we checked once distally whether it is covered well. We have taken little 2 mm extra, that's no problem, that's why. Next. But proximally we wanted to make sure that we are covering the dissection. Because actually people, somebody said you have to cover right from the ostium, but at least I wanted to cover the dissection well. So we did take it and we took enough care to cover the dissection well, at the same time not coming to too much. And then
Just the size of the stent was?
Size of the stent, what we decided was 328 to 30. We have taken a 328 here.
Okay.
Right? And then we inflated the stent. Then
No, it looks bigger. It looks like 38.
no, 30.
30.
Okay. We'll take a picture for you now to show because that's where you came back. So distally, both of the things are good. Proximally epicaudal, the dissection seems to be sealed well here. Seen minus?
The section
Epicaudal.
seems sealed nicely. And then
Yes.
tell us a little bit of the next strategy. What you are preparing to do.
Yeah, just take a picture, see that sealed is well. That's sealed well. Now the strategy is to rewire and then do a kiss and then do a final imaging and come out.
You do not plan to recross into the diagonal?
Yeah, I do that. That's what I'm saying. Otherwise,
Oh,
how will I do-
okay. Sorry.
I will cross it, then probably do a kiss, then final imaging, and then come out.
Okay, so it seems that
Part
you
of
still have
the-
3 minutes to go. If you can
the
go
proximal
ahead.
portion also finally I think we'll do with the part with the short part balloon which we have now with less of shoulders. Then now I'm taking the diagonal wire in to rewire it. And then probably initially to cross the 2 struts of stents, probably we need to take a low profile 2 mm balloon to make some air go into the struts. Then I think we'll take an optimal size balloon and then
So I would just like to ask, what was the reason behind so much of trouble getting was the stent little too much into LED?
it could be, but also the angulation also. See that angulation in caudal, exactly at the point of bend, the lesion as well as stent ending both were there. That's why I think changing the direction as well as with the guideliner both helped.
Okay, in short of time, we wanted to see your working and to get the access to the diagonal branch.
Yeah,
And,
we will do that and then we'll do a kissing and finally show you the picture. If time permits, 5 minutes, if you can come back later after the lecture or something, then probably we'll show you.
So 1.5 minutes. And
Oh.
then,
Can you show
we
us?
needed to
Can
leave
you cross it in 1.5 minutes, Srinivas?
Let's hope so.
Because we have 1.5 minutes left. 1.2 minutes left. That's Dr. Pratap Kumar. He has taken 10 minutes extra though.
Only NIC chair can take it. We can't take it. Now the issue of a proximal stud crossing, distal crossing, all that is good, but I feel it becomes less important when you're following a two-stent strategy. It is very important if you're following a provisional stent strategy where you cross distally and then probably
try a little lower maybe. Try a little lower.
Okay.
Exactly. Go to the LAD if you can, and then pull back and see.
That's what we're trying.
So, anyway, I think that...
Come back. JP Corder. No, idea is we want to go into the LAD, and then while coming back, we would like to go there because that is the more definite way.
Okay.
Now I went into LAD.
Now you switch the projection, go to the elaeocranial, and then let's see if in the last 25 seconds we can get access, and then you will tell us the story later on.
Yes.
So anyway...
So, I am coming back little in this time of situations when this is a regular run-through wire which we're using, but if that doesn't go, then BMW Elite, which has a angulation at the tip, will help in it, right?
2 minutes?
Now I think I am able to enter it, but it is getting slightly stuck there.
There. You have done it. Congratulations.
Come on.
Before
that is normal. When you are under pressure and you say that you do not have any more time, the wire is going down.
But
so
always,
thank you very much. We wanted to stay with you
and
for much more time.
Give me 1 minute. 1 minute. Can you show me the last slide, please? Thank you again. What we wanted to demonstrate in this is a young patient presenting with acute MI. We said no surgery, then I lead LAD diagonal bifurcation, two-stent strategy. I think we used imaging. Gary made our life very easy, telling exactly what stent sizes, and they deployed it. And now, sometimes, obviously, you should be prepared for this unusual things. Then we took a guideliner and did it. And then finally, why did we do a bifurcation kiss and then proximal part and then image and come out? I'll show you later. Can you show the last slide, please? Show the slides, last slide.
Are you happy with the Austrian?
Yeah. This is
I wanted to an intervention.
Okay.
Hope you are able to see the TCT India picture slide there. I request all of you to join there, and we will have many more things. Pratap and everybody and the international faculty. Everybody will be there. First day will be structural, and then will be conversation.
Thank you very much. We saw that many times the imaging is not always solving the problems that we can meet in the cath lab. Is a mixture of information, quality, and the techniques and background. Thank you very much for staying with us and for sharing this interesting case. And good luck for the remaining part of the work. And you will tell us tonight. Thank you.
Okay.
Thank you very much, Pratap.
Thank you, Dr. Giulio. He was actually following the rules of the organization. Thank you very much once again. Actually, we will go to the Abbott Vascular Precision PCI program. I think, again, Julia will definitely be there. Dr. Ashok Seth, Dr. P.C. Rath, Dr. Sridhar Kasturi, Dr. V.K. Bahal, Dr. P.K. Goyal, Dr. P.K. Sahu. I don't know if anybody I can see, but then Julio can sit in the chair itself. Continue. Dr. Balbir Singh and Dr. Takashi Akasaka. The first speaker will be Darshan Doshi. If he is available, just go. Balbir, actually, please come. Darshan Doshi, then Flooring Kukuli. Darshan is not there. Okay. Today morning you were not there in the live guest hearing, you know. You committed something and you also become like an Indian, huh? Please, first.
So without wasting any further time, we are into this Abbott Symposium, which is imaging and physiology. And first speaker is Darshan Doshi, a good friend, and really very experienced with physiology. So we'd love to hear him speak on real-world experience with FFR, some of his own data.
All right, thank you so much for having me. I was asked to talk about real-world experience with FFR. And so I think it's really hard to talk about FFR without talking about the non-hyperemic pressure ratios. So I'm going to be talking about both of them through physiology. So these are my quick disclosures, mainly that Abbott was kind enough to support me to be here. So what we know about the coronary circulation is that the angiogram only shows about 5% of the actual coronary tree. The vast majority is not seen because it resides in the microcirculation. So angiography as a whole does a poor job of actually delineating the true extent of disease that a patient can have. So there's certain things about the coronary tree that are important to know because our foundation on how we do our invasive physiology is predicated on the fact that pressure is consistent or should be consistent throughout the entire coronary tree. So as we know, as the vessel begins to gradually taper, the diameter gets smaller and smaller. At the same time, the cross-sectional area obviously gets smaller as well. But the resistance actually goes up while flow goes down. So the relationship between flow and resistance allows pressure to be exactly the same through and through. Now, if you have a stenosis, what happens is that the flow is altered such that the pressure is now different in the distal portion of the vessel compared to the proximal portion of that vessel. So we can do a ratio looking at the pressure proximally to distally and then subsequently get our fractional flow reserve. Now, the issue with fractional flow reserve is that you really need to make sure that the vessel is maximally vasodilated. So you give a hyperemic agent. So adenosine is the most commonly used agent. As we know, it's given both IV and IC. There are issues to IC compared to IV, but there's also benefits. But nevertheless, a lot of the actual flow is contingent, the FFR amount is contingent upon the size of perfusion. So if you have a large amount of myocardium that's being supplied by a vessel, a stenosis will most likely potentially be positive. But if the part being supplied has some dead tissue or is very small, specifically distal in the actual vessel, then it's possible that the FFR may be negative or borderline. Now, the other part about FFR is that it actually accounts for collateral circulation. So if you have poorly developed collaterals, the FFR can be positive, but once there's much better collateralization, the FFR can be negative, okay? So the validation of FFR really comes from the FAME trial, FAME 1 and FAME 2. So FAME 1 basically found that if you use FFR-guided PCI in a randomized fashion compared to angiography alone, that you actually had an improvement in survival from MACE. And then FAME 2, what it looked at is it looked at patients in whom all stenosis had an FFR of more than 0.8, were entered into a registry and received the best available medical therapy. And then those that had less, 0.8 or less were treated, compared to those that just were treated with medical therapy, and found that there was a marked reduction in MACE rates. Now, if you look at the totality of data for FFR, not just from the FAME studies, what it shows is that you have a decrease in cardiac death or MI, cardiac death or MI, all-cause death or MI, and particularly MI. So the difference that you derive, the benefit that's derived from FFR is really from MI. It's not cardiac death necessarily, that hasn't been borne out in the literature, nor all-cause mortality. So it's actually MI, both spontaneous MIs that you prevent by treating when it's appropriate, and periprocedural MIs that you defer by not treating. Now, with the use of FFR, you have to use a hyperemic agent, and the problem with hyperemic agents are manyfold. But since then, we've now developed a way of looking at a specific portion of diastole called the wave-free period. And what we can do is not have to give a hyperemic agent and still get our pressure assessments, both distally and proximally, and use that to figure out whether or not a patient should be treated. So Philips was responsible for the first non-hyperemic pressure ratio, IFR. And so again, it looks at a portion during the wave-free period and during diastole to calculate this. And no hyperemic agent is needed because it's during diastole, so the vessel should be maximally dilated, and the resistance should be naturally constant. Now, the data around this, so there's fairly robust clinical data, both from the defined flare and the sweetheart studies. So nearly 4,500 patients have been randomized in these trials. And when you compared FFR to IFR, there was no statistical significance in terms of outcomes. So they're fairly similar. The other part are the limitations of FFR compared to the non-hyperemic pressure ratios. So we know that when we give adenosine and other vasodilators, patients can have profound discomfort. They can feel flushing, they can feel like the world is ending essentially. Moreover, it requires time to give these medications, wait for the non-hyperemic pressure ratios to help decide. The other difference between FFR and IFR is in terms of crosstalk. So if you have two lesions that are tandem, what happens is that the first lesion, the one that's closest, is actually underestimated, and the one that's distal is overestimated. But if you use the non-hyperemic pressure ratios, because there's diffuse atheroma. Whereas here, you have a big pressure loss at a focal area. So the pullback on the right would be well treated with a single stent, whereas the pullback on the left most likely would be better treated with a LEMA if this was an LAD. Now, the other thing that you need to know is that while you can use invasive physiology to determine whether we need to treat or not and where to treat, you can also figure out if you did a good job with your stenting procedure. So from Defined PCI, what they found was that if we did a IFR at the end of the PCI, approximately 1 in 4 patients left with residual ischemia that was still in the positive threshold. And the part that's even more interesting is that nearly 80% of those patients, all you needed to do was do a bigger balloon inflation or just put a second stent in. So I'll stop there in the interest of time. Again, physiology really helps determine whether we need to treat or not, how to treat, and if we've done a great job. And the non-hyperemic pressure indices may provide some additional benefits over traditional FFR. Thank you so much.
Thank you, Darshan, for a wonderful presentation. Just really loved it. So I have one question to you. Suppose you have serial lesions and the proximal lesion is very tight. So there's a pressure drop between the proximal segment and the mid segment. So the pressure is already low. To pick up the distal pullback on the pullback, so you have a very low gradient. Suppose the pressure is 100 and now the pressure drop goes to 60 in the mid part. Now you have very little avenue for another pressure drop on the second lesion. So won't you like to stent the first one and then come back to look at the second one?
Yeah, but, so again, if you look at the data and the people that are more comfortable or very knowledgeable with the non-hyperemic pressure ratio state that there really is no crosstalk between the two lesions. So if you use FFR, then the answer is yes. You probably need to treat the proximal to figure out how severe the second one is. And usually what ends up happening is that the proximal is underestimated, whereas the distal is overestimated. But if you use the non-hyperemic pressure ratios, it should not make any difference.
Yeah, Professor.
Yes, as you said, there are advantages and disadvantages of non-hyperemic pressure ratio.
And it's fairly controversial
how to differentiate to use in your daily clinical practice?
Yeah, so my daily practice, the way I do it is, so technically FFR is the gold standard, and the non-hyperemic pressure ratios can be utilized. And so the way I use it is if the non-hyperemic ratio is definitively positive or negative, so, and it's not in the gray zone, so if it's not 0.87 to 0.93, and I know it's very positive or very negative, then I go with that value and use that. If it's within that gray zone, so if you looked at the Syntax 2 trial, it necessitated that you would potentially use FFR at that time and use that as the final arbiter of whether it's positive or not.
So thank you, Darshan. You could join us on
Yeah,
this.
not a
If there are
problem.
more
Glad to do it.
questions we could take on. So we go back to the lab. Yeah. So Elvin, can we connect to you? Yeah, so we have Elvin there.
Yes. Hello.
Elvin, can you hear us?
Yes. Can you show the previous picture?
Elvin, can you hear us?
Yes, we hear you perfectly. Do you hear us?
We can't hear you properly.
Hello, guys. They don't hear us.
Yeah, no,
now we can hear you.
Okay, yes.
Hello, you hear us now?
Hello, hello.
Yes,
Do you hear us?
Yes, we can hear you.
Oh, great. So basically what we did is, based on the OCT, we decided to put 2 stents because the length was not so good. And was not enough for just 1 stent, so we needed to stent over 60 millimeters, 62 millimeters exactly. We looked to the distal reference diameter on the best landing area. We looked to the proximal diameter. So we choose for 2.75 distally and up to 4, and we needed a 4.5, 4.2 actually proximally. We did the decay crash, so we did the measurements on the diagonal, all based on OCT without actually doing much of a contrast. And actually everything is done now. The decay crash procedure is finished. We did a double pot for the LED part, pot for the left main. We have not done anything on the osseum of the circumflex because after a pot, most of the time you probably don't need to do much because there are not a lot of struts left, but we're going to check that. We are about to do a control OCT. As said, that problem of that noduli of calcium is bothering us a little bit, but I don't think that we would have done, because it's only in one part, and that is because there is this nucleus there of calcium, and I don't think that either rotablator or something else, IVL, would have just moved that nucleus, because it's just in one side, it's like a focal thing, and it's basically, we'll see that now on the OCT.
So,
you could tell me.
Can you show us the last picture, because we have to move, we are very short of time.
Show him a last picture, go a bit more, yeah. One more picture. Next. Almost the last picture. Come on. Yes, show this. So you see that there is some under deployment where that nucleus of calcium is. Next, please. And here we are, previous one. Okay, we can do one now for you. All right. So you could see that stays a bit of an issue, but for the rest, the bifurcation and all the rest of it is pretty nice. Now we'll deal to the distal part, but it's only that focal thing that I don't think that we can do much of that nucleus and whatever we could do. All the rest of it is pretty much opened.
Okay. Thank you, Elvin. We have to move to the other lab. Thank you very much for that excellent case. And okay,
a large amount of lipid is associated
so we switch to the other lab.
Okay, you have 30 seconds to try to sum up the situation, because we wanted to update people.
A large amount of lipid.
Are you seeing us?
Yes,
Dr. Srinivas Kumar
yes,
here, huh? Yeah, what we did after we left is next, the crossing stage.
Stent can be associated with.
Crossing stage, can you go to next?
These are not.
Before, minus.
There's no randomized
Minus,
trial. These are just
minus
lots of people.
the point where we crossed it. First balloon?
Sometimes
yeah.
it's useful in,
so what we did is after we crossed where you left, I took a most lowest profile region plus balloon to open the strut a little, because directly taking 2 mm would be a trouble.
Okay, go ahead.
Then we took a little bigger size balloon, next. Then afterwards, then this is the optimal size 2.75 balloon, which we wanted to use for KISS, and the 3 in LED, 2.75 there, next. We were very careful to be having within the proximal portion of the LED stent, because we were always worried not to get into. Next. And that is a good KISS finally we got. Next, Eleocorda. And I think all of you appreciate that now kissing is done well. Now in the process of doing a pot balloon, and then finally after doing a pot, we'll image and then come out.
Could you take a last shot and show us before the pot so that we can go on to the next talk here?
Okay. I'll show them this one shot.
Okay, Dr. Kukuli is warming up the engine while we... Okay, if you can show a last picture.
Yeah, we're just coming out with the balloon. And because the contrast may not fill up well with the balloon shafts, both of them, I'm coming out of the balloon and I'll take a picture. Okay. I'll show them once. We'll give some nitro.
Okay, let's take this view.
Yeah. Cranial.
Okay, great. I think everybody was following you in this sum up. We thank you very much.
We'll show you one final cranial picture too. Okay, I think both of them, the kissing part, they opened up well, but I would like to do a part and then do OCT finally.
Okay.
Thank you again for the opportunity.
Thank you very much for this case, and we are coming back to Professor.
Yes. So let's move on to the next talk entitled Deciphering the Role of Stent Design and Polymer for Long-Term Outcome. Dr. Florian Kukuri.
Thank you very much. Thank you very much for the invitation. And just for Dr. Pratap, I will make it in 7 minutes. At 3 minutes, I will save. So, as you know, stents nowadays are fine. We are a lot of stents. And the question is, why maybe choose one over the other? And for example, I have only one stent in my lab. In my lab, it's the science, and now I'll try to demonstrate why you actually use just one stent, and then you're usually fine. So there's different topics we need to cover. First, we need to realize that stents are not perfect nowadays. So the results with stents are not perfect in the long term. Very often, we are very pleased with short-term results, but in the long term, we see that we still have continuous event in our patients. And there is room for improvement, and there is, of course, high-risk categories like diabetes, where we really have to do more work to understand why and how to improve it. And there is, of course, the issue of neoatherosclerosis, which is an issue we have not resolved yet. Now, I think if you look at the drug-eluting stents, you have different components, and it's really important to try to please all these components in a way that we have good short and long-term results. So it's the drug, it's the coating technology, it's the stent itself, and it's the delivery system, because at the end you have to be able to deliver the stent. So to bring this all in a harmony can sometimes be very challenging. However, you can see that different companies have gone different ways in order to achieve this, and they have all had their reasons why to do it. So on the left side, you see the science, where we have an 81 micrometer strut thickness. We have a PVDF polymer, and on the other side, you see Orsiro from Biotronic, which goes with lower strut thickness of 61 micrometers, and then the maximum you have here with Nobor and Biomatrix, which go with 120 micrometers of strut thickness, which is significantly more than the previous. So now, why does one work better than the other, and is it really true that one works better than the other? If you look again at what we started in the beginning, you have the design of the science stent, the multi-link stent design. Then you have the drug, which is now in basically a very well-established drug, everolimus, and you have the fluoropolymer coating. So how does this behave and perform? Never change a winning team. So I think in terms of certain components like the drug dosage, this was established and it really didn't change. And I think this is a good sign, and it didn't change for a reason, because it works so well. And as well, the coating, this did not change. What changed was maybe the catheter technology. And yes, it's true that if you compare a science from today, and if you compare a science from maybe 10 or 12 years ago, then you feel that you can deliver it a little bit better. But what didn't change was the backbone of which worked fine. Here you can see the comparison of the different stent designs and how this plays a role in terms of radial strength, and of course in terms of how much contact of the metal you have with the vessel wall. And here basically all four of them compared, and I believe that the science stent has a good compromise between good or excellent radial strength and of course then very good longitudinal strength, and as well as a relatively low metal to artery ratio, because you don't want a stent which has so much contact with the endothelium that you cannot really cover everything. And on the other side, you have the Orsiro stent, which doesn't really have a great radial strength, I have to say. I've used it in the past, and as well as the Onyx. Now, in terms of the polymer, there is also differences, and you will have the polymer the stents with the biodegradable polymer and the stent like the Science with a permanent polymer. And here, let's skip this because I think I will hit the time target from Dr. Pratap. Here, you will see that there is actually quite some difference in terms of thromboresistance and also in terms of inflammation and in functional healing, because you don't want a stent which causes inflammation and which attracts a lot of thrombocytes. And why is the Science stent such a, I think, good stent? It's because it attracts albumin. And if you compare it with other, then you will see that you have more albumin here. And this results, again, in less thrombocyte or platelet adhesion. So this means that this should relate to also the risk of stent thrombosis. And this high albumin binding is related to the lowest platelet adhesion. And there is different studies, which I will show shortly, which demonstrated really that the healing is fast enough so you can afford to shorten your time of double antiplatelet therapy. The two studies, Science 19 and 28 days of DAPT, you see here. This was the study design. And now I will show you some results. So here's the primary endpoint of cardiovascular death, MI, stroke, definite stent thrombosis and bleeding in this trial. And as you can see, it's relatively low. And it is low because especially in high bleeding risk, you can see if you compare it like Science 90 and then the Science V USA study, you see the results are similar, although you have less duration of the double antiplatelet therapy. And you don't have increase of ischemic events, which was very important, because if you remember back some years ago, you were afraid to shorten DAPT, and very often we kept DAPT for longer than maybe we should have in these high bleeding risk patients. So the bleeding risk was clearly reduced, because we know the longer you have the DAPT, the more bleeding risk you have, so you want to stop DAPT at a early point in time. And as this is important to realize that at the same time you don't have an increase in stent thrombosis, so you can afford to shorten DAPT, not increase ischemic events. So there is now a lot of experience with the Science stent, and it's performing very well, and this is the reason why in my lab I only have one stent, because I think this is all probably you need. There is a lot of studies comparing long-term patency and long-term efficacy of the Science stent. This is data from Bern, Cardiobase registry, and you can see that actually there is signal that the Science could even perform better in terms of safety of stent thrombosis compared to stents with biodegradable polymer, which is a very important topic. And again, here you see in the long term, the stents actually perform quite well, and Science performs well over years. So here I can show you also some other data which took this to a much longer time. Here you see even longer, and the performance even in long lesions and in left main is actually quite similar. So I will stop here, and maybe we have time for one question or so. Thank you very much.
Thank you very much. Yes. You showed the small difference between among the all stents. Yes, I agree. Yes, but clinically, there are no significant difference at the moment, as you showed, right? So the selection of the stent might be the operator's preferability. So what kind of stent do you prefer, and what is the reason why?
Well, I think. So in my lab, we only have one stent, it's the Science, because I think it's a safe stent in the short term and long term, and I don't see a benefit from this biodegradable polymer or even polymer-free eras. I have never seen an advantage. That's why I stick with one stent.
Do you find any difference in double stenting in a side branch decay crush using Science versus, say, Onyx design or a Synergy design?
To be honest with you, because I combine stents very often with drug-coated balloons in such settings, I am quite happy with its current design. I think if you use, if you use always a two-stent strategy for bifurcation, you might find a difference. But I think with whatever stent you use, if you use two stents in a bifurcation, you can count the days until this will fail, because this is not. We know it's not going to hold good. So I don't do that, and that's why maybe I don't see the difference as maybe others would see. I rarely use a two-stent strategy.
Florian, thank you very much. You have the pushing on your back
Yes, I
from
can
the
feel.
owner. So
I can
you
feel
needed
the
to
wind.
leave the podium. Thank you very much, Florian.
Actually, I don't want to give a talk basically, otherwise they'll be angry. OCT in complex subsets, I'm just showing 3 cases. I will be, if the time not permit, you stop there. I'll just stop there. This is a lady of 31 years. She had undergone bypass surgery in 2012 with a limber to LED graft. She came with this like this, completely occluded LMCA. So naturally the LMC was filling from the RCA. I tried my level best to open it. I'm not showing the steps and all. Reverse, and by snaring the wire, I just went and did angioplasty, and finally we put a stent, the antigrade injection showing, and I'm not going to details, and just put a wire. We did an IVIS there. Plaque in the ostial LAD, the lesion was 3 millimeter proximally with a 3.5 into 26 resolute onyx stent I put, and then the patient was doing very well. Exactly after that, final result was very good. This was a final result. The patient came within 3 months to me with an ISR. This was the situation. 99% LMCA disease. Here, I don't have to struggle too much. The wire was actually going inside. Filled FC to circumflex, balloon dilated. I did an OCT here. To understand what is it, it's a Takeyasu's case. It's a tight disease, 1.923 is the cutting, tightest MLA within 3 months. This is the situation. Probably subinguinal neointimal hyperplasia. I could not see atherosclerotic thing. I did a flextome there, dilated. I put a wire into the circumflex. And I put a 2.75 into 12 Maverick to circumflex and a 4 into 20 magic touch into the LMCA. This was the final result I produced. That is a final OCT pictures was wonderful, but still I don't know why this patient may come back again, but this was the OCT picture. So OCT helped me to not to do anything more and then finalize the case. This patient actually doing very well for the last 1.5 years, whether it's DES or my second strategy proved or not. This is a case of a decay crush technique. You can see there is a wire. This case actually I did a live case. I put a wire. You can see a lot of calcium there. Put the wire. Balloon dilated. Naturally the OCT cannot be run without an OCT. This was a pre-run. We got a proximal LAD of mean diameter is actually 2.12 only. The area was 3.53. You can see the tight disease. Again, the proximal LAD was, ostium was tight, and the proximal LAD was like this, very large vessel. The non-standard segment was like this. We just did an OCT to the OM. This was a very, very tight disease. Distal LMC and ostial LAD was very tight. Distal most part actually we got a diameter of 3.83. So the LAD to LM area was actually, this calculated, proximal LAD was 2.99, MLA was 1.95, ostial LAD was 1.57, and LMC was like this. We decided this is actually the circumflex run, tight disease. We did a Wolverine both sides. We did a decay crush here. All the steps are there. I put a wire into the circumflex, not in circumflex wire actually, just passed the wire from the LAD to circumflex, and then I took the wire into the, because it was a live case, they told, can you demonstrate to take the wire into the OM? I demonstrated, but I will show you in the next. The wire is inside, wire is here. Then the final result is like this. The crossing was good, very good opening of the circumflex. 2 into 12 millimeter balloon, that is a final shot, kissing, 4 into 12. We got a result like this. Bifurcation angle demonstrated. So the pre-run and post-run, if you see, this was the pre and post. We got an area very well developed, 1.95 become 8.76, 5.88, 13.1 and 11.6 became 14.6. This was the final shot. So this was another case which I do a lot of zero contrast PCI with IVUS, but I can do actually a zero contrast with saline also. That means actually saline OCT, a filter FC wire, saline OCT, pre-run is like this, absolute OCT with, people take 20 ml of syringe, I just take only 12 to 15 ml of saline, and normal angiogram also, in OCT also I take only 10 ml, not 15 and 20, and normal syringe only I use, I get good images. I think the rhythmic injection make the difference, not the other one. This is the morphology. I just wanted to just tell you that it is possible by OCT. 360-degree arc calcium. I did a rod ablation. Flextome. OCT again. Saline. It is completely saline. Post-rota. Morphology changed with a lot of cuts in the calcium. Length was measured, 26 millimeter stent, distal to proximal. I decided the diameter with IVUS OCT only. Just took the stent, it was difficult, but just gone in. 3.5 into 28 stent. Balloon dilated with a 4 into 12 at 18 atmosphere. This was the final shot taken. We used only 15 ml of contrast for this angioplasty. OCT was done absolutely with saline. And we can do angioplasty with OCT also. I think I gave 3 minutes back. Thank you very much.
I was just going to ask you a quick question. For your first case, I know you're trying to keep us on time. For your first case, what do you think the mechanism of the ISR was? Because
basically,
it seemed like it was well expanded. Takayasu
patients usually come back, that's a major issue. And that is why today morning, I think you heard from George Joseph, a lot of Takayasu patients come back with restenosis. He is telling not to leave these patients. Even Takayasu with carotid artery stenosis, he was telling you have to open it and give the vision to the, and to avoid hemiplegia. And I think you should try balloon dilatation is the only choice in this case. I used a cutting balloon and balloon dilatation in the second time. This time, the magic touch or the just simple cutting balloon created the difference. I don't know, but the patient is doing very well for the last 1.5 years. She's only 33 now.
Yeah, I've had Takayasu's patients keep recurring back, and I wonder if in those patients maybe bypass is the better option.
Thank you.
Okay. Thank you very much for a wonderful case presentation. And then we'd like to move on to the final talk in this session entitled The Presence and Future of OCT Imaging, Learn from the Master. Dr. Giulio Guarini, please.
Okay, let's have a look at these images. On this left side where we are, and we have great details. What we would like to do is to understand much more, so to go deeply, and then you have the projection into the future, how we can expand. So the essential concept is we are getting the more and more complex patients, and how we are empty these patients of their stents, or we are trying to understand with a different type of approach, physiology and morphology, what should be done, which lesions should be treated. This is the last document that was published less than 1 month ago. It's a consensus statement across all the imaging technologies for the quantification of the lesion and detection of the coronary stenosis. Here you can see the beauty of OCT across the entire spectrum with a great design telling you how much OCT can be sensitive to detect a different type of a plaque. At the same time, you can see the longitudinal view. And the longitudinal view is showing beautifully some part of the information. Every technology in imaging is trying to add to the lumen the content. Here you can see multiple examples of non-invasive, invasive technology, and getting closer and closer to what? To the standard of care, the pathology. This is very important. OCT is brought to the attention these capabilities since many years ago, especially with some focus. Why OCT is a little bit more advanced than the other technology? The first point is in trying to save in time. Everybody said we have a limited time. We are fight against the clock. Everybody is busy. But the first point is if really to decide to invest time and perform an imaging guidance procedure, we need to do the best possible in terms of what? Number one, fusing with angio. We saw today, we started to understand the content, where it is for making what we call actionable imaging, and to get a control from the table side. That is something that we got many years ago. Then we started to have some information about the content, the plaque, but we would like to get projected in the screen. Here you have automatic calcium detection that is not on the imaging, but is imaging projected into the screen for decision making. And then also AI is already with us because it's bringing automatic measurements. Here you can see how we can mix cross-sectional view, high quality, longitudinal view with measurements. And the measurements are across the entire spectrum of the intervention. Before you saw an example, and then during the intervention to say that the stent is a pose, what about the expansion? All these things are already in this technology. What about the possible advantages in the future? The first one is quantification of disease. This is very important. For OCT, not. Here you have a response of the consensus. Should the segmentation coronary plaque as a visual commentation to be mandatory when you are applying AI to the images? The answer is yes, for invasive and non-invasive imaging. And so we are targeting. Across this incredible spectrum of specialists in imaging, not only expert in imaging, but including surgeon, radiologists, cardiologists, biomedical engineers, and computer engineer, we ask a few questions. And one of the questions is, put all the different techniques, one beside the other, and tell us about which has the maximum accuracy of coronary stenosis measurements. And you can see the ranking points. The maximum scale was 10, good was from 7 to 10, and you see that OCT get the maximum. Can we have still something to be done? Of course. We are susceptible with all the type of imaging to the artifact, and we needed to make amelioration. Why OCT went first to the automatic calcium detection? This is the answer. This is the prevalence of a calcified lesion across the different studies done. About 1/3 of our lesions are calcified. Here you have in the same patient the longitudinal view detecting calcification by CT compared to the same cross-section aligned by my Japanese fellow, nicely had from Professor Akasaka lab, that is showing how much we can accurate in detecting. The same, you can get calcium, you can measure calcium section by section. Why? Because calcium is becoming extremely important. We saw also this morning. And we needed to update our suggestion how to treat the calcification and how to do better. And here you have one example of how much the imaging can be useful in debating, for instance, in calcified nodule, different position. Everything in the past was based upon pathology. Today, everything is based upon in vivo imaging that we can use for understanding more and more. What in addition from AI for all the imaging technique, automatic detection of the contour. We have already automatic detection of the lumen. We have already automatic detection of the EL. It's taking an accurate measurements. Here you can see how much, in terms of microns, you can be accurate by using AI for all the different type of measurements when you are confronting with the operator. And here is what we have already today, visible. The lumen automatically detected, and the EL when is available. And once, in addition, we can compare different steps of the procedure, watching to what was the lesion at the beginning in the upper panel and what was obtained at the end. That is something that is coming from AI. What about the detection of the pathology? Here is the current situation for vulnerable plaque. You have all the elements that we can get by using imaging. And you can see that for the vast majority of them, the OCT is largely dominant. You can get the vast majority of the information. Some is still miss, and we are working on that. One of the most important is a thin fibrous cap atheroma. We can detect and we can measure. And AI is going to bring a much more stability and accuracy in measurements. The future is going to bring soon also segmentation for lipid, not only for calcium. When across all these experts we ask what imaging modality is suitable as a reference standard, they say the pathology. But then you can say the beautiful position and the very limited confidential interval for OCT. Likewise, immediately after pathology, the people think that OCT could be the gold standard to be compared in terms of evaluation. Why OCT? Because OCT with a pristine imaging is especially feasible to get extraction of the measurements and to get extraction transformed in a 3D information. Why in India? Here you have three different population confront in terms of plaque characteristics across people from India, from Far East, and from European in blue. And you can see that the age is much early, but also the reasons for getting in trouble with acute coronary syndrome can be different. So knowing much more means what? Means how we can extrapolate this in terms of clinical events. This is what imaging is doing, is try to separate what is normal, what is a no-risky plaque compared to what is a risky plaque in the future. Only with morphology? Not. Combine with FFR. Derived from what? Imaging. 3D imaging can bring not only data on functionality, but also data on biomechanical simulation like shear stress. As a final words, we would like to get as soon as possible an integrated approach with imaging, physiology, and clinical annotation. This is going to be really important for the future. This is what AI is going to impact in the next few years for all the different tools we will face. Thank you very much.
Thank you, Giulio, for a wonderful masterly presentation. So my question to you is that AI is a great tool, but AI needs machine learning, giving it images and data that what happened to these patients on follow-up. Looking at calcium, maybe one simple thing of what you showed us, but there can be so many other things, like whether you should do atherectomy or not to this lesion, whether this will be an IVL case. You will have to give them clinical data to follow up, without which AI would tremendously fail. So how do you think that in the next 5 years, this can be a reality?
Okay, the big effort is mixing data, how we can mix clinical data. We are still writing the report, and the report, when we are using imaging, is stay with us inside the cath lab. We need to get out. We are not mixing with clinical annotation. We are not mixing with CT data. The big deal in the future is can we try to mix all this incredible information to get a better journey identification for the patients and the risk profile.
Thank you very much, Professor Julio, and we really enjoyed your talk. Very nice talk.
Thank you, thank you, Balbir. Thank you, Akasaka and Darshan for ending up the session on time, rather before time. We'll go to the next case. Actually, there are 30 minutes we are late. Okay. So we'll actually go to the live cases, and I told, I given a punishment for Darshan to make and sit here for another 1 hour. Adnan Kastrati, Dr. Manuel Pan, Carlo Blagori, Angur Ahuja, Manoj Kumar Rohit, Ravi Kant, Mona Bhatia, Mayur K. Jain, Abhishek Singh, Rajiv E., Murali Krishna, Aiser, Karunakar Rapolu, Mamta Reddy, Anwar Khan. Please occupy the chair, and we go to the live case, 2 live cases of calcium cases. The first live case will be, we just go to Sanjog Kalra. Sanjog and Shashikant is doing, go to the Sanjog Kalra Yashoda Hospital. No advertisement, go directly to the case, please. 2 live in lightning talks other we will be arranging in between.
Don't need to hold. You don't need to hold. See, you don't need to hold. Oh, hello, how are you, everybody? Go ahead, sir.
Hi, good afternoon, everyone. Welcome to Yashoda Hospital. We are going to have a very interesting case here at Yashoda. Can you hear us?
Yes, Sanjog and Shashikant, we can hear you. Can you hear Shashikant?
We can hear you. We can hear you, sir. We just lost the video feed, I think, for a moment.
No problem. So Sanjog,
can you see us?
Shashi, can you explain the case past?
We sure can. Go ahead, sir.
Can we have the slides, please? Can we have the slides?
The slides, please. The case slides, please.
Oh, this was a, yeah. 56-year-old woman who has presented to us with unstable angina, and she had a typical angina running to the neck, shoulder, left upper limb, and axilla.
Shashikant, we cannot hear you. Can you just be louder?
Yeah. She's in a diabetic and a non-hypertensive. She was diagnosed to have an unstable angina. The angiogram showed us a 2-vessel disease. And we had done about 2 weeks ago a stent to the LAD, very critical lesion there. We thought that was the culprit. And then we wanted to stage the procedure for the RCA. We did give a cursory attempt to the RCA 2 weeks ago, but then we thought probably there was too much of contrast for a diabetic patient, so we backed out at that particular time. And we thought we will take up this interesting case. We thought it was for a CTO with a lot of calcium there, we thought, on the initial angio pictures, but then subsequently, can we play the next slide? Can we have the next slide? Her blood chemistry was normal, her vitals were normal, her LV function was good. The next slide. And her troponin was negative actually. Can we have the next slide?
Shashikant, go to the case. We can discuss more about the case, please.
Okay, again, next slide. Next slide. Next slide. Yeah, that's the angiogram what you have. We had a critical lesion in the LAD and a good collateral filling of the RCA. Can we have the next slide? And that the LAD was stented with a 3.5 to 12 stent. Subsequently, next one. Next one. Yeah, that's the RCA which we are interested in today. So very acute angulation there in the mid RCA. That's a CTO with 2 or 3 side branches coming in, small branches.
Bridging collaterals.
Bridging collaterals there. And what would be the strategy you would go at this stage from the panelists?
And can we switch over to the live, the last fluoroscopy, so you can start seeing the dual injection. So 56-year-old diabetic, blunt proximal cap, ambiguous, blunt distal cap, lots and lots of bridging collaterals, a little bit of antegrade filling with a serpiginous bridging collateral, and good filling from the septal system into the distal RCA, as you see here. I think you probably get a good idea of how the mid RCA is about a 15 or so to 20 millimeter dense CTO with that ambiguity at the proximal cap because of all of those bridging collaterals. So maybe we'll turn it to the panel here and ask you to give us a strategy.
Yes, Sanjog, it's Darshan. Hey, how you doing? So a couple of things. One, you fixed the proximal LAD, but the distal LAD still has some disease.
Correct.
But there seems to be fairly profound collateralization going to the distal RCA. You still have antegrade flow. The problem is you have a branch that comes off right in the middle of the CTO area. So there's going to be ambiguity. So there's, I think the easiest approach would be to try to get something going in antegrade. If you get into the diagonal, the RV marginal, that'll be fine. You can balloon that, use Hybiz, and then try to redirect. Or hopefully you can get in. There's some ambiguity based on angulation, but I think an antegrade approach to start would be reasonable. If you get subintimal, that's fine too. ADR seems like a very decent process as well, given how pretty large the distal vessel is. And if that doesn't work, then I would go retrograde, though you have to understand that he does have disease in the LAD, so he may become a little ischemic as you start to block flow.
That's exactly our line of thought what we had in the
It's funny, Darsh. It's like you and I trained in the same place.
It's because we did.
So we'll show you the next pictures. This is exactly the approach that we took. So we started, this is sort of your best antegrade that we were able to get. So I got a proximal base of operations established and took a directed penetration wire, which is a guide.
Can we put the angiogram up? Because we can't see. We can just see your two beautiful faces.
Okay. So do you see it now?
Yes, we can.
So here's the problem. This was a guy out there trying to get antegrade, and you'll see the tip of the wire entering, side branch / bridging collateral after bridging collateral. Keep going next. Okay, and this was in the RAO view. We were looking at where we were going, and it was harder and harder to try to get it to go straight. So we just pulled everything back, took another good look to make sure that we understood, and then actually tried to get subintimal using a power knuckle approach. So first we just took a Pilot 200 and knuckled, but that proximal cap was very tough. Next, please. And as you can see, it was backing the guide out. So I put a workhorse wire next to it, put a balloon against the microcatheter, took that up to 20 atmospheres, and we tried to knuckle. And unfortunately, you can see the guide backing out again. So next. Next. So then we tried a scratch and go, or a run. We put the balloon across the tip of the microcatheter. Next. Next.
Next one.
And we drove, go back please. Okay, and we drove the microcatheter tip into the wall, tried knuckling, and again, the entire system would kick back at us. It was a very, very calcific, very fibrotic proximal cap that was blunt, as you saw. Next. Next. So there was a variety of attempts at this. That was the best sort of starting knuckle we got. But the knuckle started getting a little bit bigger than I was comfortable with.
Very big.
It started turning into a bit of a cauliflower, which I wasn't so happy with, and I didn't want to keep pushing that, even though I knew the RCA was quite large. Next.
Sorry, quick question. Why not just try to use base as opposed to using a scratch and go or a power knuckle? I mean,
yeah.
I think if you just go size 1-to-1 or maybe a slightly higher balloon, semi-compliant, you make a dissection and make life easier for you.
Great thought. We tried that too. And
Sanjog, actually, you will be without knuckling itself. I think that is one wire you keep there and take a parallel wire without knuckling is also another choice, as Sanjog.
Absolutely, the parallel wire technique. I guess the challenge was that we weren't really able to breach that cap because we couldn't find it. We kept getting into the tiny bridging collaterals, and I was a little bit concerned that we were going to end up somewhere in the pericardium by.
In these cases, actually, Sanjog, what we do we do an anchor balloon technique. Actually, your catheter is not giving a real support. You have a branch in the top part, right?
Yeah, it's a good thought. That's a very good thought, Pratap. It's absolutely something that we could have done to try to get the knuckle to breach the cap. We thought that with this balloon up at 20 atmospheres...
Now it is a live or it is already recorded?
We just finished it about half an hour ago.
So this is...
No, it's a recorded means I can go to the next shot and show us.
Next one.
So next one. So finally, we decided to take a retrograde approach. Next.
Can you help us with the which wires were used initially?
Absolutely. So the rationale is if you have a fibrotic calcified proximal cap, you need something that's going to penetrate. So you have the options of either a Hornet 14 or a Stato 20 or a directed penetration wire like a Gaia 3rd. We chose the Gaia 3rd because I wanted control, but our issue was that repeatedly we were unable to breach the cap. We just kept bouncing off of it. So For the knuckle, for the power knuckle, or for the base, or for the scratch and go, we tried to get into the wall with a Gaia third and then tried to knuckle a Pilot 200, and you saw what was going on with the Pilot 200. So come back one, please. So, and we'll tell you when to advance, please. Go back. Yeah, so this was the retrograde setup. Okay, this is just a straight RAO. My usual retrograde wire of choice is a Xi'an black, unless I'm in an epicardial. In those situations, I use a Shu 03. Next. So what you see here is the Xi'an black, and this was... I'll ask you when to advance. Yeah. What you see is a Xi'an black, and this is just finding the septal. The key here is it's a tiny bend. It's a hydrophilic wire, so you don't have to push much. And you just let the wire sort of find its way. It's a one-to-one torque control wire. It's beautifully designed. And that's the entirety of the time that it took to get retrograde. Next, please. This is our confirmation shot. I never advance a microcatheter, even if I know where I am, until I can prove it. Next.
Did you face any challenge of taking the microcatheter through the septal down? Because there is angulation in the septal.
Yeah, it's a good thought. So you'll see what it looks like. Next. And this was the microcatheter physically going in through the septal.
It's a Corsair or a Caravel?
Corsair Pro
Corsair
XS,
Pro XS, okay.
which is generally speaking the microcatheter that I use going retrograde. Teleflex makes a Turnpike LP as well. That's a really nice microcatheter. With this kind of tortuosity, you can make the argument that maybe a Caravel would have been a good microcatheter as well. I guess the only concern I had was that there's a lot of contraction around the distal edge of the septal where it's tortuous, and I didn't want to get stuck in that contraction, but this actually went really easily. Next. So once we were here, the challenge became trying to find the distal cap because there was lots of tiny branches coming off there. And believe it or not, what we kept getting into was the same bridging collateral that connected us antegrade, which is often the problem that we have. We get to the retrograde cap, and then we can't seem to breach the retrograde cap. So next, please. And this is just a little retrograde, various retrograde attempts. This is a Xi'an black, so I wanted something that wasn't overly aggressive until I was confident I was at the distal cap. We only had one Pilot 200, unfortunately, so there was no other Pilot 200. Otherwise, that would have been a good wire to use here too. Next. And this is...
Sanjog, make it clear that which wire you took now for crossing to the CTO segment from the retrograde.
So I will show you that in a moment.
Xi'an black is not working out. You know what? Next
well,
choice.
This isn't even at the CTO segment yet, Pratap. This is still just trying to get to the distal cap. Next.
Oh, you are going to take it only.
Okay. And next.
Stop the wire for that.
I didn't want to use something pointy in the distal RCA until I was at the cap. You can see the gap, right? So we're not there yet. It's because there's a critical lesion there. Next. Next.
Do you think the real calcium making the real troublesome for you rather than...
Absolutely, it's fibrosis and calcium. So this was just a little retrograde shot. I figured if I was at the distal cap, this could serve as a retrograde Carlino. Next. 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 I'm not sure what happened there. Next. Next. Okay, so this is now Xi'an black just to get to the distal cap. So now I proved that we were here, or at least where we thought. But do you see where it's starting to go out into funny places towards the end? Next. So then I came RAO to prove where I was, and that's obviously not good. Next. So then I redirected, and I got us into the same plane where I was safe and comfortable of where we were, and then advanced the microcatheter up to the distal base of operations. Next. And next. Confirmed. Next. And as you can see, we're not using much contrast, right? It's very little. Next. And next. And what we did is we took the same guy a third. We took the same guy a third.
Actually, he tried anti-grade wire passing, not done. Then he tried knuckling. Again, when there was a knuckling issue, he was actually having some challenges. So then he thought about going retrograde and crossing.
So here's your retrograde, and this is a Gaia third. So brought the microcatheter back up.
So Gaia third wire, huh?
Yeah.
Gaia third.
Okay, this proves to you how close we are. Sometimes it's the longest
Usually Gaia third in a calcified lesion, I usually prefer a UB3 wire than the Gaia third wire.
To be honest, Pratap, that's a good thought. I thought about a Hornet 14 or a Miracle 12 or something. I don't have experience with UB3 because we don't use that much in North America.
UB3 will be there in the lab, you know.
And
crossed.
this is our
Wonderful.
guide crossing through, and it's always better to be lucky.
Sanjog, what is that staining scene? Actually, staining is in the best.
Very, very good question. What that was you remember the antegrade knuckle that we made? So we took a small antegrade puff, and that contrast sat there. So it tells you that we were getting some action in the subintimal space, but it just wasn't enough to breach the cap. So that contrast has just been sitting there.
And sorry, just remind me again, what did you use for your antegrade knuckle? Was it a Pilot 200?
Pilot 200. We don't have a Mongo. I would have used a Mongo if we had it. Next.
Next one.
So this is external. The Gaia 3 is out in the aorta. Next. Next. And this was tough because the retrograde microcatheter was having a lot of trouble getting up through the occlusion segment because it was so nasty. Next. So we brought this back just into the vessel. Next. And brought a guide liner down. Next. Okay, next. Next. Okay, and now in the guide liner, next. We pulled the Gaia third back here, and then this was fairly straightforward. This didn't take any time at all, right? Where now the base of operations has been advanced just to the tip of the wire, and in it went, and we were done the retrograde part of it. And so the total time at this point was about 55 minutes. Next. Okay, and then we pinned this wire with an antegrade balloon. It was a 2.5 balloon inside the 7 French. And that actually is the only thing that managed to get us up here. Next. And so a word about microcatheter fatigue, because what we found was something very interesting happening where we advanced the RG3 into the retrograde microcatheter and it wouldn't go past a certain point because the microcatheter must have gotten a bit fatigued. And, you could feel that happening just as we were towards the very end, but that's kind of late to switch it out. And so I learned something brilliant from my Indian colleagues here where we would usually use, Darsh, what would you use to re-lubricate the microcatheter?
Yeah, I would probably just use a tip-in and try to make life easier.
So what we did, we would usually use Rotaglide, but the Rotaglide isn't easily available here. So we took a tiny 1.5 cc injection of propofol, which is mostly triglycerides.
Actually, there are two things you can do. One is actually a tip in taking the wire antegrade and then crossing inside. The second point is actually you can actually keeping this as a marker wire and take an antegrade wire down.
Great thought. All things exactly that went through our mind.
And the third situation is actually you can take a small balloon throughout and come back. 180 centimeters small balloons, ikasushi like long balloons you can take and do a cart there and then come back with that. These are the three choices.
Excellent thought as well. We considered, I'd thought about going antegrade using it as a marker. I'd thought about tip-in. The problem was that, there wasn't a ton of control on the Gaia third, right? And I didn't want to give up my position having crossed already. So we put a little bit of propofol in the back.
Sanjog, are you live or not?
What's that?
This is now live?
No, I'll show you live in just a second. I'll show you where we are. We put a bit of propofol into the back of the microcatheter, injected just a little bit of propofol into the microcatheter, and that lubricated it sufficiently so that we were able to get an RG3 through. Next.
The wire went in very easily.
Yeah, the wire went in very nicely. That was just a great trick. Next. Next. Next.
The microcatheter gone inside?
I'm sorry? Next.
So what you can do actually, you can take a guideline down. Okay.
Next. Okay, and just play this. And you're going to see now, after we had done that lubrication trick, the wire just kind of flies through. You
can take another RG3.
It was really smart. The propofol trick is great. I'm going to remember that. Next.
Did you try the retrograde wire with a balloon in order to facilitate the advancing of the...
Yes, yeah, we had it pinned. We had the retrograde wire pinned. But it wasn't advancing the microcatheter that's the issue. You can see the microcatheters in the guide liner. The problem was the RG3 wouldn't go through, which is a bizarre problem to have, right? I mean, we've all done this before. The microcatheter was retrograde for a long time. We were sitting in the guide liner for a while, but the RG3...
That is actually one important thought process. Whenever there is a problem of a microcatheter not crossing, you can change over to another microcatheter. Probably he has taken a Corsair Pro XS. Even a fine cross can cross, or
even another Corsair Pro XS.
I don't know whether you are not happy with fine cross, but we use a lot of fine crosses. You use turnpike spiral and all. But actually, Caravelle is not a good choice because of the calcium there.
Yeah.
And so if for a tip-in, the fine cross is the best because it has the biggest opening too. So.
Yeah, it's a great.
Sanjog, actually, we have to go to the other cath lab. That's what I'm asking you. What is the situation? Can you show the latest situation now?
Yeah, so we've just finished here. You're seeing the externalized wire, and this is where we are now. This is live. Okay, so we now have an RG3 through. We have the microcatheter back. We're just bleeding back the antegrade guide, and we're going to then take a balloon, and we're going to IVUS for you, and then you can tell us what to do.
Now you are going to do an IVUS?
Yeah, so we're taking a balloon through the CTO segment.
Balloon dilatation, then IVUS. And we wanted to know that how much...
what, please?
Totally intraluminal or how much subintimal it is.
I'll show you. It's just a 1.5 balloon.
What do you think, how much subintimal it is, Sanjog?
I think we're probably subintimal about 20 millimeters per thought and down.
No, I think it's short segment. Because
short segment is subintimal. Probably across the CTO segment he tried to cross, but actually as Darshan also agrees that...
folks, do you see the screen?
Antegrade was more subintimal than
so there's an underexpanded or unexpanded segment there. Okay, 10, 12, 14, 16.
We will actually with you for another 2 minutes and we will go to the other lab. Just want to see, if you want to take, I think you will not take an injection now. We'll just do an IVUS only, right?
No, we're just going to put the IVUS catheter in and we'll show you what we're dealing with.
Okay.
But given that underexpanded segment...
No, we want to see the IVUS and then we'll go to the other lab. Let us see the IVUS.
You don't have to. Yeah, okay. Yeah, so what will end up happening, I think, actually, with that underexpanded bit is we may end up having to flip antegrade and DOTA it. We'll see.
We had a tough time pushing the RG3 into the...
But ultimately, it did a nice job. Okay. So the other thing that everybody seems to want to do is hold the RG3, which you don't need to do because you've got a you remember what Dimitri used to call that, Darsh?
Yeah.
Felt-proof rail?
Yeah. We can see the IVUS screen. It's just not running right now.
Okay. Yeah, we're just delivering the IVUS catheter. So here's your IVUS now. Can we go live on IVUS, please? So we're just going to quickly co-register that. Okay. And pull back, please.
Can we have it?
Okay, so pulling back now.
Yeah, we can see where the IVUS catheter started from, but we obviously see the pullback, but not the angio co-registered to it.
There you go. Okay. How's that? You can see that there?
No, we just see the angio. I mean, the IVUS, just the IVUS, I'm sorry, not the angio.
That's fine. So
it's fine. It's all good. I mean, all of this looks clean now. This is the CTO segment.
This is your CTO segment. So this is a little subintimal bit, but...
Yeah, now you're true again. You see all three vessels. So I think,
You're not in the CTO segment.
three layers. Yeah.
You're still distal to the CTO on the IVUS. This is now getting into the CTO. So you see that?
Big hematoma?
Yeah,
this is the CTO segment now.
We are in the lumen.
Right. So we're intraluminal, but there is a big antegrade hematoma from that knuckle and the injection.
True.
So we're basically true to true the whole way. And it's largely fibrotic.
You're back into, you're definitely true lumen there. I don't know if the part in the CTO was obscured. We really couldn't see that part.
Yeah.
Sanjog, I think it is totally luminal. You have a hematoma on the other side.
I agree with that.
And number one. Number two, do you think that the subintimal, what is the knuckling done from the antegrade was not a good choice now?
What was that, sorry?
Antegrade knuckling.
He's asking if you have regret from the big knuckle you made antegrade.
Yeah, I mean, not really. I'm going to end up stenting it. Ultimately, that was what we had to do to try to get...
Number two, it is a large vessel, nearly 4.5 millimeter vessel.
It's really big, yeah.
So, Sanjog, can we go to the other lab and come back?
Absolutely, sir. We'll
can you switch over to the lab?
Yeah,
because the other lab is done by organization secretary.
Can you give me a distal vessel size, please?
Sridhar, we are with you. Sridhar.
Yeah, how are you?
Sorry, we are late by another 10 minutes. We will be with you for some time.
Yeah, sure.
Please.
Go ahead with the history. Good evening to all of you. Just go ahead with the first slide. Next slide.
Show the case and go to the angio.
My associate is Dr. Pranay. Now he'll read about the details of the case. You can.
Good afternoon, everybody. It's a 56-year-old male who is a diabetic for 5 years on OHS, presented with chest discomfort for 5 days. His hemoglobin is 14.5, platelets are 2.23, and elevation of the troponin. Next. His ECG is showing T inversions in 2,3 AVF. Next. So a 2D echo was done, it is showing fair LV function. Next, we took him for an angiogram. So his angiogram reveals there is an proximal LAD lesion with and Raymer's tight lesion, and mid in the proximal OM there is a borderline lesion. Next. In the LAD, in the proximal, there is an 80% lesion. There are some calcium spikes which we can see, and distally there is a diffuse lesion in the LAD. Next. The RCA, there is in the mid RCA, there is a 95% lesion with thrombus.
Next, Pascal.
So based on this, the end-STEMI presentation, we wanted to do first the right coronary artery and then tackle the left system. Over to you.
Yeah, today our plan is to do the first, because presented with ACS, elevated troponin, and it's not a STEMI, but troponin is elevated. This is the culprit. You can see the right coronary. There is a tight critical lesion. Either this comes under like an ambiguous lesion, either it could be a calcium nodule with like a eruptive nodule with thrombus, or it may be because of the plaque rupture with a lipid-rich plaque. So because the remaining entire area appears to be normal, most likely it could be, because his age also 56, most likely it could be what we suspected, ACS with the plaque rupture. So we acquired the OCT images. You can show the OCT run the OCT, Are you able to see OCT?
Yes, yes,
Yeah,
yes.
we can see it.
Yeah, you can see the distally vessel is fine, but just slow, just go back. Yeah, you can see the plaque rupture, slightly move back. That you can see the empty cavity, you can see very clearly. Move forward toward the ostium. You see the plaque, that is empty rupture. Slightly, one frame back. You see, one frame back, that is the empty cavity. You can see the nice demonstration of the ruptured plaque, just forward toward the ostium, toward the ostium. You can see the thrombus. Just to move backwards, one frame back, you can see the red thrombus projecting. Just to move toward the ostium. Now you see there is a thick fibrolipid plaque forward ostium. Now basically the ECG, the OCT shows a clear-cut lipid-rich plaque with ruptured plaque, empty cavity with a red thrombus. Then go to the next angio image. So then pre-dilated, go to the next. Because it is not supporting that much what we thought. For OCT also, we are unable to pass the OCT catheter. That is the reason we deeply intubated the guide liner. Then through guide liner, we acquired the image. This is, you can see the OCT, almost up to the guide liner is up to the lesion. So with guide catheter, we are unable to get a good images. So because that, we used the guide liner. So everybody, when we are taking the OCT image of the guide liner, one has to hold the guide liner while injecting. Otherwise, what happens with force, guide liner will go inside and it can dissect. That point I wanted to highlight. Go to the next. Now with the guide liner, we implanted the stent, that is 23, 3.5 into 23. We estimated 4, but anyhow we implanted 3. Go to the next. Then OCT images showed, then OCT show the post OCT run. No, see, slowly. Yeah, let them see. Move slowly. Yeah, now see, distal vessel is too big, almost 4 mean diameter. Move. Now see, the stent is showing under expansion. There is some malapation distally. Move forward. Though it's expanded, the luminal area compared to distal is much smaller. Actually, mean luminal area distal is 12. That stented area is about 7.4. That's the reason the system is showing under expansion. Go, pragmally, move. Now, this is the still, okay. Stent expanded, but I feel it's under expanded because distal vessel is 12 mean luminal area, mean luminal area, but stent area is about 6.5. So then we took the 4 mm balloon, go to the next. This is 4 NC dilatations, go to the next. Then we have to do the, go to the next. Yeah, this, go back, show the RCA final. Now, this is a RCA final angio. because we have to go with the left system. My interest is to show you more of the left system, because right is there, culprit to attack, treat the culprit, then go to the left. Go to the next left. So you see the left system, there is significant plaque extending from the distal left main, and the ramus is tightly stenosed, long segment involving the ostium. LCX almost 90 degrees, but there is a tight lesion in the middle also. Go to the next. Next.
We are not seeing any angio. We are simply
angio, just to project the angio.
Showing the OC.
Go back. Go back. Switch on to the angio. Now are you able to see left system?
Yes. We are now thinking about okay.
Yeah, now you can see the left system. There is a LAD, but there is some haziness. Vessels are along the before injection. You can see the calcium shadow also. We suspect some significant calcium in the LAD angiographically. Go to the next. Based upon angiography, it was looking like a moderate calcium. We thought of taking OCT, but you see we are unable to clear the contrast. That's the reason we pre-dilated and then acquired the images. So then go to the next. Now switch on to the OCT. OCT. Now are you able to see the OCT?
Yes.
Yeah. Now OCT, just run slowly run. Now you can see the thick fibrotic plaque. I don't find a severe calcium, but some islands of calcium is there. You see this is a fibrous plaque. Go to this. Move slowly. This is balloon-induced dissection. Go to the next. Go to the move. Here you can move slightly. Move. Still. See, that side you can see the there is area of calcium. You can see very clearly, but as per the criteria, it's not severe. Moreover, it's a fibrocalcific lesion. Move. This is a fibrous. This is also thick fibrotic, but up to the LAD ostium is also significantly diseased. There is a more than 65% plaque burden. This is a ramus origin. You can see ramus very clearly. That is ramus origin. Go to the
looking at the high fibrofatty inclusion there, are you thinking of using a cutting balloon on that? What is your...
Yeah, we have used cutting balloon. Then go to the LM. LM area is good. 10, 9 square mm. Entire LM area you can see very clearly. It's a nice vessel. But ostium of the LAD disease and the L6, the ramus origin is diseased. Go to the next. Then procedure show. Angio. Switch on to the angio. Now initially wide the LAD. Because it's a diffuse fibrotic lesion, my intention is entire LAD is disease up to the distal LAD also. Our intention is distal LAD tackle with a cutting balloon and use the DEB. Go to the next. So this is what we are using. Initially dilated with the 2 mm balloon. Subsequently, we took 2.25 cutting, no? 2.5 cutting. LAD we use 2.5 cutting. You can see the cutting balloon preparation. Entire vessel is prepared with a cutting balloon. In fibrous lesions, if you don't use the cutting balloon, sometimes IMH may develop and it may progress distally, proximally. Sometimes acute compromise of the branches may take place. You see the post-cutting, the vessel is looking much better, including the distal LAD. So what we thought distal LAD, we'll try. Then run this. Go to the next.
The dilation has been performed with NC balloon or with a cutting balloon?
Cutting balloon. Angiosculpt 2.5 into 12 mm balloon.
You used the scoring balloon.
Scoring balloon.
Okay, he used the scoring balloon, angiosculpt.
Scoring balloon from distal to proximal. Entire LAD was dilated. Go to the next. Next. Yeah, this is post scoring. What we thought we'll go with high pressure of the distal LAD before applying the DEB. So distal LAD, our intention is to treat with a DEB and proximally go with a stent. And ramus also to be stented using the DK cross technique. Go to the next. So we are preparing you see go one frame back. When
so
we are
actually, Sridhar, your plan is actually a DK crush in the proximal LAD versus ramus and distal LAD with only with a DEB, drug balloon.
DEB. Okay. Cutting balloon with a DEB. Okay. So see, we are able to see the slippage of the balloon when we are dilating the ostium. That's the reason we use the cutting balloon 2 mm to prepare the ramus also. Go to the next. Next.
My simple question actually, Sridhar, when you decided to do a cutting balloon followed by DEB, will you, before the DEB, will you use an OCT or an Hybiz to understand that how much you just created a luminal gain or not? Let me ask you.
Actually, whenever we use the DEB, as per the recent fourth consensus studies, whenever you are using DEB, imaging is must. Suboptimal result, prove with imaging or FFR. If still suboptimal, despite using DEB cutting balloon, if you are unable to do it, go with additional stenting. But before applying the DEB, if the OCT shows good luminal gain and no significant dissections and no flow limiting dissection is there, just put the DEB and deliver the DEB and come out. So imaging is must. It's a mandatory for DEB to get
what
the
I'm telling,
optimal
what
result.
type of imaging, OCT or Hybiz?
OCT.
OCT, number one.
In
Number
either
two,
way you can
number
use
two,
it.
in this case, when you do a cutting balloon in the distal vessel, when you put the proximal stenting and then keep the wire there, you'll be waiting for any dissection is, whether it is severe or not, you'll be watching, right?
Yeah, definitely.
Okay. So when you are working out, can we go to the other lab and come back?
Yeah, absolutely, no.
Okay.
Only few steps also, only few steps.
Show the steps.
So this, go to the next. The ramus dilation with the angiosculp, go to the next. Go to the next. This is distal LED, again dilatation, go to the next. Go to the next. Array, you are going backwards here. Go forward. This is a stent. Now, our plan is to put a 2.25 into 28 Zion's expedition into the ramus and with keeping a 3 balloon in the LED.
Which stent you are using? Which stent?
Zion's expedition, because 2.25 that I thought of using the translamina, but it's not available. So then the stent extended to the distal LM, then stent implanted, go to the next. Then crush it with a 3 mm balloon, removing the wire and balloon, go to the next. Nicely expanded. Then this is the 3 mm balloon, crushing the, go to the next. Then we are negotiating into the side branch. Go to the next branch. Again dilated with a smaller balloon because acutely angulated, relatively smaller vessel. We use a 1.5 balloon, dilated. Go to the next. Now, go to the next. Now 3 mm crushing. Okay. Go to the next. So as of now, we have completed first kissing, and stented ramus and first kissing. This is the first kissing. That is using a 2.5 balloon into the ramus and 3 balloon into the LED. Now we are going to do the LM2 LED stent, then followed by second kissing, and then final part. This is our steps. Finally, I am going to take the OCT image, and distally I will apply the DEB at the end of the procedure. Okay. I'll go, you can go to the next transmission, then I will complete my procedure.
So we'll go to the other lab and come back to you.
Yeah.
Can you just switch over to Sanjog?
Yeah. Come, give the main stent, LED 3 into 38 stent.
Ujjwal. Okay. Sanjog. Sanjog, we are with you. Sanjog, we are with you. Please tell what are the things you have done so far.
So we used the Hybiz, recognized that this was a 4-4 vessel, EL3, EL distally.
Deflate.
So I took a 2.5 balloon and I made space because it was all largely fibrotic tissue in the mid RCA. Thereafter, we took a 3.5 by 10 millimeter Wolverine cutting balloon for 2 reasons. One, we had that large subintimal hematoma there, which we thought we'd pop. And second, because it was all very fibrotic tissue inside that CTO segment. And so we managed to treat that nicely. And having deployed our second stent here, we're just going to go up here once. Go ahead.
12. Can we see the angio as well?
We're going to show you we haven't taken any pictures actually since we talked to you because we didn't need to. And so you and I will all get to see our first angio at the same time.
It's actually, what is the length of the stent and what is the size? Stent?
438.
It's a 438 distally and a 4038 proximally.
So there is actually a 76 millimeter stent, 4 stents, right?
Yeah.
It's long.
The distal RC also was significantly
severely diseased. Yeah.
438 and 438, or only single stent? 2 stents.
What was that? Sorry, sir.
2 stents you used, right?
Yeah. The artery was badly diseased.
So the vessel is 4.7 or 4.5? What is the size of the vessel?
4.4, 441.
You will be taking a 4.5 millimeter for post dilatation.
Yeah, I was going to take either a 4.0 or a 4.5. I was going to ask you what you wanted me to do. And,
will you do an IVS before taking the post dilatation balloon?
At this point, because I have the pre-IVUS, I've made my decisions, right? So
Yeah, I mean, the one thing is that, with CTO vessels, particularly as you restore flow, they can grow a little bit. So
can you come LAO
even over time,
like 2020?
So if you choose to go back again, I don't think it's unreasonable, Sanjog.
Yeah.
Can you see us?
Thanks. Can you see us now, guys?
Yeah, we can see the angiogram.
Guys? Yeah. Okay, so I'm just gonna.
One cine shot.
And okay, ready? Go ahead. There's your vessel.
Oh, beautiful.
Okay, so we've got a little bit of action distally there, but interestingly, that's beyond the stent. You see that?
What do you think about the distal, actually, the junction, the PDA PLV junction? That is actually.
Yeah, we're going to have to do something about that. That might be a nice thing for a DCB, to be honest.
No, DCB or a stent to the PDA.
Or a very short stent in that distal segment.
8 millimeter
a stent to the PDA. What if they are taking a stent to the PDA? What size of the stent will you take?
I think we have.
a landing zone, Pratap, just proximal to the PDA.
We have a landing zone there.
So I would probably just take a 3.5 stent down there and post-dilate it to 4.
Darshan, what size of stent will you take in this type of case?
Yeah, I mean, there's a discrepancy between the size of the distal aneurysmal ectatic RCA and the size of the PDA. So I think I don't have to guess. I mean, I would just put an IVUS in and then make sure we get it.
I think that's a good plan.
Yeah, so you can potentially take, to the best of my knowledge, you can take a 2.5 and get it to at least 3.75, potentially 4.
Yeah, maximum you can take a 3 millimeter stent and just 3 into 15 or 18, and then proximally you dilate. That is one choice. Second choice, you can take a depth of 3 millimeter balloon and in the just exactly proximal to the bifurcation, and then just come out without doing anything. What do you think?
Yeah, he said he wanted to go with the former, not the latter. Sorry, he wanted to go with the DB and then not potentially stent.
Okay.
I mean, I'm easy doing either.
And stent towards the bigger branch that is the PDA.
You will be Manuel. You will also take a DEB or what type of things? What you will do?
Big vessel, put a stent.
Stent.
Put a stent.
So actually, Sanjog, 50% of the people telling DEB and 50% is for. I will ask
Thanks
the
for making
audience,
my life easy,
how
guys.
many people will go for a DEB now?
DCB. Large territory, I think
So,
beyond that
Can
also.
we take a voting? How many people DCB?
Raise your hands.
Only one fellow is showing 3 hands, so there are only 4 people, and with the 3 hands of one person, and then nobody. Drug-eluting stent.
What we'll do.
Everybody for drug-eluting stent.
Yeah.
My goodness. So Sanjog, you have
Yes,
no
sir.
choice, only to put a stent.
Okay, so
Why can't we go with a short stent, just end it before the bifurcation?
Basically,
If
what
we
is
see
the point
IVUS,
is actually
we
this.
certainly can, and that is part of our
There's a
plan.
disparity of the size. One is a 4.5, other one is exact. And moreover, there is an aneurysmal enlargement just proximal to the bifurcation.
I think
So
doing an IVUS and finding out the length.
he is
from
going
the
to do an IVUS. By that,
normal
it will take time to do an IVUS, then we will go to the other lab.
So what we're doing is we're gonna hedge our bets, right? So we've got that little distal lesion, and I've just got the same 4.0 NC balloon that I'm going to use to post-dilate. I've put it down there, and I've taken it up to 9. And so I'm doing a very gentle balloon angioplasty. And if I get a stent-like result down there, then we can consider a DCB. If not, we can stent it.
If you have a dissection, I think.
Right? And we're going to end up IVUSing it anyway, so as Darshan said, why guess? Right?
Okay. I think
Down.
we can come down. Down.
Down. We don't need to guess.
You can take a shot.
1 second. This is post-dilated. We'll IVUS it first, and then okay. Go up there? Yeah, we will. I want to just post-dilate. 10, 12, 14, 16? Good.
Yeah, that's enough.
Down. Okay. And up. 16 is all right.
Proximal vessel is almost
In this
5.5.
case, actually, I will be doing a 38, 4, 38 and a 3.5, 48. Then you will be keeping with 2 stents and come out.
Yeah, we tried, Pratap. We didn't have a 48. The same cause. No, we didn't have a
No,
pilot
I'm just
200.
asking you because the stent numbers can reduce, you know.
Oh, you're 100% right.
We also do not want an overlap,
I couldn't agree more. Yeah.
By the time Stalin Roy can come to the stage and be ready for the lightning talk, because we will be giving 4 minutes for him to give a lightning talk.
18, sure. Yeah. 18, whatever you. 18.
Can you switch over to the lightning talk for 4 minutes? By the time we'll come back and take the final shots about the people and then finish it off.
I can give you a picture just before you go to the lightning.
Oh, no, 1 minute. Can you go to Sanjog again? He wants to see a picture.
Okay, I'll give you a picture right before the lightning talk.
100%,
and then
sure.
You can debate DCB versus stent during the lightning talk. Yeah. And just one more post-ill, and then I'll give you your picture.
20.
We'll wait.
20. 20. Okay.
Fluorostor, please.
Fluorostor.
You want nitro? A little bit of nitro. Thank you. Okay, here comes your
Give the balloon inside.
moment of truth.
Manuel, in these type of cases, you use a drug-eluting balloon in many cases or not?
No, I prefer the drug-eluting stent.
Stent.
In this case. No, because it's a big vessel, so it's a bifurcation, an important. And
all right, here comes your angiogram.
That the flow is excellent at the end of the CT also.
Oh, very good.
Very good.
So
The
who
POGO
wants to
result
do the
looks
stent
pretty
now?
good just by itself.
So you do an IVS and demonstrate there is no...
Because some of this might be spasm too, right?
No, Sanjog, you should do an IVS and say that we'll come back to you again for seeing the IVS.
That's exactly what we're going to do, my friend.
We'll come back to you in another
talk.
3-4 minutes and then be ready with
We'll be
IVS.
back right after your lightning talk.
Okay.
I'll give
We'll
you
go to the presentation. Go to the presentation, okay.
Good afternoon to all. Image-based approach to calcium management. As you all know, calcium is not only a problem for the patient, also for the operator. Now we have many tools for dealing with the calcium, but the problem is choosing the correct tool for the given lesion. So to help us with that, we have many imaging modalities. We have to utilize whatever is available to us at that point of time to the fullest. Coming to angiography, if there is angiography has a high specificity for calcium. So if there is if there is severe calcium, then usually the patient will require debulking. If there is moderate, we may be able to get away with without debulking. To decide whether moderate calcium lesions require debulking or not, we may have to do intracoronary imaging. There are 3 steps for doing an intracoronary imaging. That is pre-lesion preparation, where we assess the calcium morphology as well as the severity to decide on debulking modality, and post-lesion preparation to see if the lesion debulking is adequate or not, and finally for stent optimization. There are various IVS and OCT criteria. I'll touch upon the IVS criteria. If the calcium arc is more than 270 degree for 5 millimeters of the vessel, 1 point is given. If the arc is more than arc is 360, 1 point, nodule 1 point, and if the vessel diameter is less than 3.5, another point is given. If the patient has 3 or 4 points, then the risk of underexpansion is very high and the patient requires an debulking. Similarly, OCT also has a criteria where the arc is given 2 points, thickness 1 point, and length 1 point. Again, similarly, 3 or 4 requires atherectomy. This is a simplified algorithm for deciding on debulking modality. This is a very simple algorithm. If there is a decalcium, we may be able to get away with the cutting scoring on NC balloon. If there is a superficial calcium, then we may have to do an imaging to decide whether debulking is required or not. If the score is more than 2, either the OCT or the IVS score is more than 2, that is 3 or 4, then we may require debulking. The first choice is IVL because it's quite simple. But if the IVL catheter is not crossing, then we may have to go for rotablation or orbital atherectomy. Similarly, for a calcific nodule, the best option would be an orbital atherectomy. Also, rotational atherectomy can be done if the wire bias is favorable. I'll be showing a couple of case examples. This is a 74-year-old female who presented with STEMI inferior wall MI. It's a non-ST elevation MI with heart failure with reduced ejection fraction. This is the angiogram. We can see nodule sitting at the ostium of the LMCA and heavily calcified LAD with a critical stenosis at the middle AD just at the bend. This is the fluoroscopic image where we can see a nodule sitting at the ostium, a very tight calcific lesion just across the bend. These lesions are notorious. If you do rotational atherectomy, there is a very, very high chance that the burr might get stuck. So an ideal modality for this lesion would be an orbital atherectomy. We tried IVUS, but it was not crossing. You can see the nodule of the ostial LMCA, and there is significant calcium in the ostial LMCA as well as the ostial LAD. This is orbital atherectomy, where we can see very slow advancement of the burr across the bend. The burr got stuck a couple of times, but we were able to gradually pull it back by reverse ablation. And the distal part was ablated at 80K RPM, and the ostial LMCA part was ablated at 120K RPM, followed by preparation with cutting balloon and NC balloon. Here we can see the IVUS pictures. There is a clear-cut crack as well as nice shaving of the nodule in the LMCA, as well as significant luminal gain in the proximal part of the LAD. Right at the bend, we can see a crater which is formed in the calcified region with nice reverberation artifacts denoting there is significant debulking has taken place. And finally, stenting was done with help of guideliner with very good results. The post-IVUS results were excellent. Briefly, a second case. This is a 78-year-old female who presented with STEMI. Looks like a juicy, simple lesion, but nothing was crossing. Not even a CTO balloon was crossing with the help of guideliner. So rotational atherectomy was done. But again, after rotational atherectomy, the NC balloon was not opening. There was a significant outgoing. And this is IVUS image, which after rota, we can see a significant 360-degree calcium despite rota. So had to do IVL. So combining modalities helps us tackle such complex lesions. And this is the final results. Thank you.
Thank you, Stalin. Just exceeded only 40 seconds. We'll go to the live case. Can you just go to Sridhar Kasturi first? Sridhar first. He'll just wind up and then come back to Sridhar. You can actually take another 4 or 5 minutes to finalize everything and tell us.
Yeah, sure. Okay. Now go to the previous view, brother. LAD. Yeah. Go back to the place where we stopped. Ready, brother? Yeah, go to the next. Now we took the, no, go to the next. Sorry, I'm pressing. Go to the next. Sorry. It was my mistake. Now this is the stent what we took 40 mm into 3 Vivo ISAR, because in the covering the ostium to the, because distal left main there is some block. So area is about 7 and proximally 12. So then we thought of covering the end up to the septal branch. Go to the next. Go to the next. 3 into 40 mm stent. Go to the next. Covering up to the ostium. Go to the next. Now we are doing part. This is very essential. So because 3 mm vessel and almost 4.5 mm diameter of the left main, and if you put a wire subsequently without part, wire may go obliminally. It may lead to distortion of the stent. It may lead to longitudinal stent deformation. These are things. Once you develop the longitudinal stent deformation, it's very difficult to cross it with the wires and balloons. So you may not be able to introduce the hardware if you develop any LSD. So that's the reason, do the part, oppose it well in the left main. Subsequently, it also open the side branch origin very well. So we are doing the part with 4.5 into 8 mm balloon. Go to the next. Next. This is a part. Go to the next. Next. Here before Carina, we have placed the, now we see the post part, left main stent is very well expanded and side branch is flowing very well. LAD also flowing very well.
You do an OCT again?
Yeah, I am doing the second kissing. Go to the next.
Can you show the final OCT run?
No, I am doing the second kissing. I crossed with the wire. Go to the next. Now I am placing the dilated with 1.5. This is the 2.5 mm balloon in the, give me 3 mm balloon.
Already. Sorry.
Which one? This one. Okay. Now we are doing the final kissing, second kissing. Subsequently, I'll take the OCT image.
Sure.
Yeah, sure. Come closer. Now this is the placement of the LAD. Now go ahead, brother. Slightly, I'll pull this one.
So this is a final kissing, Sridhar?
Yeah, final kissing.
So what is the size of the balloon you used?
3 and 2.5.
Okay.
3.25. the part 4.5 mm. Go ahead. You
So
can go
LED
ahead.
proximal is you are thinking it is a 3.3 millimeter only, right?
Three only. But I will do subsequently with minimal. If I will do the OCT, if anything is required, I will go with the 3.5. Go slightly higher. Yeah, that. Definitely. Usually it will be 3.5 male patient.
Yeah, that is what I'm telling. You take a 3.5 and a 2.75 balloon and then going to the final pot and then one shot you can finish everything.
Yeah. I will see the OCT. If the MSA is good, then I leave it. If it's more than 7, 8 is there, that's we can.
Anyway.
I think,
Anyway.
I am removing the balloons. Then I will take the OCT catheter. I'll assess the.
Now next is actually you are going to take a OCT catheter?
Yeah.
Okay. When you prepare for the OCT, we'll just go to the Sanjog and come back. Again, we'll come back to you. Sanjog, please.
Sure.
Sanjog, can you show me the IVS pictures and final things?
We can hear you, sir.
Sanjog, please.
Yeah, just puff.
Yeah, so we did the IVS for the distal vessel. Result was quite good, but there was an intramural hematoma.
Up. Yeah, little puff again. Go ahead.
We had an intramural hematoma there, a dissection there,
just 12.
Which was we felt was quite significant. It was right.
We can show you the last IVUS if you'd like.
Lumen.
Yeah, no, we could see the dissection well, particularly with the hematoma in the media.
We'll just take a postal
deflate.
If the pre-dilation balloon would have been smaller, I think we went ahead and dilated with the 4.0.
The lumen was quite good,
we
but
could have avoided the dissection there.
Yeah, you could make that. Okay, go up to like 16, 18 here. You could make that argument. I mean, we could have taken a 3.5 down and tried to pre-dill it, but the hematoma there is not supraluminal obstructive. Yeah. Like I know a lot of people that would be comfortable just leaving that with a DCB.
Even the stent is actually hanging inside. 4 itself is insufficient. So I think the balloon is not the issue. He's actually having a plaque there.
Right?
So
the plaque.
we have to go with the stent. No question.
Here's your final. You do the honor, sir. Here's your final angio, so you can see it. Can you just come 25 or so, and we'll show you the whole shebang.
Yeah,
thank you. Okay. And here's your, and just center it, please. Okay, here's your final, sirs.
Hematoma is extended to the medium, right?
There you go.
Extensions there.
Pan, please. It's a big RCA. And we'll give you...
So Sanjog, what is the plan now?
We're done, sir.
We're done.
We'll do an IVUS.
Can you show the angio then?
Yeah, you just saw it.
They are not showing it.
No, now we just saw it.
Oh, very good. What is the size of the stent used finally?
Distally, I've got 3.516, which I'm going to take to 4.0. And proximally, I've taken 4.0s all the way up to 4.5. And there's your final result.
Okay, very good.
But the distal stent covered the bifurcation or...
No. I landed just proximal to the bifurcation.
Yeah.
There was a good landing zone there.
Yeah. So why get into the bifurcation if we don't have to, right? Can I have the 4.0 NC balloon?
But the stent is actually into the PLV or PDA. What do you put?
No. It terminates just proximal.
Just before the. Okay.
1 millimeter proximal to the PDA.
My God, how do you know that it is exactly 1 millimeter?
Because I IVUSed it and co-registered it. Aren't you the zero contrast guy? You know how to do that.
Wonderfully
Come on,
done.
You know how to do that. Good. Well, thank you, everybody. I hope...
Thank you very much, Sanjog. It was a wonderful case, and calcium lesion crossed with retrograde wiring and all. You showed excellently, demonstrated that. Thank you very much. We'll be seeing you in the hall after some time.
Back here
Thank you.
In just a little bit. The only note for the audience that's worth noting is that the whole case has taken 2 hours, 2.5 hours, right? And so it's to prove that this kind of work doesn't take that long. It's just a matter of using a set of basic principles, and it becomes relatively easy. We shouldn't be afraid of it because we think it'll take long. It doesn't take that long.
Sanjog, see you in the hall. Thank you very much.
Take care, everybody.
We'll go to the Sridhar's lab, please.
Bye-bye.
Sridhar, we are with you. Just show the OCT.
Give me some cotton gas.
You have 2 minutes more. 2 minutes.
Yeah, sure. The LED wire? This one.
By the time you wind it up, I'll take the
Is Ramaswamy removed? Yes. Go back. Just to show the previous views. Show the previous views. Where? Go back. Still, go back. So this is the final kissing what we did. And now 2.5 and 3. Go to the next. And then we did the repart. Then go to the next. This is the repart. Then take one angio. Then after that we'll take OCT. Okay? See, such a diffuse disease now nicely flowing, and the LAD LM is nicely flowing, and we did the right coronary, and LAD also we'll try to do if needed with a 3.5 balloon proximally. Still I feel some kind of underexpansion just before the, we'll do the 3.5, then we'll come back with a OCT image. Give 3.5 balloon. 3.5 NC.
Yeah. Sorry, did you do the OCT? Because if you did, we weren't able to see
No,
it.
we want to take OCT finally.
Oh,
so
okay.
already all steps are finished. After this 3.5 post dilatation, I'm going to do the final OCT image, and then I'm going to do the DEB application to the distal LAD. Because the angiographical is absolutely fine, no residual stenosis and no flow limiting dissection. This is the criteria for DEB. Suppose residual stenosis more than 30%, and if there is flow limiting dissection, definitely need some more optimization. Otherwise, go with the DEB or DES. But this is the ideal candidate because the distal LAD definitely with the scoring balloon, it is looking very good with good flow, and this will be available for future CABG also if it is required, because such a diffuse disease top to bottom, and then everything repaired. In the same sitting, we did the right coronary, and the LM bifurcation was done. Now only do the, see these procedures.
Sridhar, we are running in short of time. Can you just show the last shot and then we'll go to the next session?
Yeah, I'll do the dot and I will go with the one final image. 1 minute, only
1 minute.
Yeah, sure.
Okay.
Dilate, deflate, come back, dilate, come to yellow caudal, brother. Come to yellow caudal. Let me see the RC of the LAD. I think that is fine. Go ahead. Dilate, deflate. That's fine. Take one shot. No, take this yellow caudal. After that, we'll go to. Let it be there. Let it be. See, go to the epicranial. Enter LAD you show. Table. Now see.
Yeah, that was fantastic. That looks terrific. Thank you for an excellent demonstration of using image-guided DK crush there of the bifurcation. We're now going to change topics.
Thank you. It's wonderfully done, Sridhar. We'll see you in the afternoon again. Just come back. Thank you very much, Sridhar. Wonderful case. We'll go to the next session. It's actually a calcium management case, lecture session. Thank you, chairpersons. Dr. Ajay Swami, Dr. A. George Koshi, PC Rath, Kajal Ganguly, Raghav Sharma, Dr. P. Manokar, Dr. Guru Prakash, Mona Bhatia, Mayur K. Jain, Abhishek Gupta, Rajiv E. Murali Krishna. Then these other people can come forward and then start the session. First talk is by our CSI President, Dr. Vijay Bang. Please. No, it's all. Dr. Vijay Bang, sir, please come.
Chairpersons. If the mic will function, yeah. Good afternoon, everybody, and it's my great pleasure to introduce Dr. Vijay Bang, our President of the CSI. Without further ado, we'll start off our calcium management session, and with a humble request to all the speakers to try and help us finish in time. Thank you.
And slides forward and slides backward, can sir? Backward. This one. And slide forward. Yeah?
You point to this. Mouse pointer.
Huh?
ये वाला ये off.
Off के लिए. This is a slide change. Good. So, chairpersons, ladies and gentlemen, we have this, after that exciting live case session, we have the calcium modification session, and I'm going to cover today the calcium nodule. We know that calcium nodule is a different ball game, and management-wise, there is no guideline which tool is the best for debulking the calcium or managing the calcium. And how do we diagnose? On angiography, it may be very difficult to diagnose. Imaging is appropriate way to diagnose calcific nodule. Convex protrusion into the lumen, understandable. Irregular illuminal surface, which I will show you how it is seen on the imaging, and often significant calcium deposition proximal and distal to the lesion, which is seen as a sheet of calcium, associated with, it's a thrombocalcific lesion. So what is the prevalence? Prevalence is about 5% in the autopsy and 8% on OCT imaging. And often it is seen in patients with CKD, type 2 diabetes, hypertension, advancing age, and post-CABG. So what are the specific areas where it can be seen? Most often in RCA and 20% in left main bifurcation. It's a motion during the cardiac cycle thought to be related to forming a calcific nodule in the artery. So tortuous arteries do have issues, and there the calcific nodule can prosper and become troublesome. So advancing, as that we have covered already. So just to particularly highlight that you can see a before and after the bend. You can see a calcium sheet which is labeled there, and you can see a necrotic core. And then when heart contracts, that area particularly initiated the calcific nodule, which is at the bend. So about the 26 cases that have been highlighted, it's often seen in the tortuous artery, and necrotic core is there. It is predominantly, as I said, in RCA, and this is typically seen. So how will it be seen? This is an animated picture. We can understand there can be concentric calcium, eccentric or nodular calcium. And on imaging, the third picture is obviously the calcific nodule on OCT and in IVA's fourth picture. But when we expand, we zoom this picture, OCT picture, we can see calcific nodule very well. With those margins you can see are corrugated or jagged. That is where the thrombosis form. That's how it becomes atherothrombotic calcific lesion. And that's why it is difficult to manage. In IVAS, we can't identify because IVAS resolution is not that good, so we cannot identify what is there on the surface of the nodule, which was seen very well on OCT image. So what are the devices that we have applicable? We have balloon-based devices and we have atherectomy devices. And the new addition in atherectomy devices is, of course, laser and orbital atherectomy. And in the balloon IVL, we all know. So any of these tools can be used for management of the calcific nodule, but more often atherectomy is indicated. So if you go to see an algorithm which says that if eccentric lesion, which is nodular, is eccentric lesion, you can start with any of the balloons and you can ultimately decide atherectomy or no atherectomy. And you start with atherectomy and you have to go to the balloon. So it's a kind of dynamic use of devices which will decide practically on after use that which device will be better. So there is an algorithm which is discussed. Particularly, I am going to cover here the nodular algorithm, which says that if you have a nodule and if you confirm that it is a nodule on imaging, and if it is balloon crossable, you can use IVL. If not balloon crossable, then orbital atherectomy or rotational atherectomy is better. But rotational atherectomy requires a favorable wire bias. If the wire bias is not favorable, rotational atherectomy is not going to work because burr is not going to ablate the nodule. So in that orbital atherectomy, if the vessel is big, is most advisable. There are certain advantage and disadvantage. Once the lesion is debulked and you think it is on imaging, the calcium is cracked, then you can consider putting a DAS, then do a optimization with high pressure balloon, and the final imaging. This is the algorithm that is followed. Say suppose calcium is not cracked on imaging, then you can try ALCA in those particular subset of patients. So this is how algorithm has been currently existing, but there is no such fixed guideline. We still a research area. So how do we identify whether calcium is cracked on imaging? You can see that on the post-atherectomy images on the top, there is reverberation that is seen, which indicates that calcium is cracked, light can pass through. So, and then you can deploy the stent and images are good. One side is rotablator, other side is orbital atherectomy. But sometimes you don't see that well the stent expanded, so you may see a asymmetrical expansion of the stent with a D-shaped, which is seen rarely, but results are not, long-term results are affected due to D-shaping of any of these post-stent due to calcium. So what are the challenges? It leads to higher thrombosis, higher ISR. Everything is higher, even for that matter, sudden death is known. Everything is higher in calcific nodule. So several mechanisms are purported. Stent under expansion, that is the most important cause, or asymmetrical or buckling of the stent. Stent malposition, which is very well known, fracture of the stent, repeated fracture of the stent, not immediately, but after some time stent is deployed, patient may present with ACS, and those patients may have a fractured stent. The age dissection, because you use high pressure balloon, age dissections are possible. Protrusion of the calcific nodule through the stent cell is also possible. And not only that, the de novo calcific nodule can be developed under the neointimal and previously deployed stent, neointimal hyperplasia. So there are, we know rotational atherectomy. Only thing that is to be remembered that when you use rotational atherectomy, you must do imaging, find out whether wire bias is favorable or unfavorable. If it is unfavorable, then rotational atherectomy is of no use. So then we can switch over to other modalities of atherectomy. So what are the other modality is orbital atherectomy. Advantage with orbital atherectomy that it can ablate both ways when you do the packing. And results are very good in large vessels. Stuck burr is almost unknown in this. Wire bias is very little, if at all it is there. So in a way, this technology is a good substitute in patients where rotational atherectomy is, but rotational atherectomy is very effective in the very tight lesion, calcific lesion, where nothing is passing. So next, if nothing is working, you can try IVL. Sometimes we have to try rotatripsy. So we can try IVL if the calcium cracking is not enough, and we can see that energy is delivered. It can cut deep and the superficial calcium. Once calcium is cracked, seen on the imaging, you can deploy the stent. It can fully expand. The most important thing is expansion of the stent. Now coming to the laser, we all know laser is a new technology. How it works is a very unique way of threefold action. And one is the light which breaks the molecular bond. Second, that is a sonic pulse, which modifies the vessel compliance. And third is the bubble which is very effective in debulking the morphology of the calcium. So this is the advantage with laser, and then of course we are aware of these score flex and cutting balloon and opium. I have some experience with a very bad lesion at the origin of the LAD and crossing into left main. Classical nodule, very big one, very thick nodule. It was opened. I could not show that case here. I opened it only with the cutting balloon because it's so tight. It was not going to work anything else. Cutting balloon worked here. So there is no fear of, if we compress the nodule with the high balloon pressure, that it will go on the other side. With the cutting balloon, it doesn't happen. Either it will cut or it will not be effective. So calcific nodules are relatively rare, but they are not uncommon, and more commonly found in patients with diabetic that we have discussed. But the problem is post-intervention, everything mass rate, everything is high, but there is still a research required in this particular area to optimally manage the calcific nodule. Thank you very much for kind attention.
Thank you very much, sir. So we understand that for reliable diagnosis of calcific nodule, you require an OCT most of the time.
Absolutely, correct.
And if you identify a calcific nodule, very often you require either an orbital atherectomy or laser, excimer laser.
In case,
very often.
Yeah, very often. But in case where there is unfavorable wire bias on ROTA, because ROTA is technology which we know, but there are many people who don't want to use ROTA. For them, IVL is the balloon-based technology is good.
But many times this will be associated with other types of calcium. So
Of
ultimately the calcium
Of course,
management
there is
is
a sheet
required.
of calcium on the either side of the vessel. No deal.
Can we move to the next talk?
Thank you very much.
Dr. Deepak for his presentation.
Good evening to all of you. I would still thank Pratap sir and the organizers for having given me this opportunity. Well, I'll start with the case history of a 70-year-old gentleman. Post-angioplasty to the circumflex, the stent could not be properly deployed at that point of time. He presented to a nearby hospital with rest angina. Troponin was positive, so was taken up for angiographic evaluation. You could see that the circumflex has got the stent and there is significant restenosis over there, and you could also see that the stent is underexpanded in the circumflex territory. In the second image, you could see that the OM1 has got a very critical stenosis, and you could see in the stent boost that the stent in the mid portion, it's not properly expanded. So they tried to open up the vessel with multiple non-compliant balloons. They wired the OM1, OM2, multiple balloon dilatation. It was not possible to open it up, so was referred to us for a possible stent ablation. These were the images taken in our cath lab. The first one, you could see that the stent is underexpanded in the mid portion. Second image, you could see that the OM1 and OM2 is flowing well, and there is a tight stenosis in the stented segment with an underexpansion. Well, we started off with a 1.25 millimeter burr at 160,000 RPM. We were gentle with the lesion initially. You could see that we were able to make some progress into that particular under-deployed stent. It wouldn't move distally, so we had to increase the RPM to 180,000 and even 200,000 RPM. Well, even at 200,000 RPM, we were not able to get across the lesion. Now, how does stent ablation work? There are three mechanisms. One, it ablates, cuts, or pulverizes the stent struts. Secondly, it ablates the calcium that protrudes through the struts, and once the struts are ablated, then the calcium, superficial calcium can be ablated. Thirdly, most importantly, heat generated leads to thermal injury that liquefies the stent as well as calcium, which makes it more supple so that you'll be able to dilate with a high pressure balloon. So nearly 12 runs of 15 seconds each, one is 160,000, 180 and 200,000 RPM. Not able to get across the lesion. Patient developed angina, slow flow, So we had to remove the burr. You could see that the flow inside the vessel is not so good. So at this point of time, we thought that we have done enough of burring. Even the thermal injury, probably we'll be able to dilate with a high pressure balloon. We tried to go in with an OPN balloon. The OPN balloon wouldn't track it to that. However, we tried to get with a non-compliant balloon. Non-compliant balloon would track it, but then we were not able to open it. Now we switched over to the next New York burr, the second new burr. That's a 1.5 millimeter burr. Started off with 160,000 RPM, increased to 180,000 RPM, and again even up to 200,000 RPM. Some point of time, I started becoming impatient and try. You could see in the first image that I was trying to do the burring. You could see the guide catheter is backing out, which should not be done at any point of time during rotablation. Try to resist the idea of pushing it through and kept on burring it. Again, another 10 runs. So we used two burrs, 1.5, 1.25. We were not able to get across. We again had started seeing slow flow inside that. So we again thought that probably the thermal injury would help. Again, we started trying with the non-compliant balloon and the OPN balloons. The non-compliant balloon would go into the lesion. However, we are not able to open it. And the OPN balloons, it would partially go into the lesion. It wouldn't really get into the narrowest part of the vessel. So at this point of time, we couldn't do anything much. It was almost 1.5 to 2 hours at this point of time. Then again, we moved on to a third burr. This was a 1.5 millimeter burr. The third one, the new burr. And at this point of time, you could see that we were able to get across. Then you could see that we were doing the polishing run and finally went ahead with bifurcation stent implantation, opened up well, and we could achieve a good result. Well, is stent ablation dangerous? Well, you could have two complications. Perforations are very rare. You could have a stent stuck burr in approximately 10% of situations if you're very aggressive with pecking movement, and if you're very aggressive with the ablation, you're likely to have a stuck burr, and you could also have slow flow with aggressive burring. And what about particle size that's produced during the stent ablation? It's a 2009 Japanese article that says that 90% of particles generated is 5 microns. It flows through the microcirculation taken away by the reticuloendothelial system. However, a porcine model 2012 article, 80% of particles are less than 5 microns. However, 95% particles less than 15 microns in size. This is a very interesting article, a Japanese article, it's a case study. Proximal LED under expanded stent, 1.75 millimeter rotablation, stent ablation was done, stented, and you could see in the second image that the distal portion of the stent has been totally ablated off. And what is interesting was that they assessed the index of microvascular resistance also. Pre-procedure, the microvascular resistance was 19. Post-procedure, it was 31. It increased transiently, and they brought the patient back after 1 month, and they found out that the microvascular resistance has come down. So whatever said and done, whatever small particles that go down, that can at least lead on to microvascular obstruction, and that can lead on to trouble. Well, what should be the ideal technique of doing a stent ablation? Most important thing, be gentle with the under-deployed stent. Try to advance the rotawire over a microcatheter because you have an under-expanded stent. If you try to meddle with the floppy wire, you might damage the rotawire. So it's good to have a workhorse wire used, then a microcatheter, and then exchange with the rotafloppy. Start with a smaller burr, 1.25 or 1.5. Step up the burr size in most of the situation, not exceeding 0.6. Burr to artery ratio, lower speeds preferable, 160,000 RPM, shorter runs, 15 seconds. Give a better breathing space, at least wait for 1 minute before you go for the next run. Avoid more than 5,000 drop in RPM, or never try to push the burr through. And if at all you have to wait or you have to continue for more than 10 runs, hope that you have eroded, the burr has been eroded, the burr has become bald, and switch over to a new burr. Now, why would you want to switch over to a new burr? This is an electromicroscopic study. You could see that the rose arrow, it points towards the diamond chips, and you can see the green arrows that's looking at the diamond pits. What has happened is when you do a stent ablation, these diamond chips, that they get eroded away. So maximum beating happens with the first burr. So with the first burr, if you're not able to cross the lesion after 10 times of 10 runs, probably you need to switch over to a second burr. This is another patient who had a dextrocardia, proximal LED, ostial and LED stent implantation. You could see in the second image that that particular area, the stent is totally underdeployed, which was done long ago, and you could also see that there is significant amount of calcification. Went through the femoral approach. That's the first image. You can see that the ostial LED is totally stenosed and an under-deployed stent or under-expanded stent in the proximal left-handed descending artery. We inverted the images. In the second image, you can clearly see the stent over there, which is totally under-deployed stent in the proximal left-handed descending artery. Again, the same procedure, 7 French guide catheter, 1.25 millimeter per 1.5 millimeter per 180,000 RPM, 200,000 RPM. And finally, we were able to get across nearly birth time of almost 4 minutes. Once we were done with that, we did a balloon dilatation that was in cutting balloon, and following that, you could see in the second IOS run, you could see that the ostial LED is almost a 3.5 millimeter vessel, and the stent seems to be so much under deployed. Mind you, it was after the rotablation as well as balloon dilatation. You can also see some calcification over there. Finally, multiple balloon dilatations, we were able to stent that post dilatations, and that was the final result. You could see that the ostial LED is well expanded. These are the pre and post procedure images of this particular same patient. Well, what does the data say regarding stent ablation? An article published in 2019 says that success rates are quite good, nearly 100%. However, the MACE at the end of 1 year is approximately 40%. This was an article published in Euro Intervention 2016, 12 patients stent ablation. The overall MACE at 6 months was almost 50%, and the mortality was almost 25%. And the burr entrapment was on nearly 0% in this particular study. What is very interesting down there is every time you want to be very gentle while doing stent ablation, and you always tend to say that more than 5,000 deceleration should be avoided. But then they made out that 100% of patients they had deceleration more than 5,000, which means that when you want to do a stent ablation, you have to be really hard onto the lesion. So in closing, dear friends, technical success of stent ablation is extremely high. Be cautious about with respect to stuck burr and slow flow. Despite good initial success, the long-term MACE seems to be plentiful. So the most important point in preventing to avoiding stent ablation would be preparing the lesion. When every time you see a lesion, prepare this lesion well, deploy the stent well, so that you do not have an under expansion, do not have to go in for stent ablation, and that's how you could avoid long-term problems with the patient. Thank you so much for your patience.
Very nice presentation, Dr. Deepak. I have a couple of questions to ask you. Why should you start with a lower size burr, number one? Number two, you upgraded 3 burrs. You started with 1.25, you went to 1.5. If you see the distal vessel diameter, it is more than 3 millimeter. Why didn't you opt for a bigger size burr? As per the trial, you see the burr to distal artery ratio, if it is around 0.5, 0.6, you choose burr like that. So don't you think so? One burr. And lastly, at the point where you had the stenosis, you should have gone at lower RPM and churned and cut the stent studs and then proceeded further rather than touching and coming back.
Yes, I have the answer for both the questions.
Yeah, please.
Well, it's always recommended when you want to have a stent ablation, always start with the smallest possible size, because you go with a higher size, the chance of going across will be less likely. Secondly, if you go across also, again, the chance of stuck burr is more with bigger size. So it's always recommended start 1.25 or 1.5. The second point is regarding, what is the second point that you asked?
What I asked was the size of burr. You have told that, and then why did you go at low
okay,
RPM?
the slow speeds.
Yes.
Yeah, it's also recommended that there has been a study, not with the stent ablation, wherein you in uncrossable lesions cross at very high pressures, and then they actually, let's say 200,000 RPM, they cross the lesion, and again they slowed the RPMs to 140,000 and all. They stayed at the lesion, hoping that you would get a better luminal gain. But then the OCT has proven that it's not going to be of use. So primarily, you just have to go across at whatever speeds are possible without getting the stent stuck and the burrs getting stuck over there.
Exactly. That is the point I want to make. It is not like a lesion what you're crossing. If it is a tight calcified lesion, you go at high RPM, cross it, come back. It is a strut sitting there, which you have to churn, you have to cut, and you have to cross the lesion.
Okay.
So that is what you go at low RPM, choose a bigger size burr, and probably you could have got it done easily.
It's a really fascinating discussion. I think stent ablation is not for the faint-hearted. I don't think even the most experienced rotablators have had more than 4 or 5 cases in their entire career. I think Deepak has summarized it fantastically. I don't think anything that he said can be replaced by even a word can be changed. I think it's perfect. It matches with our experience. We'll move on to the next talk.
Thank you
Dr.
so
Claire,
much. Thank you.
Dr. Praveen Chandra. Right, so there's a little change in schedule there. So Dr. Praveen Chandra will be speaking on role of ELCA in calcified ISR.
That speaker is not there.
I don't.
He's there.
So since this session is slightly delayed and there is another session at the same time, so I requested Dr. Claire to just let me do this presentation. I'll finish very quickly though. And however, this session of ELCA and ISR, and it also said calcified ISR. So in fact, let me tell you at the very outset that ELCA is not the primary device for calcific lesions. It is a good device for in-stent restenosis. So I'm going to share with you all my experience and the data which we have for ELCA and ISR lesions. So since we already know that complex lesions are coming our way all the day, and we see all these complex lesions being treated during the live cases also. So where do we do laser or ELCA these days? So in balloon uncrossable lesions or resistant lesions, complex lesions, vessel preparations where we were doing bioabsorbable scaffolds, and ISR preparation for either a drug-eluting balloon or a drug-eluting stent before doing that to take care of the neointimal proliferation. Because we still do not have a final answer as to how we treat neointimal proliferation. And then, of course, thrombus in acute MI and also in occluded vein grafts, it has shown some good outcomes. So this is the catheter which we use, which uses the light spectrum. And when we do this, definitely, there are certain issues which we have to keep in mind, that we have to keep flushing while we are doing the laser, advancing at a slow speed, and then controlling the fluence. Fluence means energy, and the pulses means the speed. So that we control. There's the console, which I'll show you, and this console controls that. And the vessel to ratio, the catheter ratio, generally the 0.9 catheter is good for most of these patients. So typically 90% times you will be using a 0.9 catheter. So there are 1.9, 1.4, 1.7. But 0.9 is very safe, very good. So ISR, of course, ISR is something which we still do not know what is the best treatment for that. We still are trying to grapple with this problem, and it is still existing, despite all the best possible drug-eluting stents. So how do we treat that? So I'm just showing you some cases. And this is a patient who comes as a young patient and has a very nicely done stent to start with. And when he comes to us, this is the situation. This small, very small stent that also is restenosed. And this can happen. We see that. There's nothing new about it. So how do we handle this? This is a young patient. So should we put another stent here? There will be 2 stents. If he has a restenosis, there will be 3 stents. So we have to make a plan so that in this young patient, we treat it without a stent. So in this kind of situation, our dominant strategy these days is to do a laser ablation of this neointimal proliferation, and then followed by cutting balloon, which is a Wolverine these days, and followed by a drug-eluting balloon. So these are the kind of results. This is a fairly simple case, I must say, where we can use this technology and get good results without putting an additional stent. So that was the premise on which we used this device initially. Then, of course, we have other kind of cases, as you can see here. Now, this is a slightly more complex situation where you see that there is a stent here in the middle, and this stent is basically, partly it is okay, there is some restenosis, but proximal to that, there is a tight stenosis. And it is going up to almost to the ostium. How do we treat this? You can put another stent, but before putting a stent, definitely we need to debulk this because this patient is needing, because the vessel is not too big, it is about 3 millimeter in size. So we do debulking with the laser and followed by again a Wolverine, and then followed by a stent here in the proximal segment. So this is how we can combine the effects of these technologies together to get the best outcomes in these kind of situations. Then, of course, you can see a vein graft like this. And this vein graft was very tight. This patient is having acute, coronary syndrome. So how do we handle the situation? So in this, even putting a wire was difficult. So wire was put, the balloon is not crossing. So how do we do this? So we put a laser here. We lase it and followed by laser. So what laser does is, it takes care of both the stenosis and also the material which is inside, the degenerative material in the vein graft. And that also maybe, this is what we have seen. We do not have a randomized controlled trial on that, how it compares with the distal protection device. But in this patient, we didn't use any distal protection. We did a laser followed by a stent implantation, and we got a good outcome with no slow flow, etc. So this is another application which we do, especially in these kind of situations. Now, this is a kind of patient which is very, very bad patient. Here you see this patient already had 2 stents, and 2 times actually. And so this is a 2 layer of stents up there, and there is 1 layer of stent down there. So what do we do in this patient comes again? So in this patient, definitely, we cross this lesion with a, I think this was a Fielder XT wire, followed by a laser. So we did the laser catheter moves down slowly, and then followed by balloon inflations. And after this, we find this kind of outcome. What do? No more stents. So here we do more dilatations using, again, 1-to-1 balloon using cutting balloons. And these are the laser runs, which we do again. And then finally, we were able to get a very good outcome here, very good flow in this entire RCA. And then what we do is we do a drug-eluting balloon from bottom till up. So these are 2 or I think 3 drug-eluting balloons, long balloons, because the longest is 40 only. So we used, I think, 2 or 3 balloons here. And here we can see that this is a, and we do about more than 1 to 1.5 minutes inflation and get very good results in these kind of situations, as you will see here. So this is the final outcome here in this case, which was looking quite bad. And normally we would have just put some more stents also. Finally, in some very more difficult situations like this, here you can see that there is a left main which was stented. Left main to LAD and circumflex bifurcation stenting has been done, and this patient comes with an in-stent restenosis. How do you treat that? You can't put more stents here. So we again try to first, wiring was an issue here because you have to go from the main, through the stent, not from the sides, because the stent is hanging outside the left main. And this is a thing which can happen. As you can see here, even the guide was not really helping us. So we tried to do some maneuvers, tried to, do wiring from little away, and then did, wiring to both the LAD and the circumflex. Did IVUS to check whether we are in the true lumen or from the side. So we confirmed that yes, we are okay. And then after that, of course, we started doing, this laser. This is, I think, some mix-up here. And so we did initial dilatations followed by laser passage into the circumflex, and then cutting balloon, and then followed by drug-eluting balloons. So here you can see that we have to treat this with drug-eluting balloons, 2 drug-eluting balloons, LAD and circumflex, and the final result looks quite effective and promising without putting any additional stents, and this patient is doing very well. So basically, this is some kind of I must say, a hypothesis which is generated now, and using these technologies together might help in-stent restenosis, and the data is there. Some data has been already there. So at the end, I must say, why use ELCA and ICER? Because it is effective, it is safe for debulking, it has a potential for greater vessel and stent expansion, and potential for additional stent placements if required, and distal embolization also is reduced in this kind of situation. So I think, in in-stent restenosis, definitely it's a very good additional adjunct tool which can help getting better outcomes. But for calcified lesions, in the end, I must say that it is only for mild to moderate calcific, fibrocalcific lesions. If nothing is crossing, you can use to cross the lesion. But definitively, therapy has to be done with either a shock wave or a whatever you want to do, cutting balloon, etc. Thank you very much.
Excellent talk, sir. So the previous case they mentioned, so such kind of under-expansion, there is any data with such laser use in such patients?
Yeah. So basically, we have to definitely identify what is the reason for this in-stent restenosis, whether it was a heavy calcium which did not let the stent expand. So if it was an inadequate stent expansion to start with, you have to do with a either a rota or a shock wave, but if it is primarily new intimal proliferation, you can do this.
Thank you, sir. Thank you, sir.
Thank you.
Now we would like to invite Dr. T.S. Clare to deliver his talk.
Well, I think my talk more or less has been covered by the previous speakers, so I will be brief. How do you move? Okay, why calcium matters? I think we have heard a lot of speakers talking about calcium. One thing is very clear that more and more calcium we have to deal. Why? Because increasing age of people and more complex lesions we are doing now. More and more patients don't want surgery. In fact, now any patient who's more than 75, I think 3 times before sending him to surgery. So even the patients want that, and we also know that with increasing age, more diabetes, more kidney disease, calcium is very common in these patients. Roughly, if you see the pooled data, roughly 30% of the patients will have significant moderate to heavy calcification if you see various trials. And these are the lesion classification. Again, the complex lesions are increasing in PCA again because new technology and less and less acceptance by the patient for bypass surgery. So we also know that calcium leads to poor outcomes, and it's not a new information. So as far as possible, all the, the endpoints, death, myocardial infarction, TVR, everything is more in these patients. And these are also, again, data from various trials to show that how in mild, moderate, severe calcification, how the results are getting bad. So one thing is very clear that when we have a calcium, first of all, I think most important thing is that the angiogram should be reviewed very thoroughly. We should sit on the angiogram, see very well, and not only sometimes you get angiograms from the peripheral centers where the angiogram is not up to the mark, so you should not decide on basis of that. You take another pictures in your own lab and then have a assessment of the lesion. And if you are plus minus that you are moderate calcification, should I do developing, should I not do developing? I think one of the things which can help you is do imaging. But again, a caution is that you should do imaging if you know imaging. I've seen many people doing imaging, but hardly having really grasp of the imaging. So any technology, if you want to use for the benefit of the patient, you should have a very clear understanding of that technology. So if you think about the management, I think we have already talked about it. So there are imaging we have listened from the previous speakers. OCT to me looks a little bit better because it gives you more depth and study of the nodules than the IVS. But whatever technology you have in the lab, you must use to clarify these lesions and make a plan how to deal with these patients. So I think depending upon the degree and the arc, the length of this, you don't want only to know calcium, you want to know whether it is intimal, whether it is deep calcium, how much the length of the calcium, and whether it is a nodule or no nodule. So all those things matter. And one thing which is worse in CAD is that if you have a calcification over a bend, that is the worst combination. There you have to be doubly cautious to deal with these cases. So I think we have cutting balloons, we have scoring balloons, and we have the OPN balloons. We have the lithotripsy, these are balloon technologies. Then you have the ablative technology like rotational atherectomy, excimer laser, just heard Purveen Chandra, and you have orbital, these are the, balloons which you have heard. But these balloons work only in mild to moderate calcification. Or they work when you have done some debulking. Then these balloons are more useful rather than just the single technology to help you in these patients. So lithotripsy is another very good armamentarian we have got in the calcified lesion. The only thing is that the balloon, it will not go through in many of the tight lesions where you may have to use rotablation before using this technology. So I think everybody knows about these patients. I will just show you 2 cases rather than talking theoretically. I think this is one case, 72 years of male, post-bypass surgery, Lima to LAD, and he came with severe angina, and this is the lesion. Heavily calcified, 90-degree bend, and we couldn't cross first with the, we tried BMW wire, but even the nano balloon will not go through. So then what to do? Fortunately, I got across the rota wire, and then we debulked with the rota ablation. The first is 1.25 word. Took quite some time to cross this bend. It's not only immediately. See, the thing is, in rota ablation, you have to be very, very patient. Never push. That's my philosophy. Never push the burr. Otherwise, if you push it, you will have a stuck burr. So after that, we did the imaging, which showed a lot of amount of calcium. Before that, there was no question of imaging because nothing was going. That's the picture in the Hybiz. And then we did the 1.75 burr. Then we did the balloon dilatation. There was a distal lesion as well. This is, I think, we deployed the stent, dilated the left main area with the 4 into 15 atmospheres, and we got a very good result in this patient. This patient you could not do before without rota ablation, and the best results will be if you use Hybiz at the same time. We got very good MLA, the left main 12.57 and in the proximal circle 11.64 in this patient. This is a very interesting case. People have been talking about a stent, in-stent restenosis and how to deal with that. My thinking is that any stent, if you come to restenosis, first of all, if possible, study with the Hybiz or the OCT to understand the mechanism of restenosis. See, like this patient had a proximal LED stent, then he had another ACS. So somebody deployed the stent, and if you see carefully, the stent didn't dilate. You can see very clearly there is a dumbling in this patient. And in that process, he left the wire also, and the patient came next day with the unstable angina, and the stent had occluded. So cross with the wire, and believe me, even it was difficult to go with 1.5 new balloon, very hard to go through, and I used many balloons. Fractured, I think, almost like 8-9 balloons. Three OPN balloons were, but this dumbbell will not go. It will remain as it is. So I didn't have IVL that time, but then I called the IVL people, and they took some time to come. It was already 3 hours into the procedure. So did IVL, and after IVL, I was able to expand the stent. And then there was a question of this wire hanging there. Ultimately, I tried to remove this distal wire, but I could not. So I exteriorized with another stent and got a good result in this patient. So this is the final result of this patient, which is very acceptable. So the lesson from this patient is to anybody, particularly the beginners, don't deploy stent until and unless you have prepared the bed for it. And how to know about the bed, whether you are happy. One is the simple method is to see how the balloon expands, but more important will be if you can do after balloon dilatation, do the Hybiz, that how your lesion has opened, whether it is ready for the acceptance of the stent or not. So this is ultimately, these are the kind of armamentarium which I had to use in this patient, and bill was very high in this patient. So in conclusion, significant coronary calcification is seen in 20 to 30% of the patients. A critical analysis of the angiogram should be done before planning PCI. I think just looking at the angiograms, to my mind, is very important rather than just jumping to the imaging. Imaging does help in these patients. A moderate calcification and a doubt of developing should be cleared by imaging, which acts as a guide for a plaque modification. In general, my philosophy is whenever you are thinking, should I use a debulking rota or not, use it rather than not using, because you will repent if you don't use it. And I think it is not a good idea to produce dissections before you start rota ablation. So rota ablation should be known to every interventional cardiologist. I tell you why. Because you will find lesions where your IVL balloon will not go, maybe then you may have to use a laser, but everybody doesn't have laser. So rotablation is something which is indispensable, according to me, to deal with calcium lesion. There is no doubt that imaging guided PCI of calcified lesion with the proper developing gives better immediate and long-term results. Thank you very much for your kind attention.
Thank you so much, Dr. Clare. That was an excellent talk. It was great to hear all the different evolving methods and methodologies that are there in the system today and all the armamentarium that you have. I was just wondering that, yes, we go to the OCT and the Hybiz, but do you ever think of doing a CT before you start these patients, and whether non-invasive imaging? Because I do realize that now we're talking about plaque more than whether in stenosis or anything else.
Right,
and when we're talking about CT, we now can even tell between necrosis and intimal thickening with lipid to necrosis, which could actually lead to plaque rupture, and then calcification, extent of calcification, depth of calcification, and even the extent. So do you feel that CT would be of any use to these patients?
Yes, CT will be very useful if you are doing a CTO, because you do not know the health of distal vessel and you cannot study these patients. If you have a CTO, CT angiogram, I think should be almost mandatory. But again, you should have capability of yourself assessing the CT. Don't depend only on the radiologist. You should know yourself how to interpret those pictures. As far as the imaging is concerned, if it's a very tight lesion, I don't, try to do imaging. If it goes very simply, I do it. Otherwise, I dilate or I do 1.25 bar, then do imaging so that the patient is stable.
So I think the important thing is also that if you have a CT scan, you can definitely get it mapped into your interventional radiology suite, interventional cardiology suite, and then you can actually link the two so that you can take it as a railroading procedure, especially in the CTO.
So in a CTO, for example, if you have to, if you have an uncrossable lesion, like Praveen Chandra was saying, the laser, if you know the anatomy by CT, you can direct your laser to cross the lesion. So that way it is very useful.
Right.
I think
great. Thank you so much.
Fascinating discussion, but we'll have to cut it short for lack of time.
Yeah, so I'm going to invite our next speaker. Thank you, Dr. Clare. Thank you so much. So we're going to invite our next speaker, which is Dr. R. Shivakumar. He's going to be speaking on technical consideration for safe and effective rotablation tips and tricks. Over to you, sir.
Good evening to all. It is understandable that it is 20% of all cath lab lesions. It is increasing because of advancing age, hypertension, diabetes, and it becomes routine in day-to-day practice. And not properly dealing will lead to not only short-term, long-term poor outcome. The principle here is differential cutting and orthogonal displacement. Orthogonal displacement of friction, I mean during high-speed rotation, there is a longitudinal friction vector between the wire and burr, which makes a circumferential direction which facilitates the burr to advance in a challenging lesions. Differential cutting, I mean the inelastic tissue will get cut, whereas an elastic tissue will deflate away from the burr. If you compare the prepare calcium trial against older time Rotaxas trial, physicians have moved to radial, more complex lesions, but still safety was preserved, and 6 French guides for most of the time. Burr-to ratio was more than 0.5. Design class were used, Rota Pro were used, and intravascular imaging was used. And 2018, EAC endorses this device in selected cases for a heavy calcification. And the definite indication is 360-degree arc, napkin ring, and Hybiz OCT microcatheter is not able to cross. Possible indication will be 180-degree arc. High-risk lesions will be lesions with the thrombus, dissection, and lesions with an angle and bypass graft. And last remaining with vessel with the compromised LV function, one should differ. And upfront rotational atherectomy is chosen by most of the senior operators. Non-senior operators start with balloon, but even in that group, I suggest provisional rotational atherectomy. Take lesser time, low threshold to convert to the rotational atherectomy rather than rescue, getting into complication. Putting a stent and ablating the stent is not the way to do it. And get the burr, do the job before the dissection prevents you that. And you need to consider in a left main trunk with LV dysfunction, hemodynamic support. In a CTO, if the calcified CTO is nothing is crossing. In a low EF also, again, LV assist device. In a bifurcation, final result will be good if you ablate well with the calcium. And calcific nodule, it was banked by our president. When there is a bias, it works. In ACS, data is nice, encouraging data is coming up. So I will take you through some 10 or 11 steps. Step 1 is a good BP in a patient, hold beta blockers. In a chip kind of a scenario, don't hesitate to take the help of assist device. A temporary pacemaker, when you think it's going to save you the day. And I will consider assist device particularly when there is a single remaining vessel, longulated lesions, long lesions, unprotected left main, and multi-vessels diffuse disease. And you know that even during complication, you may not be able to refer the patient to CABG. You cannot suddenly now find a patient for operable. It's inoperable to begin with, and during complication also it is inoperable. So you need to begin with the assist device. Senior operators may defer temporary pacemaker because of the pacemaker-induced perf. They think a short run may not push them into arrhythmic disturbance, or they can get away with a cough reflex. So then coming back to selecting the burr size, it's been already said, ratio, then I would like, by default, it's 1.5 burr, because 1.25 can end up in a trap. If it is a larger lesions, LMC alike, then 1.75 burr. The modern trend is single burr. So single burr with a low speed, it is equivalent to poor man's upsizing the burr, but sometimes you may have to do a second burr for effective lesion modification. When it is tortuous, CTO, severely calcified, then you have to start with 1.25 burr. If your default strategy is 1.5 in a vessel size of 2.5, in a vessel size of 3.5, it will be 1.75 burr. Having taken the 1.5 burr, if you think it is not working, then you have to downsize. In a case of 1.25 burr, whether it's a diamond fatigue or it has not really ablated, then you may have to upsize. Regarding various sizes of the burr, as the burr size advances, the area of diamond coating against the non-diamond coating becomes more. Look at the burr size of 1.5. The diamond coated area is almost more than the non-diamond area. So that's the reason why in a 1.25 burr with a lesser diamond area with a high speed, you don't ablate, you just cross and trap. Whereas in a 1.5 burr where the diamond area is more with a sensible speed, you ablate and you are doing a safe, effective ablation. So these are by default, I said 1.5. Sometimes you may have to downgrade to 1.25. Sometimes with 1.25, you may have to add a rota extra support wire to facilitate the burr, or sometimes you have to go back to the 1.5 burr again with a support wire. So this is the reason behind is the support wire against a floppy wire gives a better bias for the burr to advance. Whereas 1.25 burr, one cannot omit 1.25 burr in our practice because the penetration force is good, whereas 1.5, the diamond area is good. So the guide should be coaxial. We can prefer a side hole, and you can, finally, if you think you are going to upsize the burr, your guide should accommodate your final size. And 6 French will accommodate 1.25 and 1.5, 7 for 1.75, and for 2 burr it is 8. Coaxiality, this is what I mean. Sometimes you see in LAO, but it may not be coaxial in RAO. This is a non-coaxiality in LAO. This is a non-coaxiality in RAO in an animation. Why it is difficult in an RCA osteal lesions? Because in LAO it will look like coaxial, but in RAO, in a cranial view, it doesn't look coaxial. That's why in RCA osteal lesions, rotational arthrotomy is demanding because coaxially engaging as well as maintaining coaxiality is demanding. Regarding the floppy wire with extra support, the tapering is long in floppy, short in extra support, whereas the tip spring coil is larger in extra support, whereas shorter in floppy. Why I have to discuss this floppy versus extra support? Because the floppy wire with a tapered long and lesser diameter can ablate the calcium at the greater curvature, which is other way for extra support for ablating the calcium in lesser curvature. This is just an animation where 2 guides, multiple wires, which is talking about wire bias, favorable as well as unfavorable to play with your burr. And regarding guide wire precautions, keep it as distal as possible, keep it in a larger vessel, make sure there is no, make sure you have put a wire clip torquer, and make sure there is no loop up front of the ostium after the guide, otherwise the rota will cut. And when you park it as distal as possible, then you get a better support for the burr to go in. And don't park your wire in a small branch. You may perforate during spinning. And this is about your favorable bias. When you sense your wire is crossing through the in contact with the, not in contact with the calcific plaque. I mean, it is in contact with the non-calcific plaque, then you end up in dissection. So sometimes you can pull the wire. Stands for drip, R stands for activating the burr outside with the knob tightened up, and then you advance the knob should be moved whether it is working. Then wire you should make sure the brake defeat is working, and then you advance the burr with take it proximal 1 to 2 centimeter proximal to the lesion. Either you can by single operator by pulling the wire and pushing the burr, or by activating the dyno glide. This is by once you reach the proximal portion, then you start activating the burr speed, and it should be short runs. In between the runs, there should be a good pass and pecking motion. Make sure the deceleration is not more than 5,000 final polishing run, and make sure ablations are not visual, auditory, tactile. Stimuli, all that you should respond, and we know how to remove the burr, and then it becomes, once the job is done, then it becomes routine PCI. Let me quickly take you through some of my real world cases. 69-year-old.
Shiva, please.
Right, sorry.
Thank you, Shiva. Shiva also can be in the chair for the compensation I will do. Dr. Imad Sheban can come to the stage, please. I think Ajay can continue in the same session. Can we go to the live case, Dr. Ashwin Mehta?
Yes, Pratap, I'm hearing you. Yeah, take it out. Hey, take out this.
Dr. Dal, you can come up and session chair along with Imad Sheban. Imad Sheban, Dr. Sunita Viswanathan, Dr. Nitish Naik, Dr. V.S. Prakash, Dr. Reed, Urmil Shah, Vinod Kumar, H.K. Agarwal. Sir, he's sleeping. Anil, please come. Call him and also, Sheban also. Sheban. Come. We can start the session and go to Dr. Ashwin Mehta. Sir, I am sorry, sir. We are actually delayed by 30 minutes. I am very, very sorry, sir.
Well, I can understand that.
Sir, please, please go ahead with the case. Please, sir. Dr. Imad Sheban and Dr. Nitish Naik, Dr. Anil Dal is chairing the session.
Okay, fine.
Sir, good afternoon.
Good afternoon. Is that
We've been
Anil?
waiting to see your case.
Anil?
Shiva also can sit. Shiva Kumar.
Shiva, yes, okay, fine. All right, so I'll...
Showed normal sinus rhythm with poor wave progression. Her 2D echo showed LVF of 60% with no regional wall motion abnormality. Her hemoglobin is 9.4 and creatinine clearance is 60 ml per minute. Her recent coronary angiogram showed a left main ostial plaque, heavy calcification in the proximal LAD with a 90% lesion, followed by a mid-LAD lesion of 70% severity, followed by distal segment diffuse disease. Her LCX showed approximately heavy calcification and 50% lesion with a 90% lesion in the L6OM bifurcation. The proximal RCA was calcified heavily and was followed by a total occlusion in the mid segment. And the distal RCA is shown to fill retrogradely via the left system. The syntax score was calculated at 25 points. The patient was offered CBG surgery, but...
Okay, Shiva?
Yes, sir.
Can you hear me, Shiva?
Yes, sir. I'm listening to you, sir. Please, sir. Please go ahead.
Okay. So now this patient, show the angio please quickly. Today's angio I'll show you. First of all, this is a 71-year-old lady, and you can clearly see in this particular view that there is a visible calcification. Sensitivity of calcium is only 40% on fluoroscopy. So when you see the calcium, that means there is a lot of calcium. There is a calcium in the circumflex, there is a calcium in LAD, and there is ID there. You can see here two catheters, because you can see the right coronary filling retrograde. And that collaterals are coming largely from the septal branches of the LAD. So therefore, also this patient has some disease of the left main also, because 7 French guide catheter, which is my preferred guide catheter, to match with the largest size of the burr, which I might want to use, but I could not because it was jamming. And it is sufficiently large enough to allow the flow to occur on the either side. So that was one problem. The other thing is that there is a very tight lesion on the mid-segment of the circumflex OM system. Circumflex OM system, can you see that clearly? Shiva, are you able to see my angio?
Yes, sir, we are able to see. We have a great panel here, Anil Dal and Iman Shiban and some more people, senior operators here. We are able to appreciate all the findings which you said, and particularly the LCX is very, very tortuous, calcified, and LAD is pretty long, and really a challenging case. We want to know what is your strategy. Then later on, one of the panelists.
I think I'll take your support. I'll take your decision support. Show the right coronary now. So I deliberately did the bilateral injection of the, these are some more views. And then you can see clearly the distal half of the right coronary is feeling from the collateral. And these collaterals are mostly they are coming from the septal branches of the LAD. The next slide, please.
We see two guides there. Any particular reason?
I will explain to you why there are two guides. Okay. Okay, so now there is you can see the LAD. The distal part of the LAD is very, very badly diseased, diffusely diseased, thinned out completely. And there is a fine blush on the inferior surface, which is supplied by the collaterals, and the distal right coronary is supplying that area of the artery. Go further, please. And you clearly see here that the distal half of the left main is much bigger than the proximal half of the left main, which needs to be interrogated a little later on. I can't do FFR because there is a lesion the downstream. So FFR cannot be done. We'll have to depend on the IVUS only. Next, please. Next to you, please. Next to you, please.
Dual injection.
Dual injection?
Yeah.
Where is the dual injection?
Wait. No, this is not. This is wiring. Dual injections.
Dual injection.
Come back.
Yeah.
No.
Yeah.
No, before this. Okay. Before this. Yeah.
Now see, Shiva, Anil.
Yes, sir.
The idea of doing
we are
two
seeing the
injections
RCN now very
simultaneously.
clearly that it's distally diffused. Is a stent or calcium in the proximal RC?
Calcium.
Calcium, okay.
This lady, this is the first procedure in her life. So
Right.
there is a calcium. So question is that this patient's syntax score comes to about 26. But you know, syntax score can't tell you anything. Calcified lesion, some marks. But how much calcium? Tortuosity, can you define tortuosity? Very tortuous, mildly tortuous, tortuosity at a critical point, tortuosity with angle of 60, 90, 70. So syntax score is a rough, but otherwise I think it's the operator-based decision that is to be made on the table. Now question is that should we be doing interventional procedure? The very fact that I think interventional procedure should be done because I've taken this on the table, but I want to know what should be the appropriate decision. 1, 2, 3, 4.
I think we can start with Anil Dal.
So here's a calcific triple vessel high syntax score situation with a CTO of the right coronary artery. I mean, most people would probably advocate a surgical treatment as the first choice because of pretty obvious reasons. We saw that you'd put a wire into the left system. So normally, whatever you all taught us was that if you have a total occlusion, you should try and address that first before you take on the contra system. So I was really wondering as to where you're taking us. Imad?
Actually, it's very challenging case for the calcification. Actually, right coronary artery, I don't think is total occlusion. It's subtotal. I think it's going to be easy to cross, but not the cross. It is the preparation of lesion of all these long lesions, and I think, of course, should be associated with adjunctive devices, I will go for rotaplator, of course. For all lesions will be treated, because you see that very severe calcification along all the principal three coronaries. So I think this case should be, revascularization should be staged. So whether to start from right or left, you should stage something. I would start with left side.
Dr. Clare has a point.
Yeah, I think next to me, camera here, please.
Ashwin.
Yeah.
Yeah, just Dr. Clare here. So
yes, Tiro.
There was a debate here, bypass surgery or angioplasty. I think we can discuss one way or the other, but I think if you see the LAD is a diffusely diseased vessel, so I really don't think that surgery will be of great benefit, at least in the LAD territory. So that point goes in favor of PCI. As far as I'm
yes.
Yeah, because actually there are not many landing zones for a surgeon to land a graft appropriately. So therefore, and also because this is an interventional meeting and you are doing the case, so it's pretty evident that we would be...
Okay. Ajit is my very dear friend, and he's a fantastic operator. Handa also. I am robot. This is a joystick 1. This is a joystick 2. I'm a robot. So let me ask Anil, Ajit, what would you say? Why would you not go for surgery?
See, although it's a triple vessel disease with calcified arteries in all the three vessels, I think as Dr. Clare has already said, this is a type 1 LAD almost, and the distal artery is diffusely diseased. So the benefit which you would get by surgery is very, very minimal here. And I would, and it's an amenable lesion for both the LAD as well as for the OM. As far as the RCA is concerned, yes, it's a calcified vessel. And as the previous panelist said, that it looks to be total, but to me also it looks to be subtotal and will be able to go through into the RCA.
So therefore, Clare as well as Anil Dal. You know, the commonest story is that we offered surgery to the patient, but patient refused. Half of the time it's bluff, because I have not explained to the patient then genuinely, but they wanted to do it. And the patient is refusing, chalo, let's go to the cath lab. That is not. But I think, let me say this way, that I specifically recommended as a first choice as an angioplasty. And I'll tell you my reasons. Number 1, this lady is 72. 2, she has already passed the anticipated expected lifespan. 3, the complications other than cardiac could be a termination of life, like whether stroke, malignancies, fractures, pneumonia, kidney failure, and whatnot, etc. So heart is not the only thing. 3, when you have a syntax score of 22 to 32, death and MI are not significantly different in both the arms. Especially I'm talking of left main. I agree with you. Calcification was an exclusion criteria of a left main bifurcation. But I'm not dealing with the left main. I'm dealing with the subset which is non-left main, and the syntax score is 22 to 32. Is still, I think, is a moderate complexity. And with that, worst come to worst, this patient will come with revascularization or a repeat revascularization. The strongest determinant of MACE is usually repeat revascularization, since death and MI is almost equal in all the kinds of cases. In that situation, I want to ask, do you prefer 2 sticks into your groin, or you want to get your chest opened up? What do you have to say about that, Anil?
So we quite agree that we should move on because we have kind of decided that this is going to be a PCI, and there are many reasons. We are not here. Obviously, there are not many surgeons in the audience, and we are not wanting to have a debate with them. But all the same, we understand that the surgical targets here are rather limited because of the nature of disease is rather diffuse. Calcium is an enemy not just for the angioplasters, also an enemy for the surgeons. And so we have to do what is best for this patient and lay out your plan, sir. What is the next step that you would like to take?
Okay, now that's wonderful. Now if I have to rotablate this artery, then ordinarily I do not do unless it's a very proximal LAD rotablation. But this is a donor artery to the right coronary also, and therefore first thing that I decided to use a pacemaker. I use a balloon tip pacemaker and just a mild touch so that the complication of related to the right ventricular perf is avoided. Number 2, now I decided reliably with a conviction that I will attempt the LAD for 2 reasons. Number 1, it used to be true that the most difficult region should be done first and then do the next one, because at that point of time when the patients were very frequently going for a failed angioplasty to surgery, therefore difficult lesion failed, better to allow the surgeon to have almost a virgin field. No, now the things have changed. We have a stent available, we have a bailout procedures available, etc. So it is not very important that I should do this. For all that I know, after open the LAD, the richness of the revascularizations of the right coronary will be so plenty that she will be symptom-free. And the right coronary total occlusion in presence of the 2 open arteries, namely the circumflex and the large OM, is not going to result into even in acute MI, it will not be fatal. That's my expression. So then, therefore, we decided that we will do the OM first. Why OM first? Because I'm going to maybe required to come back all up to the ostium of the LAD. And at that time, a slight mistake will make the entry into the circumflex very difficult. And I didn't want to do that. Moreover, LAD is a more important artery of the 2. But I wanted to get rid of circumflex at that point of time. So my approach was to do a show the RAO caudal, please. RAO caudal. Anil and Shiva and Claire, all 3 of you. This the circumflex is not also simple, because you can see it is taking a bend on itself, tortuosity, and then thereafter there is a lesion there, and there is a large circumflex. And believe me, Anil, my surgeon usually tries to do an off-cap bypass surgery, and therefore he will lift the heart. And if he lifts the heart, it lifts too much. So all that he does is that he puts one graft as much distally as he can, or as much proximally, which will be usually very, very distal. Putting a distal graft there is no point. So that is one more point why I didn't want the surgery to happen.
We concede that completely, sir.
Ashwin, can you show the LAO caudal view?
Yeah. Yes, show the LAO caudal view.
Next one. Next, after this. After this. After the we have taken first LAO caudal. Show the previous one.
No, just
previous, before go. Yeah. No, yeah, before this, after this.
Yeah. Okay, one more.
Next one.
We have not taken it. LAO caudal we have not taken it.
All right.
Caudal was showing.
LAO caudal was okay. Claire?
Yeah, I couldn't see that properly.
Okay, I'll have to show you now then in that case. Come on, please. Go to LAO caudal quickly.
What is the LV function? And did
normal.
You check
50%, 50.
Did you check the LVDP beforehand?
No, I did not. But on echo-wise, we find that LV contractility is very, very good. And, okay, 1 minute.
Okay.
This is what it is. So, Claire?
Yeah, I can see that.
You are very smart. You're very smart. If you see the curvature and tortuosity in 2 views, that it is genuinely tortuous. If you do not see that, then I think it is an illusion. I don't think it is that tortuous, right?
Very right. I think I am encouraged by seeing the LAO caudal.
The LAO caudal is very encouraging.
Yeah. Right.
Okay, fine. So then quickly, let's go quickly.
Show the circumflex.
So I expressed my strategy that I'm going to offer the angioplasty, not by exclusion that patient doesn't want this or that. It is my choice. This is the first choice. And therefore I convinced the patient that angioplasty is better for you. 2, that I decided to do the right coronary later on, because this is, although I agree with you that this is a donor artery, but this is not, I mean, those days when we have a lot of bailout procedures, etc., we discussed this. I don't want to discuss again. So then I went into the the OM branch, and the wire of my choice was Fielder FC. Whenever there is a tortuosity, polymer wire. Polymer wires are very, very user-friendly. And then we passed a wire, and then this wire gently went down. And then, mind you, Claire, you and I will both agree that when there is a proximal heavy calcification and tortuosity, delivery of the hardware is sometimes difficult. And you saw that when I tried to pass a balloon, the guide catheter backed out. So rewired again. Next one. Go ahead. And the balloon. Now, gently, the guide is backed out, brought it back again, and then next, a gentle forward pressure, continuous gentle forward pressure, asking the patient to take a little bit of deep breath, and then the next one. And we moved it. We moved it down, and balloon dilated. Now, mind you, Claire.
Yeah.
Usually the calcification is usually into proximal 1/3 or proximal 2/3 of the arteries, usually. So I totally agree with Japanese speaker who I heard, and I was vibing and gelling with that lady that yes, she's right. That if you do not radiologically see the calcium, most of the time you will not have to erythroblate them. You will not have to erythroblate them, and they would be responding to non-erythroblative methods like cutting balloon, lithotripsy, or high pressure balloon, or OPN, whatever it may be, but perhaps no. Lot of people, I heard now this lot of talks, but despite the fact that I agree that the rotablation has a steep learning curve, no doubt about it, but is reasonably easily accomplished. It's not a rocket science. I think if you want, and one speaker rightly said that in these days of time, if you don't know how to do rotablation, shame on you.
Ashwin, did you do Hybiz or OCT on this OM?
Or not this patient. No, I did not do that. But see further what I did.
Next one. Go ahead.
Keep going.
Next.
Dilated with the balloon. Next one.
Next. Next.
The stent.
No, balloon. Next. We're seeing whether the balloon is going through easily.
Now the stent. Now you see the bias of the wire?
Yeah.
That is creating problem for the stent. So I did another trick. I just changed the wire bias by changing the guide catheter position and then patiently waiting for a little while. Next one,
go
please.
ahead. Next one. Yeah. Slowly, pressure has started moving.
Slowly, the guide catheter is doing some natak, but I'm persistent. And over the soft portion of the wire, the stent crossed almost. I repositioned the wire. The next one, please.
Yeah, next. Yeah, this is the...
Yeah. And we inflated the balloon here.
The stent.
And when you don't want to do Hybiz, or when you have no facility to do Hybiz, you have to develop Hybiz eye. Usually, the lesion artery is bigger than what you see. Now, in RAO caudal view, since this artery is posterior and is away from your screen, it will show a mild exaggerated enlargement of the image, because farther you are away from the II tube, larger it will appear than in its real size. We deployed this stent. Next one.
So what you're forgetting is that we had your magic hands doing it. For ordinary mortals, I think that most of us would have imaged first, and following the imaging, we would probably have used an erythroablative strategy to ensure that this kind of masterly skill which you have demonstrated in delivering that stent to the distal OM need not have been used, and even ordinary mortals could have done it. So if we have your permission for a moment, we have another lab. Is it okay for us if we can visit the other lab?
Just the last scene.
All right.
Just one question before you go off, Ashwin. Because that bend proximal to that proximal edge of the stent is rather dangerous, I may have used a bigger stent so that I cover that bend. Because if I have to go into that stented area again, it may be difficult.
That kind of works both ways, sir, because you may not have been able to deliver it either.
Absolutely right.
I think if you use guideliner, it should have been much easier.
Yeah.
The last one now. Next, please. I post dilated it with 3 millimeter balloon.
Next.
And the next one, please.
Next. And this is the...
And I do feel that this is, I think, more than 5.5. My visual impression looking at the guide catheter. And
You're going to put the Hybiz companies out of business, sir.
Hybiz is coming. During ROTA it will come. One Hybiz can work for 2 arteries, so they have earned their money. Okay.
Okay.
You want to go to
We
Teja?
have your permission, sir, to go to the other lab. We'll come back to you.
Absolutely. Meanwhile, I'll do some rotation, collect the slides, and then come back to you.
Right, sir. Right, sir. Right, sir.
Okay.
Ujjwal?
History.
Yeah. Tejas.
Hello.
Hi. Good afternoon. Good to see you. This is, we are a full house here. There are people standing to see what you're up to. With me is Dr. Imad Shiban. There's Nitish Nayak. There's Urmil Shah. There are a whole host of people and a very activated audience. So we are waiting to see your magic.
I mean, this case, I'm going to talk more on the technology aspect and rather than the, sort of a technique of angioplasty, because it was on calcium management, and calcium management is all about more of a technology, and then it is mixed with some technique. So this was a lady, 74-year-old lady with long-standing diabetes, hypertension, hyperlipidemia, presented to us with NSI ACS, raised stroke, and very severe angina, and angina even on minimal exertion, and angiogram showed very heavily calcific, around 75-80% stenosis in some views, and in some views it looked less. But then we will discuss the character of the lesion also, and we decided to fix it, and we decided now all these calcified cases, OCT is a standard technology with us, and then we choose, we balloon properly with non-compliant balloon, and then we choose, if need be, ROTA and then IVL. And then again, a couple of runs of OCT, and these are the cases we always do with angio co-registration. So just go through all the films, views. Yeah, go ahead. So calcium is extremely visible, and if you see, there is some haziness on those rough areas, and the margins are irregular. We are in the habit. With me is my colleague, Dr. Sanjay Shah, who is with me since now almost 25 years. We are in the habit of interpreting the OCT finding on the basis of angiography, and we have significantly now come to know what is going to be there in OCT. Like if this is the lesion, I would think that, and when history is suggestive, like raised drop, with very severe angina, NST, ACS in a diabetic female.
So you're trying to predict nodular calcium. You're trying to predict the calcium nodule.
Right. Calcific nodule, and then haziness means, mixed plaque by and large with lot of calcium. And we have come across so many TCFAs with big calcium bulks. TCFA is not only the finding when you see only fat all around or fat with fibrosis. With calcium also, we have come across, particularly Indian arteries are pretty inflamed arteries, and we have a very, very sizable OCT imaging experience. Like in last 3 years, we have done more than 1,500 OCTs. So we know exactly that this is what is going to be there. And calcific nodule, whenever it is there, I personally feel that it is a malignant condition, because you have to accept at times not so good cosmetic result. Sometimes you feel that the stent remains little underexpanded, malepposed, all those things. So I need to know from the esteemed panel that what do you think? And then I will show you the OCT run which we have just taken because the patient was lying and patient was becoming...
Imad is a very good astrologer. He's going to predict. he's going to predict.
No, it is not astrology, let me tell you. I mean, we are discussing very serious, it is a serious discussion.
Yeah, it's a serious discussion.
Yeah, and I like to be evidence-based, and you will see
if you go back to your heliocaudal, if you go
Yeah.
and show us your heliocaudal view,
Wait a minute. No, we have taken areocaudal and epicaudal.
you had shown us one areocaudal. Okay.
Yeah.
Here, and before this, you had shown another view.
Yeah, just show.
Before this, there was another view.
Just show.
Previous view.
Previous view. Previous view.
So we kind of got a sense that there is a nodular calcium even when we were discussing here as to what we're going to find. And we got a sense that that's what you're going to find. But there is a long calcific disease. And Imad?
Actually, it is extended from distal left main to proximal LAD.
Can you show previous view?
And I would expect, of course, severe calcification. But I see that there is some distance between the contrast and the calcification in the proximal part of LAD. And that means calcium is more superficial. So that's what we'll expect. But I think the use of intravascular imaging in this case is fundamental in order to understand better and to select the right the right strategy to go on.
Imad, actually you see, you trace the calcium from proximal to the mid part where there is some significantly severe lesion. You know, that area still is quite thick. It could be calcium, it could be fibrosis with calcium, but there is definite haziness with irregular margins in that region on the surface of the lesion, which makes me think that there could be, you know, sometimes we see some plaque rupture in that region, TCFA, and some small thrombus and something. Because when we see calcium and haziness, we are blinded that haziness is because of calcium, but many times it may not be correct. There could be, you know, some thrombus or some plaque rupture or some plaque erosion or something, or those type of interesting findings. And when I correlate with the history of the patient, you know, I felt that way. But now, the things we will show on OCT, and we want, you know, the opinion from the panel. Just show the OCT and then angio co-registration also. Yeah, this is now coming from distal to proximal. It's a pretty healthy artery there, and then disease starts, but still calcium, as you can see, but not completely. Now this is a completely 360-degree circular calcium. Here you can see even TCFA with calcium and some areas of fat also. There is a definite sense of nodule. You know, I can feel that there is a nodule, and then we are in the proximal area. It's a very huge artery. Come to the diseased area, and you can freeze. Go in, go in, go in, go in, go in, go. Now, wait. Here you can see that there is significant amount of fat, you know, just at the part of the disease, and there is some TCFA, even there is some area of macrophage. And go even proximal. No. Go further, distal, sorry. Go, and you can see a lot of fat there. I don't see any, you know, disruption in the intima, of course, although I predicted that. And there again, it's a mixed plaque with again some calcium, some fibrosis, some fat. And then again you go further. Yeah, still. Come back now. Come to 360-degree area of calcium. Yeah, it's 360-degree. Number one, the thickness is also very severe. There is a wire bias there. And the length of the calcium is also significant. So if you see that the OCT calcium score is almost 4, right? The length, the thickness, and the arc. So everything together, it is now touching the 4. So what will you like to do? The area stenosis is 60, 65, 70 at some place, but not more than that. So, will you like to leave it alone? Will you do some physiology to decide whether to do or not after stabilizing the patient or what? Because the patient is NST, ACS with significantly raised stroke, I think the physiology really doesn't matter. But supposing this is a stable patient who is coming with class 2 angina and this is the picture, I need to know from the senior interventionalist on the panel what is going to be their opinion.
I think physiology in this case is not required because patient is coming for angina, severe angina, and he has this single lesion on LAD. So I think whether physiology will be negative or positive, this patient should be treated. So I think I'll not go for physiology, I'll go for intravascular imaging, as you did.
You've already done that.
See, I think history can be very, very baffling. Let me tell you, first of all, okay, I believe there is severe angina, but we also know that people have angina, severe angina with normal coronary arteries. So I would like to have physiological evidence that we are dealing with a critical disease.
The plaque burden is high. There is a nodular calcium. Nodular calcium can itself be responsible for ACS.
I understand.
The patient is troponin positive. I think we would, at least in my opinion, humble opinion.
If possible, I would like to have physiological assessment also.
But physiology can be
But
misleading in this
supposing, Dr.
circumstance.
Clare, physiology, like FFR is 0.85, then what will you do? Will you leave this patient alone on medical management?
Well,
With significant amount of PET and TCFA and all these and angina.
See, there is a paper by many years back by very senior cardiologists that 85% of the real so-called refractories unstable angina can be treated medically effectively. So I think there's a lot to think about it.
No, but what will you do?
I may like to put him on medical therapy, dual antiplatelet medication, then see how the patient responds. Because if you see the degree of stenosis, at least I'm not totally convinced that we have a critical disease.
We get your point. I think that we may have a divided house. Some people may like to do an intervention. Some people may prefer medical management. But if you'll tell us in about 15 seconds what you planned, and then we've got to go back and see what Dr. Mehta is doing.
Let me tell you, I don't want to leave her on medical management.
Excellent.
Because, that is one. Number two, now I decide my plan. Looking at the calcium, the circumference of the calcium, the length and the thickness, now I am sure that only non-compliant balloon, can be disastrous because it means that you are not cracking the things properly. There is a beautiful Japanese study by Akasaka et al. And Akasaka is my guru for OCT.
Akasaka is here, so we can ask him.
So, And that's why I will like to crack this calcium. I will like to pulverize it. And
So
for me, I will do, lithotripsy and then dilatation. And then I will make sure that I give a beautiful MSA to this patient.
Perfect.
Because
So
it has an implication on binary stenosis as well as
Conceded.
TLR. both.
So therefore, you are planning to deliver an IVL balloon catheter by itself without any preparatory atheroablative strategy.
Yeah, in this case, because we have a very, very large experience, normally I like to dilate aggressively, but in this case, I am quite confident, 90%
of being able to
confident.
deliver. Excellent. So we'll take your permission, sir. We'll just go back to Dr. Mehta and see what he's been able to manage.
Prior to that,